So if we can have some silence before we get online so I can read this opening statement. Thank you. I declare open this hearing of the Community Affairs Legislation Committee in the 2025 and 26 supplementary budget estimates. I begin by acknowledging the traditional custodians of the land in which we meet today and pay my respects to their elders past and present. I extend that respect to all Aboriginal and Torres Strait Islander people here today or watching. The committee has fixed Thursday the 29th of January 2026 as the date for the return of answers to questions taken on notice. The committee would appreciate if senators could provide in any written questions on notice to the Secretariat by Thursday the 11th of December 2025. The committee's proceedings today will begin with the Department of Health, Disability and Ageing, Outcome 2, Individual Health Benefits. The committee will be conducting today's hearing in person and also via video conference. Under the Standing Order 26, the committee must take all evidence in public session. This includes answers to questions on notice. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. The Senate has endorsed the following test of relevance questions at estimates hearings. Any questions going to the operations or financial positions of the departments and agencies which are seeking funds in estimates are relevant questions for the purpose of estimates hearings. I remind officers that the Senate has resolved that there are no areas in connection with the expenditure of public funds where any person has a discretion to withhold details or explanations from the Parliament or its committees, unless the Parliament has expressly provided otherwise. The Senate has resolved also that an officer of a department of the Commonwealth shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. Witnesses are reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. I incorporate the public interest immunity statement into the Hansard. I also remind all senators of their obligations under the Behaviour Code for Australian parliamentarians to treat our witnesses with dignity, courtesy, fairness and respect. An officer called to answer a question for the first time should state their full name and the capacity in which they appear. I remind committee members and witnesses who are appearing via a video conference who are not speaking to please mute their microphones. Live captions will be enabled for the entire duration of today's hearing. The feed will be displayed on selected video conferencing monitors at the witness bench, at the back of the room and in the waiting room. We ask witnesses to please inform the Secretariat if at any time during the hearing you are experiencing any issues, and they will endeavour to troubleshoot them as quickly as possible. I now welcome Senator the Honourable Jenny McAllister, the Minister for the National Disability Insurance Scheme, representing the Minister for Health, Disability and Ageing. Minister, do you wish to make an opening statement this morning?
Thank you, Chair. I do, but it actually relates to the outcome around the NDIS and disability, and I wonder if it might be more sensible to do it at that point in the program.
Yes, I can facilitate that for you. Thank you. I also welcome the Secretary of the Department of Health and Disability and Ageing, Mr Blair Comley, PSM. Mr Comley, do you wish to make an opening statement?
No, thank you, Chair.
Great. I also welcome I call officers from the Department of Health, Disability and Ageing in relation to Outcome 2, Individual Health Benefits. I also would like to welcome the Chief Executive Officer of Professional Services Review, Associate Professor Antonio Didio, as well. And I will now invite questions from committee. I think Senator Ruston, you're up first.
Thank you very much. Sort of feels like a bit of Groundhog Day. Do we have the answers to the questions that were asked in the letter in relation to the breakdown on bulk billing?
Good morning, Senator. Penny Shakespeare, Deputy Secretary, Health Resourcing. So for your first question, which was about the funding for the GP bulk billing incentives and then separately the program, the overarching measure, which includes funding for all agencies, is at for all agencies.
Yep.
Is at budget paper 2, page 53. Now, that is not broken down into the particular elements, but we can break them down for the health department expenditure across the forward estimates.
So you can't break them down by program?
We can, but I'm just explaining it's not the other agencies. We've got the health breakdown for you.
For this measure?
For the bulk
two
billing
measures.
incentives and the bulk billing incentive program across the forward estimates. I'll ask my colleague.
Is it possible to table that?
Well, Senator Daniel McKay, First Assistant Secretary, Medicare Benefits and Digital Health, I can read them out very quickly.
Sure.
If you like.
It's just sometimes useful to be able to see. I'm a visual sort of
No,
person.
that's fine. Look, there are two substantive elements to this measure. The first one was the bulk billing practice incentive program, which was $2.3 billion over the forward estimates.
2.3 over 4?
Yep, and in the first year, which is the first 6 months of the first 8 months, this financial year, is 251.
8 months.
So it started in November.
Is it? Okay, 8 months. Yep. Sorry.
Started in November is $251.3 million.
251.3. Yep.
Next financial year is $517.1 million.
Yep.
In 27-28, it is $755.7 million.
Yep.
And in 28-29, it is $816.6 million.
Yep. Okay.
Then the second part, Senator, is the bulk billing incentive payments on the MBS. This financial year, for the 8 months, it's $848.5 million. Next financial year is 1.3938.8, sorry. The following year in 27-28 is $1,496,000,000.3. And in 28-29 it is $1,549,000,000.
So do you have a total amount for each of those measures that includes other agencies?
So the other agency that's involved in this, Senator, is Services Australia.
Yes.
And I don't have that off the top of my head. We'd have to get that number for you.
I don't need it broken down year by year like you've done that. That was very helpful, by the way.
But broadly speaking, Senator, they had two components. They had some system changes to support the bulk billing practice incentive.
Yep.
And then they have a fee that they charge per transaction for the increased use of bulk billing incentives. And it's in the order of between 250 and 300 million, but I'd need to check that to be on notice to be exact.
Over the 4 years.
My colleague down there has it.
Jo Washer, Assistant Secretary, My Medicare and Bulk Billing Clinics. Services Australia were appropriated in the budget $211.7 million.
211.7, that's for over the forwards?
Over the forwards.
Yep, okie dokie.
And I can break that down per bulk billing incentives and bulk billing clinics if that's helpful.
Yeah, that's helpful.
In total or by year?
No, just in total is fine.
In total, it's $186.7 million for bulk billing incentive changes, and for the bulk billing clinic program, it's 24.9 or 25.
Yeah. Okay, great. Thank you very much. And the other piece of data in relation to the number of clinics that were bulk billing.
Mark Rodham, First Assistant Secretary, Primary Care Division. So the number of clinics that had signed up to the bulk billing practice incentive program as at the 30th of November was 2,902 practices.
Yep. And how many of those were fully bulk billed clinics prior to the...
58, so 1,675 or 58% were previously fully bulk billing or were already fully bulk billing.
1,675 were
right.
Previously.
Yes, and the remaining 1,092 were previously mixed billing.
Mixed.
And we had 135 who were new to My Medicare and didn't have established billing information.
Okay. So of those clinics, do we have a breakdown of where they were?
Where they what? Pardon, Senator? Sorry.
Yep.
By state, do you mean?
Yep.
By state, yes. So New South Wales has 1,160 of those.
So in New South Wales, 1,000?
1,160. Victoria, 803.
Yep.
Queensland, 505. Western Australia, 176.
Yep.
South Australia, 148. Tasmania, 51. The ACT, 15. The Northern Territory, 44.
Okay, and that's the total. So when you say they've signed up, so these clinics now are not charging anything?
They've registered to be part of the program. There's obviously
Okay.
the validation process that
Okay.
Services
So
Australia
how many
go
of them are
through.
actually delivering services as we sit here today?
Well, they're all operating clinics,
Yes,
Senator.
under the new arrangement. So we're talking about this is obviously the practice incentive payment that we're talking about here. So how many of them currently are in a position, or actually are receiving or have been authorised for eligibility for the practice incentive payment in relation to bulk billing?
So the way the program works, Senator, is practices register as part of this program with Services Australia. Then Services Australia in January for the first part of the first quarter will go through and validate that information, and if they are fully bulk billing, then they'll receive the practice incentive payment most likely in the second half of January. So there's a validation process.
Okay, so the 900 and the 2,902 that you're talking about actually aren't necessarily all bulk billing. They've just registered to
They've registered to be
for
part of the program.
For the program. So there's nobody at this stage who's actually been validated to receive the payment, or have there been?
Senator, we do have the first month worth of data
Yep.
on the overall
Yep.
numbers of bulk billing incentives. Now, as my colleagues have said, before any program payments are made, we need to make sure that the practices have been complying with the requirements of the program, so bulk billing all patients for non-referred attendances, and that's a process we'll be going through over the next couple of months. But in terms of the first month's worth of data, which is still new and undeveloped, and we will need to continue checking it, we have seen a significant increase in the number of bulk billed services.
And that's entirely reasonable, but the minister seems to be running around using this data quite frequently. So clearly it must be in a state that's good enough for him. So I'm just trying to understand the difference between the numbers you've given me and, so these have registered to become part of the program. Doesn't necessarily mean either they will continue to be part of the program or they'll be eligible for part of the program. So is it possible in terms of a state-by-state basis to break down of the numbers you've just given me, all of the clinics, state by state? Can we have the clinics state by state in terms of who were already fully bulk billed clinics prior to the 1st of November?
Yes, I can give you those figures.
Thank
Senator.
you.
So these are formerly fully bulk billing.
Yep.
In New South Wales, 776. In Victoria, 449. In Queensland, 271. In Western Australia, 80. In South Australia, 51. In Tasmania, 18. In the ACT, 8. In the Northern Territory, 22.
22, okay. So in terms of the first month's data that you're talking about, Ms Shakespeare, that isn't fully clean or however you would describe it, can you give us that data as you have it at the moment, understanding it still probably requires validation, in terms of how many clinics actually have gone through the process and would, in your minds, be eligible for?
So, Senator, it's probably important, as Ms Shakespeare and Mr Bottom have explained, that to be eligible for the practice incentive payment, you have to have bulk billed in the previous 3 months 100% of your GP consultation services, and so that will be paid in arrears. But saying that, we had a significant increase in bulk billing incentives that were claimed in the month of November, and that number was 10.8 million bulk billing incentives, compared to 7 million in the previous month of October.
Yep.
So we are seeing a very positive increase in terms of uptake of bulk billing, and that also included a new bulk billing number of 81.2% for the month of November, compared with 77.7% in October.
Okay, thank you. That's great.
I think the point, the conclusion you could draw from the data that's been provided to you is that there are a range of practices that say they wish to be fully bulk billing, have registered for a program that incentivises bulk billing, and the bulk billing statistics for that first month reflect a significant increase in the number of practices offering bulk billed consultations.
Thank you for that, Minister. Is it still possible, and I don't expect you to read this out, it's still possible to get the breakdown of those clinics by electorate?
We need to take that on notice.
Yeah, sure, quite understand, but if you are able to do that. So as we're sitting here today, despite this preliminary data, no one would be eligible for the bulk billing practice incentive payment because that won't be available until 3 months into the program. Is that what you're saying?
No, not quite. So what I was explaining is that the incentive payment is paid in arrears on the basis that practices bulk bill in the first in the 3 month period 100% of their consultation services. What we're seeing is a large number of practices have registered with the intent of doing that, but we do have a validation process to ensure they actually do it.
Yeah, quite understand. So no one's received the bulk billing practice incentive payment yet because they wouldn't be eligible.
The bulk billing incentive payments that are attached to each bulk billed service are
The
certainly
practice
flowing
payment,
through.
I said, Ms Shakespeare, I was talking about practice payment, I said practice.
But sorry, Senator, I think it is quite important because in the consultation with practices led up to this measure, they were very clear that they were considering what their business model is, whether they would fully bulk bill, because once you register for this and then you decide not to bulk bill even a small number of services, you lose the full 12.5% payment. So what the other officers are saying is, clearly to make sure that we have the appropriate expenditure of government money, we need to check in arrears that they actually did that. But there's a very strong expectation if you've registered, you've done so because you've decided as a practice this is your business model, and that you've collectively done that as a group of GPs to make the trade-off between some out-of-pocket expenses versus receiving the bulk billing incentive. So we won't know for certain until that reconciliation occurs, but you would think that practices trying to achieve the bulk billing incentive need to have decided up front at the start of the quarter that this is the practice they intend to make.
Thank you for that. So the government's got a target of reaching 90% bulk billing by 2030. I think I've asked you this before and haven't got an answer, but I'm going to try again. I'm just interested to understand what your projections are year on year to get to that 90% by 2030.
I think as we discussed at the last estimates hearings, we have some key performance targets which are set out in the impact analysis that we undertook for the policy, which has been published. Those are the targets we're working towards. So we will be monitoring, of course, the impact on the bulk billing rate and how close we are to achieving that 90% target by 2030. So far in the first month of the program, I know it's very preliminary data, but we have seen a 4 percentage point increase in the bulk billing rate from November this year compared to November last year.
Yeah, so thank you for that. I think you probably answered the same way last time. When this measure came into play, bulk billing rate was about 77.9%, depending on which figure you want to extrapolate, and you've said that by 2030 you want it to be 90%. Surely you have got a trajectory that says each year you are hoping to increase the bulk billing rate by a certain amount to get from 77.9 to 90%. Do you have that data?
So the data on where the bulk billing rate will be monitored and released
No.
quarter by quarter.
Have you got projections? You're saying you're here now. Well, no, you're not saying, you are here now. In 2030, you want to be here. What is your expectation of the bulk billing rate at the end of 25, 26, at the end of 26, 27, and at the end of 28, 29, and the end of 29, 30? What is your expectation? Or are you just going to go, we're 77.9 now, and in 2030 it'll be 90?
It's, in fact, over 81% now.
That is 1 month. We're talking year on year, so let's not conflate our data. So what is your expectation once this new measure is in place of the bulk billing rate on the 30th of June 2026? What is the target?
The government has not published a target for the 30th of June 2026. We have targets published in the impact analysis, and there is the commitment to 90% by 2030.
Yeah. But clearly, in terms of being able to determine the funding that's been allocated to this program and the objectives that have been publicly announced, you must have some targets. I mean, why haven't you published these? What was the reasoning behind not publishing what the milestone targets
Senator,
were?
last estimates we gave evidence that we forecast 3,600 practices would be enrolled in the bulk billing practice incentive program within within the first 2 years.
Okay, so in 2 years' time, what does that equate to in terms of what you think the bulk billing rate is going to be?
We have not modelled what that does to the bulk billing rate, Senator.
So, I mean, I'm just understanding, you've gone out with these big headlines, Minister, big headlines about this is what's going to happen, and of course we all want to see that happen because nobody doesn't want to see Australians getting easy and affordable access to primary care. That is clearly what the objective was. But somehow we're on this trust journey with the government that we're here now, you're going to throw this money at these incentives and these measures, and somewhere when we turn up in 2030, up's going to pop this, magical answer with us all for 5 years trusting that it's all going to be fine, and you've given us no measure, and there is no quantitative measure at all that has been provided by the government. All this information is either not available or clearly being withheld as to what the government thinks is going to be the measures that will eventually get us to the point where we want to be, and that's where bulk billing rates basically back up to where they were when we were last in government. So I'm just keen to understand what's the rationale behind not actually providing these interim targets. Was there some basis why you've kept...
Well, I think the intriguing thing about this line of attack, and it is a line of attack, it's a very long preamble, it's an attack on a policy that you took as an opposition to the last election. We announced this policy and within hours you stood up and said you endorsed it, and then you said that we should recall Parliament to pass it, and then you said a whole lot of things about what a terrific Health Minister Peter Dutton had been. I think the point the government would make is that we do have a target for 2030.
That's past the next election,
We
Minister.
need to do an enormous amount of work to remedy the damage that was done to bulk billing under the government you were part of, Senator Ruston, and we're providing the resources to do so. This is a significant change to the way that the MBS works. We are determined to make sure that Australians can continue to access high quality public health care. This is part of that.
Okay. Well, maybe I could come from a different perspective, but just, I think, to be clear, Minister, I think in my preamble I made it very clear that the Coalition absolutely supports Australians getting timely and affordable access to primary care. Nothing could be more important. So I don't think that I'm attacking the measure. I probably am attacking the lack of information about how you've derived budgets that you've derived, this is the purpose of estimates, is to understand the expenditure of government money. And, you know, there was a lot of money was allocated to these measures, and I'm just trying to understand how you derive the numbers that you gave me in answer to my first question, which were quite detailed, when you don't seem to have any explanation around how those measures are going to be measured in each of the years. So, I mean, how can we know you're on target or on track to meet your target if we don't have any measures to understand that?
Sorry, Senator, I think Ms Shakespeare, and maybe it's a confusion of terminology. As Ms Shakespeare said, the analysis was included in the impact analysis, which had annual estimates effectively of where the bulk billing rate would be. As Mr McCabe said, one of those estimates was that there'll be 3,600 practices within 2 years bulk billing, which is a quantitative measure. As it happens, we have data in the first year of at least on registrations that the number is 2,902, and Ms McCabe or Mr McCabe or Ms Shakespeare will remind me exactly how many practices there are, but my recollection is there's about 7,000 practices in Australia. But the distinction between having estimates that are in analysis or things that feed into estimates versus targets is a different thing. The government has set a target by 2030 of reaching the 90% bulk billing. It's not uncommon for governments to set targets over longer periods of time without necessarily having precise interim targets as opposed to estimates. And that's partly because governments, as long as I can recall, will often take account of the information that rolls out over the early stages of a program and decide whether there need to be any modifications to that program. So I think there's a fair bit of information here, including the estimates we've just provided in terms of the ramp up of the scheme over the 4 years and the number of practices that have been registered over the first month. In the next 2 to 3 months, we will have the first indication of whether those that registered for those practices actually bulk billed 100% and receive the incentive, which would be further information we'd feed into our estimates. So I think there's quite a lot of detail available at both the estimate and the longer term target that informs people about where this measure is going.
Okay, so is the program based on the number of practices you think will sign up or the overall bulk billing rate?
So the overall target that the government has set is the bulk billing rate. The number of practices that have registered or intended to pick up gives you also an indication of how much of that bulk billing is occurring, but the ultimate target set by government was the bulk billing rate.
Okay,
So the interim quantitative targets were set out in the impact analysis were about the number of participating practices.
Yes, and that's what I mean. I'm interested that in your impact analysis you talk about the number of practices that are going to be participating in your practice incentive payment, but the Secretary's just said that it's actually the number of bulk billed services is sort of like the measure of success. So I'm just sort of, what I'm trying to understand from a budgetary perspective is that, for instance, in 28 to 29, it's just under $2.4 billion is expected to be expended on the two measures that we're talking about that make up this bulk measure. How did you get to those numbers? Because the incentive was $816 million and the bulk billing payments were 1.5, and I mean obviously some of that 1.5 billion on payments were going to the ones that have got the incentive because they get both, I'm imagining. Well, they have to be getting both because they're bulk billing. So how did you come up with those numbers? Because they're pretty precise numbers.
So, Senator, and I'm just looking at the policy impact assessment at the moment, we focused in how this was explained on practices that enrolled in the bulk billing program in terms of how this would roll out over the forward estimates.
Yeah, I get that. But the Secretary just said that this is based on the bulk billing service rate, which is the number that everybody talks about and I think everybody understands. And then there's an additional payment for those clinics that decide that they're actually only going to solely bulk bill. but we don't actually have any targets in relation to how you think the actual bulk billing rate's going up as we currently understand it.
So the target is 90% of
Yes, I
services
know
by
that.
2030.
Yeah, Ms Shakespeare, I think you know I know that. I'm just trying to understand what the 4-year targets, because 2030 is past the next election. So how do we measure the success of this program? If it's based on bulk billing rates, we need to understand what the bulk billing rate's going to be next year and the year after, whether this is meeting your targets. I mean, this is a lot of money. It's a lot of money. And I don't think it's unreasonable that I ask you how you've come up with these numbers, because sure, the practice incentive payment is one part of it, but there is an awful lot of money just going to the bulk billing services. What is your expectation of what this money is going to achieve, apart from clinics signing up?
And 90% bulk billing by 2030.
That's past the next election. It's 5 years away, and you're giving me no interim measure to see whether this is on track. What program in government gets put into place and you don't measure its success against the very metric that you say it's built on for 5 years?
So, Senator, I'm genuine. So we'll be measuring the bulk billing rate, or the government will be measuring the bulk billing rate on a monthly basis, and the monthly statistics will be made available as to what the bulk billing rate is. So that is a very real-time transparency compared with almost any other measure. The government hasn't set interim targets that it's holding itself against, but it is doing estimates across those periods which feed into this. Those estimates are based on current expectations of the take-up, but there's a difference between expectations of current take-up and a target.
And it's also worth remembering, Senator Ruston, that this is one part of our broader efforts to lift bulk billing. And so we have raised Medicare payments at each budget, we tripled the bulk billing incentive. It's obviously very different to the freeze that you had in place, but we are taking a series of steps, of which this is a core part, to raise bulk billing rates. And we've set a target for 2030. We'll continue to transparently publish information about how bulk billing rates are going. It's a really important initiative, one that, I repeat, you backed in the lead up to the last election.
Thank you very much, Minister. I'm just asking for those estimates. This is what the budget estimates is all about, is about asking you how you determine the numbers. Quite clearly that's not something you're prepared to give me. So can I maybe move on? So at a press conference on the 2nd of November, the Minister made the comment that 3/4 of general practices around Australia are financially better off if they take up this investment. So is it possible for you to table the modelling or the assumptions that underpin this statement?
So, Senator, we can have a look at the assumptions. I can't table the modelling because it actually identifies every practice and their current billing arrangement. So that would be commercially sensitive and also potentially in breach of the secrecy provisions of the Health Insurance Act. But we can have a look at the assumptions and see if we can get them shared.
Well, information that's obviously appropriate for you to be able to table would be great. So in some attempt to try and understand this, so the bulk billing rate of 90% is obviously is it contingent on a certain number of practices signing up to the bulk billing practice incentive?
Yes, it is, Senator.
Okay, and what is that number? Is it the 3/4 that the Minister Butler?
Just be, Mr McCabe might just want to reflect. There are different scenarios in which you can reach 90%. So there'll be a combination, multiple combinations of ways you can get to 90% of different numbers of fully bulk billing practices.
Well, we don't know that because you're only giving us half the information, Secretary.
Senator, if I just to give you an illustration.
Can we wait for the officials to finish their answer, please, Senator Ruston, and offer them the courtesy to complete their answer?
So by way of illustration, I could have 0 practices 100% bulk billing, but every practice 90% bulk billing, and I'd reach that target. Or I could have half of the practices, if they're all of equal size, half of the practice 100% bulk billing and the other half bulk billing at 80%. So whilst we have created 100% bulk billing at 80% of those, so while we have done estimates which is a combination of a particular level of 100% bulk bill clinics and the others that are bulk billing another percentage, there are multiple ways in which you can get to the 90% bulk billing rate. Sorry, Mr McCabe.
Can I just follow through with that? So on the basis of the logic you've just provided us, Mr Comley, you would have a situation if you had no clinics bulk billing entirely, but you had 100% of clinics on average bulk billing 90%, then your figures are all completely wrong. So what I'm asking you is, you have provided me this morning with a set of figures that show over the forward estimates the profiling of the two programs that make up this combined measure. Now, quite clearly I would reflect on the fact, or you might reflect on the fact, in no circumstance is there no clinics 100% bulk billing, and in no circumstances is there all the clinics that are entitled to this bulk billing. So that was I completely understand the point that you were trying to make, but that is not what these figures say. I'm trying to understand how you've got to these figures. So,
But sorry, Senator, you asked a question and I haven't got a Hansard obviously in front of me, which I think was essentially, is it contingent on hitting exactly the 100% bulk billing target rate for clinics? And I agree that those figures are based on estimates of what the proportion of clinics that will be 100% bulk bill, because then that tells you what is the proportion of the funding that is going through the incentive payment. But I was just responding to the point that there are multiple combinations that could lead to meeting the 90% target, which is not what we are currently estimating.
Okay.
And
so can I ask you...
may just finish. As is always the case with estimates for demand-driven programs, as we roll through time and we get better information, we will update those estimates of what the ratio of the 100% bulk billing clinics are versus the others.
Okay. So could I ask you then, on the basis of the figures you've given me this morning, what were your assumptions for these figures? What are the assumptions in relation to the combination that you've just talked about that go into these figures? All I'm asking for.
So Mr McCabe did indicate that on notice we would look at the assumptions that we can provide to you around the modelling that has contributed to these figures.
Yeah. Well, he actually said he would take into account the assumptions. What I'm trying to understand is, what is the breakdown between the number of clinics that are going 100%? So what is the breakdown in these figures in terms of the number of clinics that reflect the figures and how much you're paying out in the bulk billing practice incentive payment, and what is the assumption of the number, the level of bulk billing that goes into the assumption of the amount of money that you're paying out year on year on the actual bulk billing incentive itself? What are the determining factors? How many clinics, bulk billing rate? That's all I'm asking for. It seems like a pretty easy answer, and I think it is a reasonable thing for me to be asking. And for some reason, I don't know why we just spent half an hour and I don't have that answer.
Well, I don't think that this is just simple modelling of this number multiplied by that number. There are assumptions that need to be made based on the services provided by different practices in previous years. There are thousands of practices. There are assumptions about them changing their bulk billing. So Mr McCabe has said that he will take on notice providing the modelling assumptions that we can without identifying individual practices.
It's even more simple than that, Ms Shakespeare. You have figures here that have to have been determined on the basis of something. I don't understand why you can't just say, this is the bulk billing rate in 26, 27 that we expect that these figures have been based on. Now, of course that might well change. Let's hope it's better than you're thinking it's going to be. But it seems incredible that you are just continually refusing to provide that piece of basing. It doesn't identify anybody.
As we've said, there are no particular bulk billing targets year on year. We
But
have
they
a target
have
we're
to have
working
been.
towards, and we have
Can we let the
estimates of
official finish her answer? I can tell you're extremely passionate about this, but it is disruptive when we don't let the officials finish their answer. And just alerting you that I will need to shift the call now that we've got a new player in the game with Senator Pocock. So if this could be your last question, I'll let the official finish their question and then I will shift the call.
Thank you, Chair. And we have estimates of expenditure that have been published in the budget papers.
Yeah, so
we will take on notice, Senator, the questions that you've asked in terms of the breakdown that underlies the estimates in a way that doesn't reveal confidential information.
I just want the big number. That's all I'm asking for. Big number broken down state by state.
Okay, I believe that the Secretary has taken that on notice for you, so I will shift the call now to Senator Pocock. You have the call.
Thank you, Chair. Thank you for your time this morning. I've got a few questions about the PBS, if that's all right, and a bit of a case study, and just trying to find out what sort of thing can be done in these sorts of situations. I've had a mum in Canberra write to me about access to biological medicines for the treatment of Crohn's disease. Both of her children have quite severe and debilitating Crohn's disease. Her eldest son is now on one of the biologics, and she says it's been amazing, total game changer, but has been a long time in the making. As essentially you have to try every other available medication first before you're allowed to access these medicines on the PBS. Her younger son is now starting that same journey and having to essentially go through treatments that are usually used for cancer patients, and obviously really knocking him around. And she says in this letter to me that she's been sleeping beside his bed each night because she's worried he's so ill, and because she is, and I'll quote, worried that he's going to die. So clearly very distressing, and particularly for a mum who's already been through this with one son and now knows how effective other treatments are. She also says that we're the only country in the OECD where these medicines can't be accessed as a first-line therapy for children with Crohn's disease. And so I guess my question is, what can be done here? How can we actually avoid a lot of this for young Australians who are dealing with Crohn's?
Thank you, Senator, for your question. And yes, Duncan McIntyre, First Assistant Secretary, Technology Assessment and Access Division. We are aware of this case, and I'll be mindful of the details of particular cases in providing an answer. But the treatment of Crohn's disease is an issue that continues to be a matter for active discussion amongst our clinical committees. Both our Pharmaceutical Benefits Committee and our Medical Benefits Committee, looking at pathology testing, have been in discussions about ensuring that there's the best pathway for treatment for different kinds of patients who might be suffering from this terrible illness. Mm-hmm. In most our understanding is that in most OECD countries, it's been the practice that these more advanced therapies that you're mentioning are a third-line treatment. Australia is not alone in that regard, but there is an ongoing discussion about how we can make sure that patients are escalated to the medication that is most likely to be suitable for their condition at the earliest possible opportunity. There's been two changes to the way in which restrictions are managed for these therapies in the past year, and indeed we're anticipating that at the meeting that PBAC will have on the 10th of December, it's on the agenda again. The outcomes of the deliberations that happen on the 10th of December will be published on the 30th of January, and so at that point we can anticipate further updates.
And so, I mean, what needs to happen here? Do we need the pharmaceutical company to put in an application to PBAC? Do you know if any of them have done that? Like, it just seems like this sort of thing should be expedited, and there should be a way, particularly if you have one son who's clearly gone through the ringer and is getting effective treatment, to potentially jump a lot of that and go straight to biologics.
Senator, there is a process, as I understand it, and I don't want to get into the clinical details here, but there is a process that allows patients to be tested on other treatments, and if those treatments are ineffective, move to this treatment. But those first and second line treatments are in many cases effective, and PBAC are very careful about making sure that they're assessing the evidence before making clinical changes such that they can ensure that they're improving the quality of therapy. And that is an ongoing discussion because the evidence is evolving here, but it's not clear in the discussions that PBAC have had that it's that the treatment path that they currently have isn't the right, like basically the pathway that they're recommending is always designed to be provide the best options for clinicians. There is a sponsor that has an application, but working with the sponsor is important to ensure that the drug company is willing to provide supply on the terms and conditions that are necessary for good clinical therapy, and that's also a part of the ongoing discussion that PBAC needs to have. The sponsor needs to be willing to provide their medication on the terms and conditions that would be considered good clinical care.
Thank you very much, Ms McIntyre. That's really useful information. I understand there's obviously stringent processes and checks and balances, but is there in sort of an instance like this, and don't want you to refer directly to this, I understand you can't, but are there pathways sort of on compassionate grounds where someone can actually say, hey, I've understand there's this process of first and second line treatments and then potentially biologics, but I've been through that with one son. Can I?
Senator, without speaking to a particular case, which is neither appropriate nor would we be qualified to have that discussion here, that's certainly a matter that I would anticipate should be discussed with the treating clinician, and there are pathways that the clinician might be able to recommend if they feel that would be the right treatment for a particular patient. So the PBS is about providing public subsidy for medications. There are ways in which if a treating clinician has determined that an alternative pathway would be desirable, there are other ways that they can recommend that to a patient.
And so what happens then if the clinician says yes, then what?
It'll depend on the circumstances, but the PBS provides the treatment pathway that's necessary for subsidised access on the PBS. But if the treating physician formed the view that an alternative way of treating that patient were appropriate, then they could recommend that to the patient, and the patient could pursue that.
So, a couple of examples, Senator. Sometimes companies provide compassionate access, so that's at the cost of the company. But where we have a situation where an individual patient would benefit from a medicine that's not PBS listed, or the evidence for that broader patient population hasn't been presented or convinced the PBAC to list something on the PBS, the public health system is also able to fund treatments for people. That's usually assessed through drugs and therapeutics committees of public hospitals.
Okay, thank you. And so just finally, just so I understand this better, can the treating physician skip the first and second line then and potentially go straight to biologics?
It's difficult to answer that
Not
question.
on the PBS.
no, they can't do it on the PBS.
On the PBS.
So the PBS restriction basically communicates, so the restrictions are available on the PBS website. They're there mainly for clinicians to read, but they're available for the rest of us if we wish. And they outline the process that clinicians need to go through in order to recommend a therapy and to have it subsidised under the PBS.
But I guess that was my whole question, is that how do you potentially go straight to biologics if you know that it works? And I mean, if you can't do it on the PBS, it's just too expensive unless you're incredibly wealthy Australian.
So there's a pathway that lays out how you can go through the steps to allow it to be subsidised under the PBS, but the treating physician isn't bound by that. If they want to work with the patient to recommend an alternative therapy, they can do that. In terms of how that might be paid for, there's the potential for that to be done through the hospital system. There's also compassionate access that some pharmaceutical sponsors are prepared to provide to patients in particular circumstances.
Okay, thank you.
I believe
I might
the Minister
follow up.
wanted to.
Yeah, well, it perhaps goes to your follow-up, Senator. I'm conscious that you are asking officials policy questions, but that those policy questions are grounded in the real-life experience of a family that you're in contact with. I know that Minister Butler would always be open, and his door would always be open to a representation from you about these issues.
Yeah, no, I think that's really, I think useful to kind of lay out the pathway. It seems like that's not going to work in this instance, and so I'll try and potentially take it up with the Minister. Just on bulk billing, I overheard earlier that the national bulk billing rate for November was 80%. That's a fantastic result. So congratulations and thank you for the work that you're doing there. Like that is impressive. Can I ask what the rate for the ACT was in November?
So, Senator, I can see if I can get that for you, but the numbers, as Ms Shakespeare indicated earlier, are very early. We only concluded November on Sunday, so I just need to check whether we have that number.
Sure. Maybe while you're looking for that, I think you also said that 15 clinics were registered with bulk billing practice incentive program in the ACT, and then that 8 were already fully bulk billing before the 1st of November. But I was just wondering if you could take me through the 15 figure and what it means. Some of my team just went on Health Direct and could only find 9 clinics that said that they were fully bulk billing, and I thought it was a requirement to register yourself as fully bulk billed clinic on Health Direct to receive the PIP.
So yes, you're right. 15 clinics have registered in the ACT. We're asking Health Direct to follow up with those that haven't registered on Health Direct yet, that have registered with the program with Services Australia. So we'll be doing that in the coming days and weeks.
Thank you. And how stringent is that requirement? Can you receive the PIP if you're not listed on Health Direct, or is it kind of a...
It's a requirement of the program to be to be advertised as fully bulk billing on Health Direct and to display the Medicare bulk billing signage.
Okay, great. Thank you. I'll follow that up. And of those 15 clinics, do you know how many are open to sort of the general population? I know a few of the fully bulk billed clinics in the ACT are sort of more specialists, Winunga and others.
We'd need to take that on notice, okay. Senator.
Thank you. Number?
So, Senator, I do have the bulk billing number for the ACT. In the month of November, it was 53.2%.
Wow, okay.
So still a little bit of work to do in the ACT.
Yeah, a lot of work to do. Okay. Do you have the under-16s?
No, we haven't got... do we have splits? I don't know if we've got splits for November at this stage, Senator.
Maybe just on notice then, if you're happy to break that at 53% under-16s and then concession card holders, unless you have it there. The other thing...
Senator Mary Warner, I'm Assistant Secretary of Diagnostic Imaging and Pathology Branch. We have September concession card data for concession card holders. We have the September quarter for the ACT.
Yep.
And the bulk billing rate is 74.4%.
Great. And what was that, the national number for that?
The national number was 54.
No, the national number
For the
the national
September
number?
quarter for concession card holders.
I don't think I have it for the September quarter. I've got ACT for the September quarter.
Okay. Maybe just on notice then, if that's all right. I was also keen to ask about diagnostic imaging, and thanks for the data that you provided on notice. Over a few years now, sort of looking at the ACT. And from what I can see in the 2022-23 financial year, the bulk billing rate for ultrasounds here in the ACT was 48%. For CTs, it was 75%. MRIs, it was 80.3%. If we fast forward a couple of years to the June quarter this year, the bulk billing rate for ultrasounds is now 34%. CTs is 66%. And MRIs, really concerningly, has halved. That's collapsed to 46.5%. It's the lowest in the country. And I get a lot of Canberrans contact me about just not being able to afford scans. And I know that the situation is so ridiculous that Canberra Imaging will bulk bill children at their Goulburn clinic, but not at their Bruce practice. Same company, but bulk billing differently in New South Wales that they do in the ACT. I'm really keen for your views. I've spoken to some experts and they kind of say, well, this is a competition issue in the ACT, but I'm interested whether the department has an analysis and what can be done.
Perhaps I can say this, Senator, and then officials will doubtless have more detailed information for you, but we are very conscious that there is a particular issue in Canberra in relation to people accessing bulk billed health services. And obviously our focus to date has been on GP practices in particular. The dynamic you raise, where a similar business makes different decisions in different markets, is a really intriguing one. It's why we've taken the additional steps that we have in the ACT on GP practices to try and enliven some additional practices that will bulk bill, because we do want to see more bulk billing practices in the ACT, and the interventions that you are well aware of that have been announced by Ministers Butler and Gallagher to really get that moving are really important, because we do want to see better services for Canberrans. On the diagnostic imaging questions, I'll defer to officials, but we are very aware that this is a really interesting market dynamic.
So, Senator, we've been discussing the government's interventions to support primary care and to increase bulk billing rates. We have also been working on what we need to do around specialist out-of-pocket costs. So we've held some roundtables with specialist doctors, with patients to discuss options. We've looked at the extended Medicare safety net, which is additional support that for patients who have high out-of-pocket costs for specialist services over the course of the year, and are looking at reforms we can potentially make there to try and reduce some of those out-of-pocket costs and the fact that they are going up quite significantly in some locations. So I think, as we've discussed in previous hearings, the way that the Medicare system is structured, the Medicare benefit schedule provides rebates for patients to seek services off their preferred provider. It doesn't require providers to accept those rebates as full payment for their services, and there is a market deciding what to charge for the delivery of services that seems to operate a bit differently in Canberra than it does in other parts of Australia.
Thank you, and I really appreciate all the work you're doing on that. But say on MRIs, in 3 years, the bulk billing rate going from 80% to 46%. What's the analysis of what's actually happening there? Like, how does that happen when you're actually sort of putting other investments in, and the market kind of shifted that much in 3 years?
So, I mean, MRI, there has been quite a significant change and we're still expecting further changes. I'm not sure if my colleague Ms Warner would like to talk about that.
There's been significant changes in the MRI, sort of the policy of opening up MRI Medicare licences. So since the 1st of July this year, if you were a practice and you had an ineligible Medicare MRI machine, that machine would become Medicare eligible. So that happened on the 1st of July, and that was also in MM1 areas, including the ACT. And from the 1st of July 2027, there will be a change to the policy as well. So any practice that wants to commence services with a new MRI machine, they can purchase an MRI machine and they can start billing Medicare. So we've had a staged introduction to opening up MRI services.
We are hoping, especially in metropolitan areas, Senator, with that change in policy, that we can increase competition.
Right. And is there any sort of modelling or analysis of how you think that'll be taken up in a market like Canberra? You know, how many MRI machines would there be that aren't?
We did some analysis about how many machines were were registered with Services Australia but weren't Medicare eligible. Yeah. So we've done it from that, but we don't know what machines are out there providing private services.
Do you have the number for that?
I don't have the ACT number.
Okay.
Maybe
take on just on those. Okay, thank you.
I mean, there are 10 eligible MRI machines in Canberra that have that can claim Medicare rebates. I think that's right. Just check.
But we will take on notice how many machines we're aware of that do not currently or did not have licences.
Okay, great, thank you. And then just finally on the Medical Cost Finder website, I'd just be keen for an update. I believe there was work underway to publish individual fees, and just wondering how that's all looking. This is the last sort of section. Thank you.
Assistant Secretary, Health System Strategy Division. So it's progressing well. So I guess to do what the government has announced, we have to get data from multiple sources. We have to publish that data at individual specialist level, which will require legislative change to allow that level of scrutiny, and there'll be system design changes. So we're doing all those things in parallel. We're hoping for legislation to be introduced next year, and then no one underestimate the task that we're going through, but if all that goes well, then hopefully a launch of the site with those median level at specialist disclosures by the end of next year.
Okay. And has that legislation been drafted?
We're going through that process.
Okay. And is it a case of you have the ability to collect that data, but you just can't publish it until the legislative changes happen, or is the legislative impediment actually holding you up, getting everything ready for sort of royal assent, where you can then press publish?
It's a bit of both.
Yeah.
So we will use both MBS data that we have access to but can't use in a specific way, and we'll be drawing data from insurers and using that in a different way. So we'll be able to say not only what the specialist charges, but also the extent that they charge no out-of-pocket costs or no out-of-pocket costs, and by what insurer. So all of that requires, as I said, multiple data sources, and it's some we have already but can't use, some we don't have, and so it's a question that we're doing a bit at the both, but we're starting to get those data feeds for 24-25 and then incrementally for 25-26, and we need a certain period of that billing data to be able to work out the median in a credible way. So all of those things are happening in a staged way.
Thank you, Mr. McBride. And are there any other impediments or roadblocks on this project? Is the website, is that the back end and the
so there'll have to be changes to the website, and I think in previous estimates you've pointed out some of its limitations. So we're seeing that people have to click through too far, and we lose some people in that process, or we're doing a bit of a redesign and user testing to make sure that people can get to the things that they want and understand that process more easily. So again, happening in parallel with the other processes.
I think, Senator Pocock, this project is in a context where Minister Butler's made it really clear that specialist fees and affordability of specialist services is a focus for the government in the second term. I understand he sought advice from the department about additional things that we might do to get out-of-pocket cost growth under control, but sorting out the failures of the previous government's medical cost finder scheme is first amongst those, and officials obviously are updating you now, and I get they have in previous estimates also.
Cheers. Thank you. Thank you, Mr McBride. Appreciate your work on this. I think it should be incredibly valuable once it's up. Minister, just finally, my final question. You talked about the government interventions on primary healthcare, and they, as a Canberran, they are genuinely very welcome. One of the big challenges we face is around workforce and GPs in the ACT. We have one of the lowest GP to population ratios in the country. The Albanese Labor government has now funded 120 additional Commonwealth supported places for medical schools around the country, 20 as an election commitment for Tasmania, very much needed down there, another small jurisdiction that's really struggling with their health system, 100 through a competitive process. Every jurisdiction in the country that has a medical school has now received additional CSPs except the ACT, the place with the lowest bulk billing rates, one of the lowest GP to population ratios, and just wondering if you could provide some assurances to Canberrans or I guess tell us how the government is going to address the GP shortages if we can't train more at the ANU.
I understand that this was the subject of quite a lot of questioning with officials yesterday. Those officials are not here because they were
no, it's a
present for
political
outcome
question.
one. Yes, I know, and you had a chance to talk about those yesterday. I mean, I think you've also asked me about this in the Senate, and the point I made at the time was that there are a set of criteria for that program. They were used in the allocation of those, the competitive allocation of those places, and there were a range of personnel within the department who supported that decision-making process.
Thank you. And I totally understand the 100 CSPs through the competitive tender process, but we've seen when the government does want to address something, we've seen sort of the 20 CSPs as an election commitment, obviously no competitive process, and just wondering if the ACT could get that sort of, I don't know what sort of attention.
Well, I think announcements are made in the ordinary way, Senator Pocock, not by acting ministers at the table at Senate estimates. But as I said, I think you asked a lot of questions around this yesterday, or somebody did,
really
because it's in outcome one. But we will continue to make investments in the ACT, establishing appropriate new practices, incentivising the development of new GP practices, and making investments in workforce.
Great. Thank you very much. Thank you.
Thank you, Senator Pocock. Senator Ruston, you've got.
So, continuing on a similar line, the latest Medicare quarterly statistics confirm that for the first time, out-of-pocket costs average were more than $50. Can you provide me with the department's estimates on the average cost for each year across the forward estimates is likely to be?
I'm sorry, Senator, which out-of-pocket costs were you referring to?
Out-of-pocket costs, the average out-of-pocket cost for visiting a GP have gone...
For GP non-referred attendances?
Sorry?
GP non-referred attendances.
Yes. Yeah, they're non-referred. Non-referred attendances, correct. And it's the last figures for 24-25 were $49.14. The latest stats that came from the department's website was that they were over 50. I'm just interested in what your projection is. At the last estimates, I'm not sure which of the officials said that there was an expectation in the department that out-of-pocket costs would actually continue to increase. Just wondering what those expectations were over the 4 years of what the increases were expected to be.
I think while the official's assembling her answer, or getting the information she needs to provide an answer, the point we'd obviously make is that out-of-pocket costs are the reason that we seek to improve bulk billing rates, because when you are bulk billed, you are not paying an out-of-pocket cost. We're very pleased to see some of the early results in increases in rates of bulk billing, and it's why we are making that $8.5 billion investment to repair the bulk billing rates, Senator Ruston. I know you know that, but these things are intimately connected. The reason that we wish to raise bulk billing rates, and we are taking the steps that we are to shield people from out-of-pocket costs and give them the option of attending a bulk billing doctor.
So, contrary to what the Minister has just said, you gave me evidence at the last estimates that the expectation of the department was that out-of-pocket costs were going to go up.
That's not contrary to what I've just said.
So I'm just keen to understand if you have, and so obviously there must have been some basis for your belief that they were going to go up. So I'm just wondering if you could provide me with the data of what your expectation in terms of that increase in out-of-pocket costs is likely to be over the next 4 years.
Senator, we do not model those out-of-pocket costs. They're based on the decisions of private businesses. I think if there were any comments about out-of-pocket costs going up in future, it's probably based on the data that we've collected since Medicare was established in the early 80s about out-of-pocket cost trends.
Yeah, okay.
Senator, I think the other thing that's important to note is we anticipate that bulk billing will increase over the next 4 years, up to 90% by 2030, and so therefore more Australians will be getting access to free GP services.
And just to finish that point, the data you're quoting on out-of-pocket expenses is only out-of-pocket for those who are not bulk billed. So if you think about out-of-pocket across the whole population, it's a weighted average of those bulk billed and those actually paying an out-of-pocket expense.
Tell that to the person who's at the front desk of their family doctor. I don't think they think, oh, this is great, I'm paying so much more because on average it's less. I mean, the reality is that is what somebody who is not bulk billed is paying at the doctor's surgery. So I accept your point, but I'm not sure that that's how the person paying the bill feels.
If that is your analysis, Senator Ruston, it is surprising that your government didn't take more steps to repair the falling rates of bulk billing. As you know, bulk billing rates were in freefall when we came to government. We have taken a series of steps in the last term to start to repair that. We will take more in this term. We do think Australians should have access to affordable healthcare. It's why we prioritise bulk billing, and it's regrettable that an extended freeze on bulk billing payments led to the problems that we are now seeking to repair.
Thank you very much, and I'll continue to prosecute the budget and the estimates that the department has on the budget, if that's okay. So I'm also interested to understand the number of patient-billed services. So obviously that is the number of people who are paying. So were you able to confirm, so the average out-of-pocket cost now is over $50?
Senator, the average out-of-pocket cost Australia-wide for the September quarter well, actually, I'm sorry, I'm just looking at concession. Are you interested in concessional patients?
I'm actually interested in the average out-of-pocket costs for non-referred attendances.
Yeah, it's $50.49.
$50.49
for the September quarter for concessional patients. The average out-of-pocket cost is for the September quarter is $43.32.
$43.32 for concessional.
Yes.
Okay, thanks. That's very helpful. Okay, so two patient billed services. So this is clearly the people that are on average paying over $50 to see their GP, and recognising that some of them are paying a lot more than $50. In 24-25, so I'm interested, am I correct in reading this that there were 37 million patient billed services?
What period are you talking about, Senator?
24-25?
For GP
GP non-referred
attendances.
Yep. I'm talking about the ones that attract the $50 average.
I'm just checking whether we have that data, Senator.
So GP non-referred attendances, the number of services in 24-25 was 167,000.
No, I'm asking you, what was the patient billed services?
So I don't have that split with the Senator, as Ms Warner was explaining. There was 100.
Ms Warner seems to have the number of services that were provided, but not the number of services that were billed.
Ms Warner has the total number of services that were provided by GPs. We just don't have the split of those that had a copay, Senator.
Of those 167,000 odd services, 77.9% were bulk billed.
So how many weren't?
It's 167 million services last financial year.
So multiply that by the bulk billing rate and subtract those, we could work out the number of services that were billed. So over 77% of that 167 million services, there was no charge. For the others, there was a charge.
I know, Ms Shakespeare. I'm just trying to get to the bottom of who was actually paying on average the $50. So, so according to my records, this is Medicare data, by the way. This is not something I found in the paper. This is Medicare data that you have arrived here without. You seem to have all the other Medicare data, but you don't seem to have this Medicare data. So according to your Medicare data, on the same sheet that all those other figures appear, there is a line that says patient bulk billed services 24-25, 37,123,713. Do you have that data with you? Because I'd like to talk to you about it.
I think that data will be on our website, so we can check our website and confirm for you, Senator.
You had all the other data that was on your website, because this all sits on the same sheet. So what I'd really be keen to understand is, over the trajectory of the last 15 years, we have seen, by the data that's on your website, an incredible increase that sort of exploded about 2022, on average from 2009-10, there was...
Senator Austin, it might be helpful to officials if you're open to this, to tabling the document that you're reading for, so officials can see.
This is their data, by the way, Chair.
I'm aware of that, but I think it's helpful if you're reading that into the Hansard. They may also be able to look at figures and or confirm that it is on the website. I think that's what Ms Shakespeare was referring to. So if you're happy to do that, I'm just obviously trying to be helpful for the committee and to facilitate everyone being on the same page.
Okay. I'll just ask a couple of other questions on something else while that's being done.
By all means.
Okay. So in regards to your bulk billing incentive, I understand that there is mandatory signage requirements for the clinics that sign up to it. Is that correct?
Thank you, Senator. Yes, there is, and we've published on our website the requirements around signage.
Are there penalties if they don't?
It's a requirement of the program.
Yes. My question was, are there penalties if they don't?
So at some stage we will look at compliance. What we'll do in the first instance is see if there are delays and if we can send out communications to ensure that practices are aware of the requirement. We have put on our website all of the details. We've done a number of webinars to ensure that practices are aware of the requirements, and we've certainly put communications out via key stakeholder groups as well.
Okay. So how are you going to monitor whether people are doing it or not?
So, Senator, we've got a relationship with Health Direct, and certainly we are talking to them on a regular basis about what figures they have compared to what figures we have.
Of how many people put a sign in their window?
Not for the signage, for the requirement for Health Direct advertising as well.
Okay. So how much money is being invested in either doing this signage or monitoring this signage or enforcing compliance with this signage?
In terms of the funds for the signage, I think that's our whole of portfolio communications team that has a contract for the signage.
Could you maybe find that out?
We need to take the amount on notice, Senator.
So that's the signage part of it. So understanding what the printing of it, the design of it, the delivery of it, the processes that it had to go through, then how we're intending to monitor it. If you could get me the budget for that, that would be great. Is it possible to get that quite quickly?
We'll see what we can do, Senator. I think the other group of organisations involved here are the primary health networks as well, in terms of their support for general practice to have the appropriate signage displayed. They will have a role there as well.
Okay.
I mean, I think the point here is, of course, we want Australians to know where they can find a bulk billing practice. We're really proud of the practices that are bulk billing. We're proud of the investment that we're making in bulk billing, and we want people to be able to go and find a bulk billing doctor if that's their choice. And I think many people will choose that. So we've put up similar signs on the Medicare urgent care clinics. Over 3 million people have chosen to visit those. Telling people how you get public health care is a really important part of the project.
And I think people getting access to timely and affordable healthcare is very important, Minister. But what I'm trying to understand is, GP practices, our family practices, are private businesses, and I certainly understand that they're funded through mechanisms from government. But this is effectively forcing private businesses to display signage to promote the government. So I just think it's reasonable for me to understand what amount of taxpayer money has been spent requiring private businesses to display government promotional material, and what sort of compliance is required of that. So I'm going to sort of understand how that happens. So it really is just a budgetary request. How much taxpayers' money is being used to force private businesses to display government signage? That's all my question.
Look, I think officials have taken that question on notice, but
thank you.
I think that the main point is that we do want people to be able to find these services. We're not forcing anybody to visit a bulk billing clinic. They are choosing to do so. But our experience with Medicare urgent care clinics tells us quite a bit. I think I may have spoken earlier, but there are 2 million people who have visited these clinics. Letting people know where they are is really important. And some of the ones I've visited have very prominent signage, and it's really clear that people walk past, see that there's an urgent care clinic, and actually log it mentally and use it. And that's a really good outcome. We're very pleased and proud about that.
Yeah, I'm not suggesting you're forcing people to visit clinics in any way, shape or form, but you are forcing the clinics to put signage in their window, and I'm interested in how you're able to do that, the legality of you being able to do it, and the costs that have been invested in the process of doing that. So
we are giving people good choices, and it is a significantly better outcome than the trajectory that bulk billing was on when you left office. It was, as you recall, in free fall.
Minister, I'm not arguing that you're giving choices to people. You are giving no choice to a small business. That is my point. It's not about the people that are getting access to it. You are forcing small businesses to do something. I just want to understand the legality of doing that and the cost of doing that.
That's also incorrect, Senator. Small businesses are not forced to become a bulk billing practice.
No,
but if
I didn't
they
say that at all, Minister.
They are able to access the incentives that we've put in place, and when they're doing that, we want people to know about it. And I think the small businesses that are engaged in this will also want that. You know, it's a very positive development for public health.
Yeah. Minister, just to be absolutely clear, I did not say that we were forcing clinics to become bulk billed services. I'm merely saying your officials have just told me that it is a requirement to use this signage. I've asked some very legitimate questions. I don't know why you're being so defensive.
No, I'm just explaining the purpose because it's really important and we are proud of the program.
Okay,
Senator.
thank you. So have we got that document yet or not? No, it's still being photocopied. Okay. I'm just interested, in a television interview on the ABC on the 29th of October this year, Minister Butler was speaking to Patricia Karvelas, and in that interview, the minister said that if GPs cannot afford to fully bulk bill under the new policy, he will intervene in the market. So can you outline the steps that are being considered for interventions in the general practice market?
Senator, I think an example of that is the 3 fully bulk billing clinics that are being funded in the ACT. So that's an example of an intervention in a market. With Senator Pocock before, we were talking through the particular challenges in the ACT. That's an example of an intervention that the government can take in the market where there are concerns about bulk billing rates.
Okay, so the government's intention potentially would be to take over the operation of general practices in areas, or provide services in the same community, government-funded service in the same community, alongside of clinics if they're not prepared to bulk bill.
They're not government-funded services, Senator. They're incentives for practices to become, or to create a fully bulk billing practice.
Okay, so the intervention is that the government would provide additional funding to a clinic in the same way they do with the fully bulk bill clinics. They would actually provide the funding to those clinics. So what's the difference between that and providing the incentive? So there would be additional incentives over and above.
So what is happening in the 3 clinics in the ACT are incentives to attract workforce and to assist with the establishment costs of a clinic to recognise the particular challenges in the ACT.
So the funding that's been provided in the ACT is over and above the practice incentive payment that sits alongside the bulk billing.
Yes.
So there are actually additional incentives that are going to be put into those clinics. So if I say I can't afford to fully bulk bill, you're likely to, are you going to give me the clinic that can't fully bulk bill, or are you going to give it to somebody else? In
the example in the ACT, Senator, these are to establish new bulk billing clinics.
Okay, so basically if you don't... printer's broken. So basically if I say I can't afford, as my family practice here, I can't afford to fully bulk bill because of the cost of doing business or whatever, the government's response to that is to put more money into a competing clinic to make them fully bulk bill, to actually basically put more market pressure on this clinic, this family practice that is unable to...
I think, Senator, our purpose is on the consumer. We want the Australian people to be able to access bulk billing services. And there might be a range of reasons why bulk billing services are not available in a particular community. If that's the case, that's a problem for that community, and we want to be able to make sure that people can get them. And so, that of course is the purpose of the broad investments that we're making in the last term and this one to lift rates of bulk billing. But in the interview with the ABC, Minister Butler is observing that there are some places where bulk billing is stubbornly low, and where we see that, if there are opportunities to intervene, to make further interventions to lift bulk billing, we're willing to contemplate that. And he provided the ACT as an example. Obviously, that's been canvassed here, this estimates and previously.
Thank you very much, Minister. I'm seeking to understand the measure. I don't need the political logic behind it, but I accept that you have the right to put that on the record. I'm actually seeking to understand what is actually being contemplated by the department.
There's a concrete example in the ACT, and I mean, I'm not sure if you want more
Would it
information.
be okay if I was able to ask the officials questions?
Well, Senator Ruston, the estimates process does involve ministers attending, and from time to time I will answer questions, but please continue.
Thank you.
It'd be helpful, Senator Ruston, if you are directing questions, and I think the Minister is in line by providing a substantial answer. But in my experience in the last 2 days in this committee is that it's not always clear who the questions are directed at. So it might be helpful if you are asking specifically to an official. One, you can use their name to direct that in, or be a bit clearer around this is for the officials. That might also be helpful.
Yeah. Although I will say I reserve the right to answer those questions as well.
Absolutely, Minister.
Under the
And
standing
we would never stand in the way of that.
Great.
Rest assured.
They should defer to the Minister. Yeah.
I believe the document is being circulated. Senator Ruston,
Thank you. Yeah. So just following on from the point that you raised, Chair, sometimes the officials are probably best placed to actually identify who's in the best position to answer a question. I mean, I'm happy to sort of try and pick out the person who might best answer it, but obviously I would leave it up to the discretion of the department to decide who has the
Absolutely, Senator Ruston,
information.
but I think you're aware as a Shadow Minister that Minister McAllister, being the repping Minister on behalf of Minister for Health, Minister Butler, is also within her right to answer the questions that are being posed during an estimates hearing. So rather than splitting hairs on that, let's agree to disagree on that one. And you do have the call, and I believe you're proceeding with questions in relation to the table that's been, document that's been tabled.
Thank you. I think perhaps we're not talking about the same thing, but I respect your judgment, Chair.
Sorry, just Senator Ruston, before you continue, I will just note I think this document is actually really difficult to read.
The one I provided wasn't.
Yeah, but yours are probably a lot clearer than the ones that we've got in front of us. Just so you know, I'm having trouble reading it. So officials also might be having trouble reading it. I'm just flagging that as an issue.
Thank you, Senator Stewart, for that information.
So, I mean, this is a very unusual situation to find ourselves. The document I provided was clear. The photocopying, I believe, has been a little challenging for officials, so I acknowledge that. Do you have the information that is on this document accessible to you as you're sitting at the table?
Senator, we can confirm that the data you've presented is consistent with data on our website.
Is it consistent with data on the website, or is it actually the data from your website?
It is the data on the website. It's a view of data that's on our website.
Yeah, okay, so it's correct.
Yes, it's correct.
Okay, so I'm just keen to understand.
The website's correct.
Yeah, funny about that.
Even though it doesn't note on your document that the source of that. So I just want to note that. I think that's the confirmation you were seeking. Is that correct, Senator Ruston?
Oh,
Yes,
not at all.
I should note that I had to put a whole heap of filters on a table that's on our website to get this view, Senator.
Yeah. I must be so much cleverer with finding information than you then, perhaps. So I'm just keen to understand quite clearly from 2910, we have seen pretty much a completely steady average of the number of Australians and the services that are Australians that are billed for. And that remained consistent from 2009, when this document starts from, right the way through the COVID years. And then for some reason in 22-23, we've seen an explosion from 22 million paid attendances for services to 37 million. So it goes 22, 32, 37, 37. Is that correct? Have we seen nigh on, well, pretty much since 2020-21, we've seen a doubling of the amount of services that are attracting a charge?
So I think we went through the analysis of service numbers and the proportion of patients being charged in great detail in our impact analysis about this measure. I think the most likely reason was, and I think it was an exhortation by the then President of the Royal Australian College of General Practitioners for practices to move to mixed billing that seemed to be coinciding with the increase.
So that was done in 2021, Senator, in November.
Yep. But certainly the community was very concerned about the reduction in bulk billing access. The government has responded to that through the measures that were included in the 25-26 budget, and we've rolled out from the 1st of November this year $7.9 billion investment in bulk billing incentives, triple bulk billing incentives for the entire Medicare eligible population, and the 12.5% program uplift for those practices that bulk bill 100% of their GP non-referred attendances.
So can I ask you, Ms Shakespeare, what is your, your projections or your analysis in what's going to happen to those numbers?
So based on the first month of operation of the GP bulk billing incentives and opening of registration for the program, we have seen what looks like on early data to be a 4 percentage point increase in the bulk billing rate.
Yeah.
We're going to monitor to ensure that that continues and that we will be carefully looking at the data, but the early indications are that the number of patients who will be charged for services will reduce.
Okay, so I'm just interested, except that you're talking about a different, they're all interconnected, this data, but I'm just interested to understand what are the department's projections in relation to the number of people who will not, that will be actually in this column which says patient billed services. What are your projections on patient billed services going forward?
Look, I'd have to take that on notice. That's probably part of that exercise we took on notice earlier to provide you with the assumptions underpinning the estimates over the forward estimate period.
So can I be really clear here? I'm not just asking for the assumptions, I'm actually asking for the
targets?
Well, no,
I think we've already covered
we won't
that.
use targets because I know you don't like that. Well, it has a different meaning. What are the estimates, the assumptions and the estimates? Understand that you can't provide data that's likely to identify, commercially sensitive information. But in this case, what is your estimation in terms of the trajectory of the number of billed services? What is your estimate in the trajectory of the bulk billing rate? What is your estimate the trajectory of the number of clinics that are likely to be moving to fully bulk billed? What are those estimates based on the assumptions that you agreed to take for me?
We will provide you with the assumptions that are underpinning the estimates over the forward estimates.
But you'll give me the estimates as well?
So our estimates are really looking at Medicare expenditure and what we expect for particular areas. Like
but there must be metrics by
attendances.
which you will measure that. So if you could provide the metrics through which you are intending to
So
measure.
if we're back to metrics and targets, we've had that discussion earlier, we can certainly provide you with the assumptions underpinning the estimates in the budget papers.
Yeah. So,
Senator Ruston, I'm just checking how much time. I know you're in a conversation around your question on notice, being taken on notice, but I do have Senator Roberts who I'd like to get on before we go to the morning break. I'm just conscious that I will need to find time. So
yes.
I'm happy to complete the question, but I will need to give Senator Roberts.
I understand you've been very generous with the time this morning. So I'm not asking for targets, I'm just asking for, you've got three pieces of information here. You've got the assumptions, you've got the budget estimates that you've provided me, and then what are you doing, what are the measures that reflect those estimates? You didn't just make the numbers up, you must have a series of things of which you are measuring that against. What, if you're going to have that much expenditure, there must have been that assumption that you were going to achieve that outcome. So not just the assumption, but the numbers that actually sit next to those assumptions that match up with the dollar figures that you've given me would be fabulous.
Right.
Thank
I'm
you.
sure officials will take
think
that
we
direction and
understand
provide
the
to you
nature
what
of
they
the
can.
Sorry?
I think we understand the nature of the request.
Yeah, thank you.
Whether you
We
give
might
me the
have an
answer
offline
to it.
discussion about nomenclature at another
Well, we're
point
back in
time.
February, so let's go there then. Are you just checking you've completed that round?
Oh, sorry, you wanted to...
Okay.
Yeah.
Senator Roberts, you have a call.
Thank you, Chair. Could I have the professional services review schedule?
Antonio Didio, Director, Professional Services Review.
Sorry, what was your second name? What is your second name?
Didio.
I didn't hear it clearly.
Didio.
Yeah. Didn't recognise Mr. Didio from over here.
It's good to see you, Senator.
Same here. Who actually writes the draft and final reports on doctors? PSR lawyers or committee members?
It is the report of the committee members, and they are assisted in the drafting of those reports by the PSR's staff.
Lawyers or staff?
Well, usually they are lawyers, yes.
Okay. To what extent is legal assistance involved in the authorship of such reports?
Sorry?
To what extent is legal assistance involved in the authorship of such reports?
The committee are assisted by the legal practitioners who form part of the support team at the PSR to a significant extent, but ultimately the report is their own. They review the report and ensure that the report contains their views, their opinions and their assessment as to what the outcome should be.
How much of the final reports is written by lawyers and how much by doctors? I know it would vary.
It very much varies, Senator. I can only reiterate that the report is the report of the committee.
So which parts are written by lawyers?
I can't make it clearer. The report is the committee's report. Legal officers assist with the drafting, but the report reflects in a very granular level what the concerns of the committee are, in both a generic sense and in the sense of individual services being reviewed.
The committee members presumably need to collaborate and cooperate if they're to produce a final report together. What form does this take? Is it emails, phone calls, Zoom meetings, face-to-face meetings?
It's something that occurs in a variety of ways. They also have shared access to technology, such as SharePoint and other.
So they might pass the written report around amongst themselves, modifying it, reading it?
There are a variety of different ways in which they do it, Senator. It is their report.
So what's the justification for lawyers writing draft and final reports when the Act states that they must be prepared by the committee?
The committee is provided support services by the agency in order to do their jobs. The report is their report.
So do lawyers ever draft a report or write the final report?
Lawyers have a role to play in the production of that report, and the report is created after a committee has sat for however long it sits for, days, and at that committee hearing, the questions are asked by the members of the committee, and the members of the committee present and clarify their findings with the practitioner under review. A process then occurs whereby a draft report is initiated, but that draft report is based upon an extensive review and analysis of what occurs at the committee and what the practitioners who are members of the committee do and say. So there is a role to be played by the PSR team in the preparation of the draft of that report. But the draft of that report is based upon a variety of pieces of data which are initiated by the members of that committee, whether it is what they said contemporaneously, what they asked, the contents of a transcript. It is the committee's report.
So a lawyer may write the draft, but it'll be after consultation with the committee?
That is what may occur, yes.
Okay, thank you. Are committee members paid for their work in writing the draft and final reports?
Sometimes, Senator, it depends on whether or not they request to be paid for their work.
Whether or not they request to be paid? Okay. So what sort of role does a committee member have? What are they paid for? What are they not paid for?
Georgia Wycott, General Manager. So committee members are entitled to be paid under the Remuneration Tribunal determination for their input into the draft and final reports. It just depends whether they submit their timesheet to us to process that pay. But the Remuneration Tribunal determination is what sets out what they are entitled to be paid for.
Okay, thank you. Assuming that lawyers are not trained in clinical medicine, how can they know if what they're writing is a correct summary of the medical evidence canvassed in meetings? How do you make sure that it's accurate medically?
The committee members do that.
That's the whole purpose, that the committee members conduct their committee meeting, and then they review a draft report at various stages. And they continue to review it.
Last question, Chair. How long has this practice been in existence?
What practice?
Drafting with the lawyers.
I'm not sure. I suspect it's been many years.
Okay, thank you.
Senator, can I just comment? The practice that Associate Professor Didio is talking about is absolutely common practice throughout probably all parts of public administration, where multidisciplinary teams with different aspects will help in the preparation of documents, but there is an authorised person or persons that is actually accountable for the output. In the same way, there's many products that are prepared for me, but fundamentally if I sign them off, I take accountability for those judgments. Or any other area that occurs. When I think about other regulators, that's very, very common practice. So what's being described is very common. Finally, that person signing off or that body signing off takes accountability for it, but there are many people who actually prepare the raw materials that go into it.
Thank you, Mr. Comley. What we're concerned about is a number of doctors who've said there doesn't seem to be any accountability, and quite often the reports are errant. Medically, and they haven't been given a fair go. I'm just trying to find out who would sign off on the reports.
But I think that it's been made clear that the people signing off on the report is the Professional Service Review Board. They take accountability for it. They take responsibility for the report, but they are assisted by other people in preparing the raw material before they say, finally, yes, we are comfortable with that output.
So just as you sign some reports, I understand you need to have it legally vetted by a lawyer. Who signs off on the report for the committee?
The committee.
The whole committee? Each of the committee members, or...?
I believe so. I can take that on notice, Senator, but I believe the whole of... It's either the chair or the whole committee.
Thank you. Mr Comley, the reason for my questions is that we've had lots of complaints about the PSRS reports, and they appear to reflect in some doctors' eyes a lack of understanding of what's going on. So we're concerned about accountability. Thank you for your comments.
Thank you very much, Senator Roberts. We will now go to the morning tea break early and return at 11:05, and we will continue in this outcome area for further questions. Thank you. We'll recommence in continuation in outcome 2. And I will pass the call to Senator Ruston.
Thank you. So I just to follow on from the line of questioning in relation to intervening in the market. So in questioning, in question time on the 30th of October, when asked about the statement in relation to intervening in the market, there was a question around would the government rule out the compulsory acquisition of small family practices who cannot afford to bulk bill. Just interested if that was not answered then, whether it can be answered now.
Well, I mean, I might ask the Minister to comment in a second because that's really a matter for government where they rule something out. But I do think the context is quite important here. The ACT is an illustration of what the Minister had in mind, which is that the government has put in place broad-based and universally available incentives, either through the triple bulk billing incentive or the practice incentive payment. In some cases, there may be circumstances where that feels insufficient to stimulate the level of bulk billing that's required. Now, some cases may not be exclusively, but is really the idea of geographic locations where that would occur. We have potentially thin markets, and this actually overlaps, I think, significantly with the work that has been done through the scope of practice review, where Professor Mark Cormack provided a review which included questions about what the right balance of funding in primary care was in terms of fee-for-service versus other forms of blended payments. So we already have blended payments in some locations. I have in particular, if you think about Archos is a good example of that, or some places where you need higher practice incentives to provide higher services in areas that are thin markets. So the question of ruling out, I would leave to the Minister, but certainly in all the discussions I think anyone's had on this, no one has ever raised a question of compulsory acquisition of a small practice. The whole idea would be, what is the funding model that leads to the right access outcomes for a community where broad-based measures across the country have proven to be inadequate? But I may be thrown to the Minister, or so a bit presumptuous for me to throw to the Minister, but...
That's right, Secretary. I don't have a great deal to add to the answer that the Secretary's provided. We are not contemplating compulsory acquisition at the moment. I think history demonstrates there are significant constitutional impediments to this, but as the Secretary said, we are interested in what interventions could be made to improve access in markets where it appears that for one reason or another bulk billing is lower than you would expect given all of the other fundamentals of the Medicare scheme.
Secretary, has there been any consideration of expanding the Canberra model into other markets?
I'd have to check with my other colleagues, but I'm not aware of another proposal at the moment that we're actively considering.
Okay. And if you are, I'm just interested in understanding whether you provided that advice to the Minister that there are other markets, because obviously there are some significant impacts in terms of workforce shortages, competing, the government competing with the private sector, or your family practice in terms of getting access to workforce, etc., that obviously will have to be considered if it becomes broader than the 3 clinics you're referring to. But more generally, has the department provided any advice to the Minister on options to intervene in the market if family practices can't afford to bulk bill, with the exception of the situation in Canberra?
Senator, equally I'm unaware of any consideration of other locations. Obviously the 3 practices in Canberra were publicly announced earlier this year, and were really intended to address the persistent low bulk billing rates in the ACT compared to other jurisdictions.
Can we exclude the ACT and just talk about? I'm only asking about. So after you exclude the ACT, there's a lot of information on the record this morning about that. Have you provided advice to the government more broadly on market intervention? And so the question.
I think as we've discussed, the bulk billing program, bulk billing incentives, triple incentives for the entire Medicare eligible population have only commenced operation in the last 4 weeks. So I think we'd be looking to see the impact of those measures before looking at other areas that might require intervention if there are, like in the ACT, persistent issues with access to bulk billed services for the population. But I think we would, as Secretary said, need to check that right across the department that's the position, that no other advice has been provided.
Okay. So if you could just be clear whether any advice has been provided, advice, briefs, etc., to the Minister in relation to market intervention, with the exception of the situation that has occurred in Canberra.
I think officials will have obviously taken that question on notice so they can check. But can I simply say this, that of course we are making a whole series of interventions across the entire market, and the Minister's made no secret of his determination to lift bulk billing rates. And so
it's going to be for longer.
They do include increases to Medicare rebates, and we are starting to see bulk billing lifting, and that's very pleasing thing, Senator Ruston.
Yeah. I'm just talking about market intervention. I understand you've got a broader message, but
No, it's more just the definitional question, because we are making a series of interventions to lift bulk billing rates right across the market.
So could I ask then, if the measures that you have put in place that we've been discussing them this morning, the $7.9 billion worth of measures, if they don't have the desired impact, have you provided advice in relation to, are additional interventions going to be considered if the $7.9 billion intervention that we've talked about doesn't achieve the desired impacts? Is that what you're saying, Minister, that they will be?
Senator Ruston, we've made clear our plans to lift bulk billing. I mean, they've included so far the 3 largest increases to Medicare rebates in 30 years. So we are on a path to lift bulk billing rates. Additionally, the Minister has made clear that where there are persistently low rates of bulk billing that are difficult to explain given the market conditions, we are willing to examine other options, and we have an example of that in the ACT.
Okay. So can you guarantee that, can you rule out compulsory acquisition?
I think I've said to you that it is not something that we are contemplating at the moment, and that was consistent with the advice provided to you by the Secretary.
So you're not ruling it out, you're just saying it's not being considered at the moment?
We're not contemplating it, Senator.
Okay, thanks. Okay, so can you guarantee that no existing small or family practice will be disadvantaged or displaced as a result of your market interventions?
Senator, we respect practice leadership and their ability to make decisions about the viability of their businesses. Consistent with all of the evidence that's been brought forward this morning, individual practices will make a decision about their own preferences, what suits them, what suits their family, what they think is likely to suit their patients. Our broad purpose is to lift the accessibility of bulk billing so that more Australians can see a doctor for free. We're really clear about our policy objectives.
And that's great, and I quite understand them, Minister, and I think everyone would agree that we need to get easier and more affordable access to primary care. But
part
that
of
wasn't
it is about, I mean, part of it,
finish?
Minister, is about lifting trust. So we had a 6-year freeze that did actually see trust in
Minister,
the system.
Senator Askey, did you have a point of order?
Point of order in the middle of Senator Ruston's question.
Oh, sorry, I didn't mean to. Please, Senator Ruston, go on. I'll come back to it.
Straight over the top of him. We've been trying to prevent that. So.
Yeah, sorry. Yes.
That's okay.
Thank you. And I think the Minister didn't realise that
That's okay. I just wanted
Senator
to
Ruston was still speaking, so you do have the floor to continue.
So, notwithstanding what you've said, and I'm not disagreeing with it, I actually asked you, or asked anyone, a specific question, not about what the intent of the policy was. It was about giving a guarantee that the interventions in the market that are being considered, that they will not negatively impact on existing small and family practices as a result of the government's market intervention. I mean, I understand that you just made the comment that it was around ensuring that where there was market failure that you were intervening, but in the process of doing that, what is consideration has been given to the impact on the family practice, your family doctor and small practices of the market intervention of the government, if that's what it is? Can you guarantee that no small or family practice will be negatively impacted or displaced, that is, shut down, as a result of the market interventions?
I think you may be getting ahead of the policy development process here. Officials have said to you that at this stage, the work that has been done is in relation to the ACT. We'd obviously consider a range of factors about any other additional intervention that the government seeks to make, but I think your question assumes a level of analysis that officials have told you is yet to be prepared for government.
Senator, in terms of the three practices that have been committed to in the ACT, that's against a backdrop of the ACT having a relatively low number of GPs per head of population compared to the national average. So there are 90.5 GPs per 100,000 people in the ACT compared to the national average of 113. So that data does not indicate that the interventions that have been announced by the government would have an impact on other businesses. There is demand for more GP services. It will be meeting demand, not displacing existing services.
Thank you. So I'm just keen to understand how you will ensure that government-funded clinics don't undermine the viability of existing small practices already operating often with thin margins, because we all know that the cost of doing business is very high at the moment, skyrocketing, and, you know, family practices are small businesses. So I'm keen to understand what measures are you putting in place to ensure that government-funded clinics don't undermine the viability of existing family practices?
I think one of the big pressures on existing family practices over the last decade has been the freeze on the MBS. However, I think Ms Shakespeare has given you an answer to the way that the department thought about this in the context of the ACT, which is providing additional access rather than displacing existing arrangements. More generally, though, of course it matters to small practices that we're lifting the rebates. I mean, of course that matters. And we want general practice to be a viable business that can provide good quality services and allow people to access public health care. That is the point of the government's investments that we made in the last term and this term in bulk billing.
Has the government analysed international examples of market intervention in primary care and identified the lessons of that international experience prior to making these changes?
Senator, we monitor international developments in primary care more broadly. I think the Australian system is quite different to a lot of other countries, so there's only so much we can glean from that, but we do always see what we can learn internationally.
Yeah. So it's just really interesting. I mean, is this a significant change in terms of the competition that exists within the primary care market? So we know that there are examples around the world where there is a much larger component of government involvement in the primary care market. So I was just keen to understand whether you've actually analysed the outcomes of that against the changes that have been made.
Not specifically that question, Senator.
Yeah, okay,
I mean, I think our general view, and I say this as a Labor government, is that we think Medicare is the envy of the world. We built it, we'll defend it. We think it is a terrific system.
Okay. So has the department assessed how potential reduced viability of small private practices might impact on things like continuity of care, especially for patients with chronic and more complex conditions?
Senator, I suppose what I'm struggling with is the premise. The government has just injected around $8 billion extra into primary care. And in fact, some of that is directly going to increase the viability or the profitability of practices who were, for example, already 100% bulk billing. Others will encourage them to bulk bill more than they otherwise would. So I just think the idea that a significant injection of funding by the government that's broadly available to every practice who chooses to take it up reduces viability is just not where our analysis would start from.
I'm not the one that made the threat of intervening in the market if practices didn't take up the bulk billing incentive. So that's fine. I'm happy to move on now to the next line of questioning. I'm just refer to the pricing framework for Australian private hospital services.
We've got the right people if you want to ask the
Okay,
question.
great. So I refer to the document pricing framework for Australian private hospital services. Has this been publicly released yet?
Celia Street, Acting Deputy Secretary of Strategy and First Nations Group. No, it's been consultation within the CEO Forum.
Okay, so more generally, so it's just the CEO Forum that's got it? Do they have it under confidentiality? Or could they just do whatever they like with it?
So it has gone slightly beyond the CEO Forum to some other peak organisations. So it is a select but limited consultation.
When it was released, does it have any caveats on in terms of the ability for the people that have received it, how they can use it and consult with it?
It was encouraged to keep it close, but no strict confidentiality.
Okay, so more broadly, the paper outlines the principle that patients must be at the centre of the private hospital system in terms of outcomes. So what consultation has been done with patients on these changes that are being
So as part of the CEO Forum, we do have Consumer Health Forum as part of the CEO Forum. We also have representatives from private health insurance, private hospitals, from the AMA and the like. So that's largely the consultation in relation.
Are you intending to release it more broadly?
So we've gone out to limited consultation. We'll look at that feedback, test it with the CEO Forum, and then see if the paper needs to change. It was deliberately open in some of the items it discussed. So depending on the CEO Forum view, we'll then determine the next step. But at some stage, it's envisaged if this gets traction, there'll have to be a broader consultative process.
Because in the document, it details the implementation plan and some pretty tight timeframes in terms of the delivering the policy intent of this. So it would suggest that there is a fair bit of work and intention in relation to it becoming policy. So I suppose when is the government intending, or does the department or the minister have any idea when the government would be intending to make to transition from being discussion paper.
Senator,
So you go, yeah.
I don't think that we would say that this is the intent of the government. This is very much a consultation document in terms of the conversation within the CEO forum. The timeline set out a timeline that you could potentially implement it. It's in no way government policy.
Yeah. So I suppose the question is, if the government's intention isn't to pursue this, why have you released this paper?
So there's an acknowledged problem in the way insurers fund hospitals, such that some services hospitals make reasonably good money on and some they're losing on, so they have to sort of cross-subsidise to remain viable, and that's been raised as one of the issues. And as hospital viability and overall profitability has constrained, they've started to stop offering some of those services or constraining those services.
Can I just add something to that, Mr McBride, which is, and for you, Senator, the idea of having a private efficient price in the system has been raised by many stakeholders for a number of years. This is not actually a new idea, and it has been largely put forward by some sectors concerned about the implications of bargaining between private insurers and private hospitals and whether that leads to appropriate outcomes in the market. The purpose of this paper is to move beyond the general concept of, if you had, having a private efficient price, to putting more meat on the bones to say, if you were going to have one, what would it look like, is the first question. And then secondly, if you were going to have one, what would you use it for? Because the paper makes it clear that there are a wide range of uses for it. At the light touch end would be you would have it simply to provide a pricing piece of benchmark information, which would have no implications other than would provide publicly available information which may inform the bargaining process. Second approach might be that it provides some floor under bargaining, which is very similar to what we have under second tier defaults. Or the third, it would actually be, and this is advocated by some in the sector, would actually be the price contracted between private insurers and private health. So the purpose of the paper is to take an idea that's been around for a long time, raised by stakeholders, and tease out what would it look like in practice so that informed stakeholders can look at it and say, is this idea worth pursuing further, when it's actually, you can see it warts and all. Because as you would appreciate, Senator, many times when we're doing policy, people are comparing the messy reality of what currently exists with an idea that hasn't been fully fleshed out. And when you flesh out an idea more fully, you get a comparison between something that's more comparable, which is the real life complexity of the current system with the complexity of a potential system. So the government hasn't made a decision that this is government policy, but we think it helps the policy development process to flesh out the idea more so that stakeholders can react to it. And we fully expect that the more it's fleshed out, some stakeholders may become more enthusiastic, some stakeholders may become less enthusiastic as they think through the implications of that. The timeline, as Ms Street said, is again really in the, if you were to do this, what is the type of time frame that would be required? Because again, I don't think any stakeholders are saying that. Some could say, can you turn this overnight? And I think what the paper makes clear is that even if you decided that you were doing this as a matter of policy, it is quite a significant piece of work to bring it to an implementable initiative.
Thank you. I mean, essentially what this seeks to do, if you pursue what you're talking in terms of a private, nationally efficient price, is to basically replicate in the private system what already happens in the public system. So I think there'd be an awful lot of people out there that would be terrified at that as a concept. But anyway, I'll look forward to watching with great interest, and we'd be really, really encouraging that maybe you broaden your consultation a little bit more, because this potentially, from my reading of the document, if you pursued what is being proposed or considered in this document, would be a massive, massive change into the private health sector with massive consequences for Australia's private health system. So I think I would be recommending that you be very careful about where you go to with this and make sure that you've got all the advice and not just restricted advice. Can I just quickly circle back on some questions that were asked this morning in relation to accessing treatments for Crohn's disease? So just circling back from this morning, I just wondered, can you clarify whether a gastroenterologist can prescribe a biologic as an initial treatment for a patient with severe Crohn's disease if they deem it clinically appropriate?
Senator, the current listing on the PBS is that's a third-line treatment, so there's other treatments that need to be tested first. But this is an issue that's currently subject of discussion by the PBAC. It's listed on the agenda for their 10th of December meeting. And so we anticipate that this is an area where there is active discussion about the appropriate way in which drugs for Crohn's disease are provided and the restrictions that are that guide clinicians in their in the way in which they use these treatments.
Is there a specific criteria that prevents a specialist's clinical judgment from being sufficient to actually prescribe a course of treatment that is already approved and available?
Can we just, Senator, please confirm which treatment you're referring to? I think we've got several that might be on the PBS for this condition.
Well, we're talking about moving immediately to a biologic as opposed to... I understand there's a number of treatments that are available for Crohn's disease that are approved on the PBS. So I'm just interested, if a gastroenterologist actually made a decision that they thought that it was the appropriate treatment for their patient to commence their treatment for Crohn's on a biologic, Mr. McIntyre said that couldn't happen. I was just interested to understand if there is a specific criteria. I mean, what is the basis for that?
The PBS listing criteria is set out in the PBS legislative instruments, and that determines whether or not a PBS subsidy is available for a medicine prescribed. So it doesn't actually stop the prescription of medicines if there isn't a subsidy available. But I think if we should really be clear about which medicine it is that you are asking about so that we can just make sure that the advice we're providing you is correct.
But just to be crystal clear, I think your question was, could the gastroenterologist prescribe it? And as Mr. McIntyre said earlier, there is nothing that would prevent them from prescribing it as a first-line treatment.
But they'd have to pay for it.
But it would not be subject to a PBS because the PBS subsidy is based on the criteria that the PBAC has identified, which is designed to take into account the evidence about the likelihood that first or second line treatments, which may be more cost effective, would actually be appropriate.
Yeah. So my question is that you're making that decision about whether they could be more cost effective if the gastroenterologist is the one, at Illumab or something could be an example of that. What is the criteria that you are using that is saying that the advice of the gastroenterologist is insufficient for the prescribing of a particular treatment for Crohn's disease, that you're saying, no, you have to go through A, B, C, D, E and F, and if they all fail, then we'll let you go to that? What is the criteria that enables that? Those
criteria are based on advice from the Pharmaceutical Benefits Advisory Committee, which advises the government under the National Health Act about which medicines should be listed on the PBS and in what conditions. And that's based on an assessment of evidence usually brought forward by the sponsor of the medicine about the comparative safety, comparative clinical effectiveness and comparative cost effectiveness of that treatment.
Perhaps on this one, the CMO might want to comment, who's also been a PBAC member, so bring both a clinical and a PBAC perspective.
Yeah, happy to do so, Senators. So as an individual clinician, you can make prescribing decisions based on your clinical judgment. That's done obviously in consultation with the patient, or in the case of a child, with their family members, weighing up the risks and benefits. These biologic medications that you're alluding to, they target the immune system to decrease inflammation. They can be very helpful in the symptoms of inflammatory bowel disease like Crohn's disease or Crohn's colitis. They can cause side effects in some people, and so that clinical decision is based on balancing those risks and benefits. You may also use clinical guidelines. Now, clinical guidelines may provide different information to the PBAC guidance, but they can help in making clinical decisions as well.
Okay. So is the department aware that patients, and particularly children in this instance, are experiencing permanent intestinal damage and scarring during the period to prove that they're actually sick enough for compassionate access? Are you aware of that?
Senator, we really are going to have to check the particular listing, and I think you mentioned adalimumab.
I've got a whole list of them here, which I'm sure I can't pronounce.
So to work out whether or not it's available for paediatric patients on the PBS, those are the things that I would like us to check to make sure that the information we give you is accurate.
Okay, but it doesn't actually matter what the listing is, in the sense of Mr. McIntyre said that there were you couldn't move to a biologic treatment as the first treatment for Crohn's disease. So all I'm seeking to understand is why, if this is the most effective treatment, why it is being denied, and we have got a situation. And so the question is not about the treatments. I'm saying, is the department aware that patients, particularly children, are incurring lifelong damage during the period that they're required to go through all these series of other treatments before they're actually able to get to a treatment that they clearly have to be sick enough to be able to get, despite a gastroenterologist having suggested that access to this other treatment, which you've said they can get if they pay for. So are you aware of that? That's the simple question. Are you aware that that is occurring?
Senator, PBAC, the clinical committee, responsible for these recommendations, considers a full range of evidence, and while we would need to confirm the specific evidence that has been considered by the committee, it is usually the case that they would have a full range of studies related to the disease. So we will need to confirm the precise evidence that they have considered, but they do their very best to consider a full range of clinical evidence as well as patient outcome evidence, and they debate the impact that different courses of treatment have on the health sector, including on treating clinicians and on patients and their families. So we in the department respect the advice of the clinical committee about what the best source of treatment is, and the information about their deliberations is published, and we can certainly provide you on notice with links to the specific times that these matters have been considered by the committee and the evidence that they considered when making those deliberations.
So simple question, is the department aware of the circumstance that I just raised or not?
The department, through its clinical committee, has considered a wide range of evidence. We would need to confirm on notice the precise evidence that has been considered.
So, given that we have evidence, obviously you'll need to confirm your own evidence, but we have evidence that permanent intestinal damage is done from delayed treatments, and this particularly occurs in children, which requires lifelong management. Has the department or PBAC in its processes done any cost-benefit analysis of comparing what the outcome of early access to biologics would be in terms of the lifetime costs of the damage that's done in the intervening period when they aren't be able to get access to them? I'm assuming that's part of the PBAC process, and if so, are we able to get access to that?
Senator, yes, I can confirm that PBAC has considered these issues. They considered them twice in 2024. They're currently considering issues related to these matters. We can, on notice, provide you with an understanding of the scope of the issues that they have considered, which will relate to those issues that sponsors have expressed a willingness to list for. But we can't outline today without, we'll have to do it on notice.
That's fine. Understand. Yeah, I'd just like to understand, because I mean, obviously the PBAC process is the cost-benefit analysis. It would be really interesting to have the opportunity to have a look at that. I'm just wondering, is Australia's approach to restricting initial access to biologics for Crohn's disease consistent with other OECD countries' approach to this?
Senator, it is quite challenging to compare Australia's system to others. There are a whole range of differences in the way we do it. In particular, one of the great strengths of the PBS in Australia is that there is a common approach across most patients and clinicians because of the common way in which the PBS negotiates for drugs. That can make it difficult to compare our system to others. But my understanding is that the situation for many years has been that biologics have been a third-line treatment, but that this is an issue where there is...
Around the world?
Yes, Senator.
Okay.
But this is an issue on which there is emerging evidence which is now being considered by a range of HTA processes, including ours in Australia.
Okay.
Just if I may, Senator,
Yes,
my understanding is that the NICE guidelines, which are used in the UK and the National Health Service, lists the biologics as third line currently. But
Okay.
I'll need to recheck it. But that's the advice
So
I have.
just to be clear, Professor Kidd, I'm really keen to understand if comparable countries allow specialist gastroenterologists to prescribe biologics as a first line. It may well be a third line under normal circumstances, but in circumstances where the gastroenterologist believes that it is the most appropriate first line treatment, how is that comparable internationally? Not whether it's a first or a third line treatment more generally.
And I assume your question for us to take on notice is first line treatment that is subsidised under their system?
Well,
because
in the case that the comparability in terms of subsidisation is probably a little more difficult, but it's around whether yes, I suppose that makes sense.
Well, we've already given evidence you
yeah.
can use it as first line treatment here if you're not seeking a PBS subsidy. So the comparability is the subsidy regime in the other country.
The comparability is the subsidy regime, but I mean it's about whether a specialist can recommend it for that purpose as opposed to whether it's listed.
As we discussed earlier today when we were on this topic, it is possible for medicines to be funded through drugs and therapeutics committees of public hospitals in situations where an individual specialist, or in this case a gastroenterologist, thinks that a medicine would be appropriate for an individual patient, but it's not PBS listed for that patient.
Yeah.
Senator Ruston, I'm just checking on how much longer you need.
Very, very, very long answers.
Can we get some indication of time, just so that
Maybe
we need to get
officials? I'm quite happy to whiz through the rest of my questions, and I'm quite happy for you to take on notice anything that has a lot of information. If that would be helpful.
That will be helpful to
great.
the process.
Thank you. So, in terms of the compassionate access component of that, I'd be really interested to know what tests and hoops that you have to go through to get access to that. But thank you for that, and thank you very much, Professor Kidd, for taking those things on notice. Can I just quickly ask you? Obviously, the executive order that was signed by the President of the USA, delivering most favoured nation prescription drug pricing to American patients, I'm assuming you're aware of that?
Yes.
Yeah, okay. So I'd be interested to understand what the government, or through what advice or what analysis the department has done about this policy and its implications in Australia. Do we have any advice that you could provide?
We have provided advice to the government, Senator. Would you like us to tell you about the dates on which we provided that
No,
advice?
that's fine. I was just going to ask the Minister, is there any possibility that maybe you could, that we could have access to have a look at what the implications of that particular executive order is?
I think it's best if I refer that to Minister Butler. Sure. I think you're asking for something outside of the estimates framework, and I'm sure, as you know, he's often...
It's not outside the estimates framework. It could have significant budgetary implications.
What question are you asking me?
So I'm just interested in the advice that the department has provided the government in relation to the implications of this particular executive order, and specifically in relation to, obviously, access and price.
I'll take that on notice, Senator Ruston, for all the obvious reasons, but I will also make the point that this is essentially a DFAT issue because it goes to our trading relations, and so they are, of course, appearing today. So if you did want to talk to them about it, they're here.
Yeah. I'm speaking in relation to the impact on access to medicines and cost of medicines as opposed to the trade implications of this.
Senator, perhaps I can add to that, to just note that the PBS has built into its processes opportunities for sponsors to seek increases in their price should they have the view that their costs have increased and that an increase in price is warranted. There are processes that allow them to do that. There are also processes that give them the opportunity to bring forward to delist medicines in circumstances where the sponsor no longer feels it's economic. And I'd note that we haven't seen a substantial change in the patterns that we have seen for those delists and price increases, but we continue to work with a range of companies and consider those requests where they are made.
Yeah, I don't necessarily think that's what I was talking about, Mr McIntyre. I quite understand that that's the normal process. So I'm just interested, where's the health technology assessment review at in terms of its implementation? I believe we're reviewing the review, and what's happening to it in relation to these latest developments and the necessary commentary we've seen around the processes that are undertaken in Australia to list drugs?
The government asked a implementation advisory group chaired by an eminent expert in the area of HTA, Professor Andrew Wilson, including consumer representatives, industry representatives, state government representatives, to provide a roadmap for implementation of the many in number, but also in complexity recommendations out of the HTA review. That group has been meeting very frequently this year. It's been, I think, had 11 formal meetings and other out-of-session meetings, and it is very close to providing its advice to the government.
I've heard that story about 100 times before in relation to this particular review, and I've heard it along many other reviews. So I'm not sure meetings actually deliver outcomes. We'd like to actually see something happen from it. So I'm just keen to understand. Obviously, we saw earlier this week the arrangements that were signed between the UK and the US in relation to favoured nation status. I'm just wondering, have you analysed what the budgetary impact would be if a similar sort of agreement was required from Australia? Has the department modelled that?
The Australian pharmaceutical benefit scheme is very different to the UK arrangements. I'm just not sure how we would even go about modelling if you took the same approach here. So we are looking at the impact, as Mr McIntyre said, in terms of approaches from companies, if they might be seeking price increases. We're monitoring the number of applications that we are receiving to the the Pharmaceutical Benefits Advisory Committee for new listings, the number of new listings we see each month. As Mr McIntyre said, we haven't seen an impact on the PBS, and we're continuing to monitor that.
Okay, so I'm really quite distressed to think that the department hasn't even tried to have a look at what the potential impact of this could be on the budget bottom line.
Ruston, I don't think that that's the evidence that Ms Shakespeare has provided.
Oh, sorry, that was what I heard. Would you like to... I'm happy for a reconfirm.
We've actually spent a lot of time thinking about this issue and doing analysis on what would happen. It's a complex issue. You've asked for our advice that we provided to government on that. We've taken on notice, and I think the minister has said she would refer it to Minister Butler because you're asking for something that ordinarily would not be provided, the content of advice to government, in what is a substantial and evolving issue. I think that what Ms Shakespeare was referring to is that, yes, you could do a simplistic costing, which is if you move to a certain proportion of GDP that went into pharmaceuticals, similar to the commitment of the UK, and you had an understanding of what the split between the private and the public component of that, you could work out the cost of that. But clearly, the government has a whole range of other options before you consider such a kind of blunt instrument, and they're the issues that we're thinking through. But I just would like to assure the committee that as a department, we have spent an enormous amount of time thinking through these issues and have engaged very deeply with many companies directly and the peak bodies of the industry on the implications of the MFN issue.
Are you concerned that the delisting of PBS medicines could be a possible or likely outcome?
We are concerned always for access to medicines into the Australian market.
Mr Comley, I'm specifically talking about this. I mean, I'm sure you are concerned more generally. I'm asking you specifically about this particular executive order. Are you concerned that the implications for Australia of the application of this executive order could result in the delisting of PBS medicines in this country?
We're monitoring the situation. As I said, what Mr McIntyre indicated is that we haven't seen evidence of that accelerating at this point in time. We are engaging directly with many firms who are talking about the possibility of that, but of course there are commercial issues they will have to deal with as well, because as we all know, in the issue of pharmaceuticals, often the cost of manufacture is quite low, and therefore if you decide not to list in a market, you are making a commercial decision to not take revenue that you would otherwise earn. So we're watching very carefully this issue. We're not taking it lightly, and we're trying to look at all signs as to how this is evolving.
Because obviously the greatest concern is Australians' access to affordable medicine. So can I just ask about some changes, the Medicare item changes in relation to hospital-only services?
Can you just repeat the last part? So I didn't.
The hospital-only services. There were some changes in March this year in relation to that.
Senator, I'll get my colleague to give a bit more detail, but we have been reviewing an historical part of Medicare where...
Sorry, I haven't asked a question.
Go ahead.
But thank you for your proactive approach, Mr McCabe.
Thank you.
I think that was his opening statement.
So I was just wondering, can you confirm that the changes to the MBS that came into effect on the 1st of March in relation to this measure had total savings of $72.3 million? Is that correct? Just trying to...
Senator Louise Riley, Assistant Secretary, MBS Policy and Reviews Branch. The changes that came in on 1 March this year, over the estimates, the save was just under 53.7.
Okay. I shall go and reanalyse budget paper number 2. Because mine, it says, I thought it said 72.3, but anyway. So have I understood correctly that a patient who previously was receiving one of these treatments that these MBS items apply to, as an outpatient, now must have it performed in a hospital, has to actually pay 25% of the out-of-pocket costs rather than 15% if the treatment was received privately.
So, Senator, what I was probably going to say before was we've done an analysis of MBS services that clinically should be done in a hospital setting. We had an anomaly in the way the schedule has been designed over many years that paid what was known as out-of-hospital benefits for services that should be undertaken in hospital settings. Where those services are claimed in a hospital setting and patients are treated privately, their private health insurance would pay the 25%.
Okay, so what if they weren't privately insured?
Then they would be public patients.
Okay, so in terms of the out-of-pocket costs performed in a hospital, you're saying that the patient doesn't have to pay 25% out-of-pocket costs?
If the patient is not privately insured, Senator, and is funding the care themselves, they would have to pay.
Okay, so they do have to pay 25%. So they can either, they're a public patient, if they can get access, they pay the 25%, but previously they were paying 15%. Is that correct?
So I think it's probably important to go to the point around the clinical safety elements, Senator. What we were worried about was those services being performed outside of hospital settings.
Yeah. I'm just trying to understand the out-of-pocket cost to the patients. So if the treatment was conducted in a public hospital, that obviously means the state and territories pick up the cost?
Those services should be funded under the NHRA, Senator.
Yep, okay. Well, that's another story. How many people each year typically access services that are subject to these changes?
Senator, I don't have those figures, but I can certainly tell you that in the 1 March changes, the number of MBS items that were reviewed were 965. Of those items, 833 of them had the 85% rebate removed.
Okay, thank you. Just quickly, newborn blood spot screening. Have we had any movement on Pompe disease, or is it still not intended to be listed?
Good morning, Senator. Liz Devlin, Deputy Secretary from the Department. As you're aware, that has gone through the MSAC process. It is yet to be considered by ministers as part of the decision-making pathway.
So when did it go through the MSAC process?
The date it was published, we will find for you.
Sorry, Senator. Melissa Caldo, Acting Assistant Secretary, Screening Policy Branch. So at its second and third meeting in April, MSAC considered Pompe disease.
So the recommendation not to list Pompe disease went through MSAC on what date?
The 2nd and 3rd of April it was considered.
2nd and 3rd of April.
That's correct.
Okay. And the determination as to whether it be listed on the newborn blood screening list is a matter for the Minister?
It will now progress through the decision-making pathway. So it has gone through, so MSAC's made its recommendation. It now then progresses through to our Cancer and Population Screening Committee, then our HSEF, which is our Health Chief Executive Committee, and then Health Ministers. So yes, it is a decision of Health Ministers.
So 3.5 years ago, the Prime Minister, who wasn't the Prime Minister at the time, held up a baby with Pompe disease and said that, you know, no more lottery, this baby and every other baby will be tested for Pompe disease. 3.5 years later, we still have no further movement, apart from MSAC have actually defied the Prime Minister's commitment to the Australian public and every mother by saying that we shouldn't be putting Pompe disease on the list. So when do you expect, or maybe Minister, when do we expect that the Prime Minister's promise to mothers, and particularly that mother with the baby that had Pompe disease, when is she going to know whether the Prime Minister has kept his promise?
Senator Ruston, officials have given you an indication about the work that's being done through the formal processes of the department. I don't have anything to add about Minister's consideration. If I have anything, I'm sure the Minister can update you directly.
Thank you. And
sorry. On that one, so we're expecting in the first half of 2026 it will be considered by health ministers.
Okay, so 4 years later we might even get an answer. Okay. Intravitreal eye injections. Last topic, Chair.
Thank you, Senator Ruston. Noted.
So I'm just wondering if you could break down the cost for an IVI procedure done under MBS item number 42738.
So we don't have that with us, Senator. We have to take that on notice.
Okay. So what are the current out-of-pocket costs for patients, and how much? Well, so you don't have any information. And so on the 1st of July, that particular item number, 1st of July 2026, because I think the Minister prolonged it for a period of time, are due to be reclassified from MBS type B to MBS type C procedure. Do you not have any information on that?
I mean, that's correct, Senator, that the government has deferred the proposed change of that MBS item number to a Type C procedure to 1 July 26. I don't have the details you're asking for in terms of the breakdown of that item at the moment, but we can take that on notice.
We've received an incredible amount of correspondence from people that are concerned about the proposed changes in terms of the out-of-pocket costs that will be incurred by people when on the change of this procedure. And I would acknowledge that the Minister obviously has had those too, for the reasons that he's extended the change time by a year. I'm just interested what action is being taken in this intervening period this year about making sure that these out-of-pocket costs will be pushed onto patients, because previously obviously they were able to claim them from their private health. They now no longer will, so their choices are either pay significantly more out-of-pocket costs or join the line at a public hospital, which is not necessarily going to be great for either the person or the public hospital. So what action is being taken by the department to make sure that we resolve this in a way that is not counterintuitive either to the budget or the person?
Senator, the department issued a consultation paper on this last month, and that closed for consultation submissions last week. So we're at the process of going through the submissions that have been received on that, and we'll be providing advice to government for them to consider.
And more broadly, Senator, we have been organising discussions between consumers, specialist groups and their representative organisations to talk about action that we need to take more broadly to address out-of-pocket costs for specialist services.
Yeah.
The extended Medicare safety net review or report that we undertook last year, there's a lot of work happening at the moment to think about what we need to do to address out-of-pocket fees for specialist services, including these types of services.
So currently under private health insurance laws, under current government laws, private health insurers can't cover out-of-pocket costs for MBS services for procedures performed out of a hospital. That is correct?
Correct.
What's the rationale behind that?
I understand that provision in the Health Insurance Act stems from the creation of Medicare in the early 1980s. And
That's a long time ago.
Yes, and I think it was designed to ensure that we had a universal system of coverage under the Medicare benefit scheme arrangements for out-of-hospital services and not differential access depending on whether or not people had additional private health insurance. Private health insurance was retained for in-hospital services.
Well, I look forward to how you deal with the conflict that exists here in terms of the efficiency of the procedure outside of a hospital system and the additional costs that will either be most lower and the additional costs that will be placed on the consumer. Because at the end of the day, this is all about the out-of-pocket costs for consumer. But
Well, I think that's right, Senator Ruston. And look, the officials will know a great deal more than I do about the particulars of this, but I understand that the deferral is precisely so that we can understand the impact on patients and to actively look at options for supporting access to affordable treatment.
Well, interestingly, Minister, the MBS review actually stated that this reclassification, and I will quote, will not impact on public patients, but this reclassification occurs, won't it be pushing private patients towards public facilities? Because, I mean, if you're all of a sudden every 40 days $250 out of pocket, I would imagine that, you know, given this is a largely older audience of people who are receiving this particular treatment, they'll be forced to turn up to public facilities. So I'm interested to understand how that doesn't impact on public services.
Senator, it's probably important to note that depending on the clinical circumstances of the patient, they can still be treated in private hospitals.
Yep. And that's fine. They can go and be treated in private hospitals. At what cost?
With your private health insurance.
Yeah. But so the most efficient place you have determined, it's perfectly safe for this to occur in a clinic surgery setting. So anyway, that's fine. I'm just looking forward to making sure that these people that rely on these particular treatments are still able to access them affordably, and I'm sure that your process will deliver that. So thank you.
You're finished, Senator Ruston? That's great. That takes us to the end of outcome 2 on individual health benefits, and we say goodbye to those witnesses. We are going to suspend for a short time while we call our next round of witnesses for outcome 4 in disability and carers. We'll get back on broadcasting. Thank you. I now call officers from the Department of Health, Disability and Ageing in relation to outcome 4, disability and carers. Minister McAllister, you flagged with us earlier that you had an opening statement relevant to your portfolio, so I'll give you the call first.
Thanks very much, Chair, and I appreciate the committee providing the opportunity to say a few words. I'll try and keep it brief. The Albanese government is committed to the NDIS as a world-leading part of Australia's social fabric. We are focused on ensuring that a sustainable NDIS can continue to provide life-changing supports for people with significant and permanent disability. So one of my priorities in this portfolio is improving the participant experience within the scheme. The NDIS review identified that the current approach to planning is inconsistent, confusing and cost-intensive, and they recommended a fairer approach that is easier to navigate. The NDIA is continuing to work with the University of Melbourne and the Centre for Disability Studies with disability representatives and participants to develop the new approach to planning. The new approach will deliver fairer, more consistent and more transparent outcomes. It puts a semi-structured conversation between a participant and an assessor at the heart of that planning process. This will be a strengths-based approach that understands each individual NDIS participant's disability support needs. And the process will be collaborative. It will provide opportunities for participants, their families and supporters to ensure that the information is accurate. It will give participants greater clarity and confidence in how their disability support needs are assessed and funded. Now, I know that there is more work to do here. I want to thank the disability representative organisations and the disability advocates for working with us as we are developing this new planning framework, and we are committed to working through these changes with the disability community and the states and territories before they are rolled out in mid-26. I also want to emphasise that the scheme must operate with safety and with integrity. Those who defraud the NDIS are stealing from the hundreds and thousands of Australians who rely on the life-changing support that the NDIS delivers. An updated statement of expectations to the NDIS Quality and Safeguards Commission outlines my priorities to uplift quality, ensure safety and take a hard line on fraud in the NDIS as their regulatory approach matures. I've also recently introduced a second bill focused on integrity and safeguarding, which is currently being considered by the committee. Generally and broadly, our government is committed to tougher penalties for misconduct and unsafe practices, as well as strengthening the monitoring, compliance and enforcement powers of the NDIS Commission. I welcome the release of the annual financial sustainability report from the NDIA, and the report indicates that the NDIS continues on a pathway to sustainable growth in line with the sustainability framework set out by National Cabinet. This is a sign that the government's initiatives to achieve sustainability are working. Meeting this target matters. It will ensure that the NDIS can continue to provide life-changing outcomes for future generations of Australians with permanent and significant disability. Any further reforms will be developed with participant outcomes and safety front of mind. We continue, of course, to work to establish a unified system of disability support that sits outside the NDIS for people with disability across Australia. The goal of Thriving Kids, our focus at the moment, is to strengthen that layer of support so that children aged 8 and under with mild to moderate support needs and their families can access supports in a timely, straightforward manner. And this also is in line with the NDIS review findings. Finally, I would like to welcome Graham Head as CEO of the NDIA. Mr Head brings extensive experience in social policy and public administration, including his previous role as NDIS Quality and Safeguards Commissioner. His leadership will be crucial during this period of reform to strengthen the NDIS and put participants back at the centre of the scheme. And I thank senators and members across the parliament for your continuing collegiality and collaboration. I do think that the disability community wants to see us working together to support them, and I look forward to working with you across the parliament to ensure we're reaching the best possible outcomes for NDIS participants and the broader disability community. Thank you, Chair.
Thank you, Minister. Can I also echo and welcome to the desk this afternoon the new Chief Executive Officer of the National Disability Insurance Agency, Mr Graham Head, AO, and also the NDIS Quality and Safeguards Commissioner, Ms Louise Glanville. Mr Head, would you like to make an opening statement?
I don't have an opening statement prepared to make this morning, but I echo the comments of the Minister, and I'm very pleased to have been asked to take on this role, having had a deep interest and involvement in the scheme for a long time, particularly during my period as Commissioner, so it's good to be back.
Thank you. Ms Glanville, would you also like to make an opening statement?
I don't have an opening statement to make, but I would like to note that Associate Commissioner Natalie Wade has had to remain in Adelaide today, and I think she will be joining us online as needed, so thank you.
That's great. And thank you for both joining us this afternoon. And I will now invite questions from senators, and I believe Senator Ruston has some questions.
Thank you. Just wondering when the plans for the Thriving Kids program are to be presented in, I'm assuming in some sort of draft model to the states and territories.
Well, so Senator, we've been engaging in constructive discussions with the states and territories on foundational supports and Thriving Kids. Well, in the construct of foundational supports for, well, it's actually almost 2 years now. And in the context of Minister Butler's announcement, Thriving Kids, ever since then, we've been engaging with the states and territories. So they are, in fact, co-designing the Thriving Kids program with the Commonwealth and have been doing so over the last few months.
So do you have an answer to my question, or is that you don't know?
Well, no, I suppose the premise of your question, which is the Commonwealth is going to present a plan or the final Thriving Kids program, is not the way it was being done. The Thriving Kids program is being developed in collaboration with the states and territories, but it is also building off the previous work on foundational supports that has commenced, been going on for 2 years with states and territories.
Well, I think the federal government did present Thriving Kids to the states and territories, because when it was announced, the states and territories didn't know anything about it. But so when the model is in, at what stage and when of the development of this model will it become publicly available for?
Well, that's still subject to the Commonwealth state negotiations as to when they'll move to public consultation. But I do note that there are two processes, there are three processes really currently running. Obviously, I mentioned the Commonwealth state negotiation. The second is that Minister Butler formed the, well, it's co-chaired by himself and Frank Oberclade, who is a prominent paediatrician. And there is an advisory group around that, which includes experts, it also includes lived experience representatives, and it includes two members who've been nominated by states and territories, and that's so that states and territories can both bring their service delivery expertise to the table, but also to ensure that there is no information gap between what's happening on the Oberclade Committee and the Commonwealth State design process. And the third process that's currently being undertaken is there was a parliamentary inquiry that was commissioned or commenced that is co-chaired by Mike Freelander and Monique Ryan. That has been taking public sessions on the ideal design of Thriving Kids.
When's that due to report?
I don't think we've got a specific date, but it's imminent. They have received when.
Excuse me, Chair, through you. I mean, I really appreciate this information. It's information that I think is on the public record already, and I know the Chair is really trying to make sure that we keep this to the time. So I just very respectfully be good if you could just answer the question. And I mean, I appreciate you want to give extra information, but we're not going to get through this.
Well, with respect, I think it is relevant because your question was about the level of public consultation and the parliamentary...
No, I asked when it was going to be released.
Yes, well, I said the question of when released implies there's one document that will be released. We're co-designing with states and territories. There will be some variation, it's likely, between designs in states and territories, and so it depends at which pace we reach agreement with states and territories on the nature of the program.
Is funding for Thriving Kids still dependent on the delayed NHRA agreement being finalised?
As we discussed yesterday briefly, the agreement to the NDIS reforms that was put in the National Cabinet meeting of 2023 and the NHRA are linked in a joint negotiation with the states and territories.
Yeah, so, but I'm just trying to understand, so, well, maybe question step back. Are Thriving Kids, or is the Thriving Kids program a foundational support?
So Thriving Kids is part of foundational supports. From the December 2023 Cabinet discussion, there was actually $10 billion set aside.
How much?
$10 billion set aside for foundational supports, which was 50-50 match between the Commonwealth and the states. Of that, the initial $4 billion was considered for the target of children from 0 to 8, which the Commonwealth would consider Thriving Kids.
Okay, so the $2 billion of that $5 billion
of the Commonwealth component.
Joint contributions, yeah, so 2 and 2.
Yep.
So Thriving Kids is the response to that particular part of the foundational supports work.
That is the intention at this
Okay,
stage.
so therefore, because foundational supports are tied to the NHRA by virtue of the fact that Thriving Kids is a program that sits within foundation supports, it's
We're
tied.
trying to negotiate a joint deal with the states and territories.
Thank you. That makes it clearer. I'm just interested in terms of the changes in relation to foundational supports. What is the assurance in relation to no worse off? Is there an assurance around no worse off?
No worse off is not directly related to Thriving Kids. The December 2023 decision had a commitment that the states would be no worse off overall as a result of that deal.
The states?
The states and territories.
Oh, sorry, I'm thinking more of the participants. The no worse off principle in relation to, so if you're one of the people who would fit into the Thriving Kids program, also are children who would fit into the Thriving Kids program who are currently on the NDS, will they stay on the NDIS or will they move to Thriving Kids?
The Minister has been very clear that the word he uses, we don't
want... you were the Minister.
But Minister Butler is leading on Thriving Kids. He made a speech at the National Press Club and has spoken about it on other occasions. Minister Butler describes it this way: he doesn't want anyone to fall between two stools. And so he has indicated that children who are presently on the scheme will remain on the scheme, subject to the usual reassessment processes which have always been in place for scheme participants.
So a standard reassessment process that would happen automatically if at that time it became apparent that that particular person would be better suited to move to Thriving Kids. That could happen at that time.
I think Minister Butler has made the point that there will be access changes to the scheme, but he wouldn't seek to put those in place until we had the foundational supports or the Thriving Kids program in place. And he was very clear about that at the National Press Club.
Yeah, I understand that, but I'm just sort of trying to understand in terms of the design of it, in terms of the no worse off principle. If children that are on the scheme at the moment, the NDIS at the moment, and receiving the supports that have been determined, does the scheme design or does the NDIS design enable or facilitate that they could, at some point in the future, under the normal review procedures that the NDIS or the NDIR conducts, move from the NDIS into Thriving Kids?
I think I'll ask officials to talk this through with you, Senator, but the reassessment process isn't designed to test for eligibility for Thriving Kids. It's designed to test for scheme access.
Yeah,
Okay, so
Ms Shannon can comment, but there is currently a rolling reassessment of children to see if they're available. At the moment, if they left the scheme, there wouldn't be a Thriving Kids program available. The intention is to gear up a Thriving Kids program broadly commencing on the 1st of July 2026 and being fully rolled out by 1 July 2027. Would you like to comment? Ms Shannon.
Robin Shannon, Deputy Secretary, Disability and Carers. I mean, just to add to the Secretary's response, as is currently the case, children are regularly, they're reassessed at certain points in time, and some children, particularly those who come through the early intervention access criteria for the scheme, at the point of reassessment are found to have benefited from early intervention and
no
exit
longer
the
need it.
scheme.
Yeah.
So
what happens to them now?
So now they would exit the scheme and they would access mainstream services.
Okay.
So in effect, we're improving
Well, if
the
they
mainstream.
are exit for mainstream services, why do they need Thriving Kids if the mainstream services are available to them?
They may not need Thriving Kids. Yeah. They may benefit from some elements of Thriving Kids.
Okay, cool. All right, thank you. That's obviously the outcome we're wanting for young people.
We would hope children benefit from investment
absolutely.
in early intervention.
Yeah. So, Minister, there was much media speculation at the last Disability Reform Council, whatever it's called, that you were asked to leave the room while the states and territories discuss matters. Is there any, I mean, obviously I think the public probably drew from that there was concern in the negotiations. Are you confident that negotiations in relation to your part of this in getting the states and territory disability ministers to agree to the reforms are going to be finished in time to be able to provide that piece of advice to Minister Butler as he goes into the major reform negotiation?
I think for clarity, Senator, the negotiations are being conducted through specific arrangements that have been put in place consistent with the broader negotiation about the health agreement. The DRMC has a different role and an important role with a range of tasks that are important to the disability community, including implementation of recommendations from the Disability Royal Commission, discussions around provider viability, actions to crack down on fraud. Those are all matters that are tasked to the DRMC, but the negotiation around both Thriving Kids and the hospital agreement is occurring in arrangements that are specific to that negotiation and discussion.
Okay, obviously nothing to worry about by the sounds of things. Could I just ask a few questions around the disability accommodation issue in Victoria? I think there's 5 organisations. Homes owned by the Victorian Government.
I think if you, unless you want to have Ross.
I think your people.
You can take it? Okay.
Because it's Penelope's.
I think we've got the right people at the table, Minister, if you'd like to ask the question.
Okay, cool. All right, see how we go. So, obviously, yeah, this particular issue has been the subject of media debate in Victoria. So, just wondering, well, first of all, that the department and the NDIA are aware of the current issue with the funding of disability group homes in Victoria?
Yes, Senators. Deputy CEO Scott Norton, yes, we are aware of it, and we've been working closely with the Victorian Government, the large providers of the SIL homes, and of course the department.
Yep. So my understanding is that we're talking only less than a month away before the Victorian funding expires. Is that correct?
That's correct. That's obviously a decision of the Victorian Government, though, Senator, not one
Sure.
for the agency.
Yeah. No, I'm just making sure that I've got my facts right. So the question is, and it may be to you, Mr. Head, is the funding provided by the NDIA insufficient to keep these services running? I mean, I'm interested to understand how this has come about in relation to the federal government funding to, obviously, the people that are living in these accommodation.
I'm going to let Ms McKay take the question.
Sure.
This is day 8 for me, and I don't want to kind of...
I thought you'd know everything by now.
Skate across the top of important issues like this.
Can I just indicate that I need to shut the call after the answer Ms McKay gives, if that's...
Okay. I was going to say I've got 2 quick questions on this one and then I'm happy to hand over.
Okay.
Yep. Okay, so we've got what finished.
Thank you.
Mr. Cade?
Thank you, Senator. It's Penelope McKay speaking. I'm the Deputy CEO responsible for markets. We've been working closely, as Mr McNaughton said, with the 5 SIL providers. Issues relating to their funding agreement with the Victorian Government are matters that we can't comment on. What we can say is that we've been working closely with those providers. We've been looking at the SIL participants who are serviced by those providers to ensure that their plans are appropriate, and that we, like all providers in Australia, we've set pricing that reflects a reasonable approach to pricing, ensuring that the market is still growing and viable. Of course, there are issues, and we've talked previously about the fact that we want to ensure our pricing incentivises quality. But in terms of the financial sustainability of those 5 providers, we look at pricing and the issues relating to the financial agreement with the Victorian Government and matters for the Victorian Government.
So ultimately, whose responsibility are those 2,000 people?
Senator, I'm using the captions, so
sorry. Sorry, I know you do amazingly. Yeah. So I'm just understanding who ultimately, is it the state government or the federal government that takes primary responsibility for the resolution of the issue about these 2,000 people who face homelessness in less than a month?
So, Senator, obviously the way our scheme operates is that we're responsible for ensuring that participants have plans that are appropriate. In situations where there are provider exits, we work very closely with the Commission to ensure that there's continuity of service and safeguarding around the participants. In terms of the financial viability or the financial decisions that may be made by individual providers or funding agreements they may have with other levels of government, they're matters that we can't comment on. They're about the individual business strategy of those providers.
Have you had raised with you concerns similar to this from any other jurisdictions?
Sorry, I'm just going to intervene. I know Ms McKay's seen me just signal that there are media in the room, and so they've requested permission to take photos of proceedings, and the committee has agreed. I remind the media this permission can be revoked at any time, and the media must follow the direction of Secretariat staff. If a witness objects to filming or photograph, and the committee will consider that request. The media is also reminded that they're unable to take images, senators or witness documents or of the audience. Media activity may not occur during suspensions or after the adjournment of proceedings, and copies of Resolution 3 concerning broadcasting of committee proceedings are available from the Secretariat. Thank you. Sorry, Ms McKay, you can continue.
Did you want me to ask the question again? Yeah. Okay. So, yeah.
Happy for you to keep going, but maybe as a general thing, if the question really is, are we aware of providers raising questions about viability in the SIL sector, then the answer is yes. We get many representations on the issue of the viability of the SIL sector, and we're working very closely with the sector in concert with the agency and the Commission to understand what the veracity of those claims are and what may need to be considered.
So yes, in terms of the sector more generally, what about with any other state-owned homes?
Well, the commission, the agency or commission agency in particular may want to comment, but from my perspective, it's largely been non-government providers who've made those representations outside Victoria.
So it's just Victoria.
The Victorian has the specific, as I'm sure you're aware, industrial issue, which is slightly different to the other states and territories.
Sure. So have you had conversations with your state counterpart in Victoria in relation to this specific issue?
No.
No.
No, although I've been very clear with the department I administer that I want them to work actually across the country with the SIL providers to understand the issues that they say they are confronting. And as the Secretary says, part of that means understanding the actual price drivers in their businesses. And so one of the things we've initiated recently is the SIL quality pilot. I can ask NDIA officers to talk you through that, but part of the value of that pilot from our perspective is it allows us to work with the SIL providers, understand what are the drivers of quality and safety in the services they are offering, and help us better understand the kind of pricing arrangements that would support those kinds of services continuing.
It's 27 days until these people will potentially become homeless. I'm not sure they can wait for a pilot to be tested more generally around the country.
Well,
So
I think that would
okay
that would
if I finish my
misunderstand the
question?
steps that are already being taken by government senators. So Ms McKay has described to you the interactions we are already having with the Victorian providers to understand their circumstances and understand what parts of that the Commonwealth can contribute to. But we can't direct the Victorian government to behave in certain ways or to take any steps. We're focused on the thing we can control, which is the work that we do around pricing and the work that we do around planning for participants in Victorian accommodation.
We can't direct them if you don't speak to them.
Well, I talk regularly with counterparts, but this hasn't been raised with me directly by the Victorian Minister, which was your question.
Yeah, and you haven't raised it with them.
Senator,
Well, our agencies are working very directly
I had
on the
indicated that I
question.
was shifting the call, so I do want to give Senator Steele-John the opportunity to ask his questions before we break for lunch. So I will do that now. Senator Steele-John, you have the call.
Thank you, Chair. And hello, Mr Head. Good to see you here. Look forward to working with you and your team in your new role. Now, I'd like to table two articles for your reference and the reference of those at the table. So I've circulated them to the Secretariat ahead of time. They are the Guardian articles from today, 4th December 2025, and from yesterday, 3rd December 2025. I'll just give a moment for them to be distributed. Awesome, fantastic. And they'll make their way over to you now for your reference, but I'm sure you've read them. My questions, firstly, will go to making sure that I and the community have an understanding of your new assessment processes. Firstly, can I ask you this, so that we have a shared understanding of a basic fact. The NDIA are moving towards a new assessment, a new needs assessment tool, the ICANN tool, and are working towards this tool being rolled out by June of 2026, correct?
Senator Scott Norton, Deputy CEO. At this stage, what we have certainly done through a lot of the information that we've been talking through with community, with the states and territories, and with the disability sector, is that we're working.
You're going to have to turn your mic up. I can't find
Sorry, we're working very much through the design and the policy settings. At this stage, the intention is to do all that work and get ready to roll out progressively from middle of next year. And what that rollout looks like, we're still working our way through that, of course, but it would be a very small-scale measured rollout so we can get all the settings correct. And we can talk through all the work we're doing around co-design, because absolutely want to reassure the disability community in the sector that there is a lot of work that we'll be doing with the sector and with disability people with disability to get those design settings right, and of course with the department.
And we can get to that contextual information later. I just want to establish some basic facts. So we'll begin that rollout in June of 2026. We are still not doing a formal trial, correct?
At this stage, Senator, what we are doing, because we sort of go through the context of how we went to market and we procured the support needs assessment tool, which we've spoken to the committee about before and through the various hearings. We've now had access to the tool and we're doing a whole range of desktop surveys. In the last couple of weeks alone, we've been doing some work with a group of participants to go through the process in a simulate. We had a 2-day workshop to go through that simulation. We've just opened up for participants to nominate to be part of a new framework planning work pool, so where participants to volunteer to be part of our design forums early in the new year. So we're gearing up for a whole range more of co-design and consultation activities. We'll get into that more granular testing of how the process will work, Senator. So we're very, very mindful of the need to do very deep and consultative testing on this model. And we have a whole range we've started, and we've been talking to a whole range of reference groups already, but there is more work that we'll be doing over the coming days, weeks and months as part of that.
Mr McNaughton, have you or the NDIA more broadly conducted a risk assessment? And if so, can you table it for us?
I'll take on notice the tabling. We have a risk assessment for the entire program, the project management approach for the entire program of work. But let me take on notice what the risk assessment.
Okay. Are you able to table the ICANN tool today?
We can talk through the tool and the domains and how it works, but also how the tool will work with a whole range of other questions. We'll be talking to the participants, as the Minister said in her opening statement. It's a broad-scale, semi-structured interview, goes through a whole range of questions about the participant, their circumstances, and then there's other modules we may need to commission. So we can talk through that.
I understand that, but just in the interest of time, what I'm asking you to do now is whether you can table the tool for the committee today.
Can I take that on notice? I think we will be able to, but certainly at a high level, talk through table the domains of the tool so you can see how that works.
Yep, okay. Because the concern is that we are sitting here at the 4th of December, so about 6 months out from the start date, and the government has yet to be able to publish the full tool so that it can be open to public scrutiny. The ICANN assessment will be administered by an assessor who has completed a short training module, not exclusively an allied health professional, correct?
So, Senator, when we've been working with the University of Melbourne and the Centre for Disability Studies, there is a range of people and skill sets who will be trained to administer the tool. This tool is not new for us. It's been around for some time. It's the ICANN version 6 tool. What we're working with the university and the Centre for Disability Studies is the training of our staff who will administer the tool. We already have a number of staff who have allied health backgrounds. We expect staff will come and people administrators will come from a broad range of backgrounds, having allied health, social work, lived experience of working with people with disability. The Centre of Disability Study will help with the training of our staff, so we'll do that as part of the contract. They will also do a lot of the quality assurance, train the trainer, and making sure we're applying it in the correct ways. There's a lot of deep engagement with the uni and the Centre for Disability Studies to get that training right over the coming weeks and months. So.
And there will be specific targeted assessments for complex support needs or specific needs of participants, correct?
Yes, Senator. So, as I mentioned, the tool is part of a broader holistic support needs assessment approach, which every participant will have what's called a personal environmental circumstances questionnaire. Then we'll go through the ICANN assessment, which covers those 12 domains, and we can talk those through in detail. Then for some participants, we'll get additional modules, and they'll be modules or targeted approaches such as complex home modifications. If the participant has a more complex needs or a behaviour support plan, we'll have to then get additional information from treating professionals, allied health experts to help inform the reasonable and necessary supports required for that participant.
And you will get them from allied health?
If we don't have that information already, we may need to commission some additional reports, such as the treating health professionals already supporting that participant. Or if we need to get home modifications, it's quite a specific activity centre, as you know, so we'll get that information from the various therapists, allied health professionals.
And will there be alternative formats for those disabled people undergoing the assessment who have difficulty verbalising their needs or who aren't able to read or write, or for whom English is not their first language?
We're going to work through and make sure that there's a range of accessible formats, people that might need to go through it with Auslan interpreters. We're also working through our First Nations group to make sure the tool is culturally safe and administered in a culturally safe perspective. So there will be a whole range of testing of this tool to make sure it covers a whole range of medium and can be delivered across a whole range of different people with disabilities.
But none of those additional modules are completed at this point.
We're working on those as we speak with the department and through the policy groups and our co-design work.
And you mentioned a additional assessment process. I believe you used the phrase an environmental tool. Just wanted to check.
Yes, it's called the Personal Environmental and Circumstances Questionnaire, the PECQ.
Yeah.
And this is where, Senator, we get to understand the participant, where they live, who their informal supports are, their goals, their disabilities, all of those activities around the person. So every participant goes through that, will go through the PECQ, the Environmental Circumstances Questionnaire, and then into the ICANN assessment process.
And is that a questionnaire that you've developed, or is it one that you've purchased?
It's something that we've developed internally through the work we've already done, because it also builds on the risk assessment tools that we currently have today, which sort of determines participant risk and safeguarding responsibilities.
Can you table a copy of that questionnaire for the committee?
We'll take a notice, but we should be able to table that, Senator.
And now the information gathered by the assessor will be fed into a computer program where an algorithm will determine a funding package or budget for an NDIS plan, correct?
The legislation requires, Senator, that the inputs from the support needs assessment are applied to develop a person's budget. So we're working through with the department very closely around what those policy settings, what the rules that need to be developed to enable that to happen. They're still very much in development. But I do just want to stress, Senator, that still leads to the development of a budget that a staff member has to approve. There is a delegate under the Act who has to approve that budget.
Yeah, we'll get to that in a moment, but I just want to clarify the inputs from these assessments and questionnaires will be fed into a computer program which will then deliver a funding total or a planned budget. Functionally, that's what will occur.
So yeah, they will be applied to help develop the budget, which then goes to the budget assessor, the planner, who will work on finalising that budget.
Inputting the data into a computer
applying the data from the support needs assessment and those other modules I talked about.
Yes. And have you purchased a piece of software for the purpose of translating those data inputs into a budget total?
We're currently designing and building that ourselves internally at the moment based on the policy settings which are still in development. So it's still very much in development and design at the moment, Senator.
Okay. What software platforms are you considering as part of that build?
Let me take a notice, but I understand it's our existing, what we call our PACE platform.
It's your PACE platform
that we're using. But let me take that on notice, and we'll see if
that's. I think we're going to end that round of questioning with that particular red flag, and I will pass back to the chair, and I'll return.
It is our current ICT system, Senator.
It very much is, and it very much doesn't work. So we'll come back to that.
Senator Stilton, I think the important point here is that I appreciate your interest and I note your public comments that seek to compare, seek to emphasise algorithms, etc. The government's been really clear for many years now, since we received the report from the independent review of the NDIS, that we wanted a system that was more predictable and fairer. But we wanted to deliver some other things for people with disability on the scheme too. We wanted more flexible budgets where people would have greater capacity to substitute items for one another within certain areas. We also wanted longer plans so that people were not subjected to planning again and again. These are all features of the process that we're building. We are generating a support needs assessment that is strengths-based, that involves opportunities for participants to confirm their information with their planner. And my personal objective is to make sure that this planning experience is a positive one. We hear a lot of reports that the present process isn't a positive one for participants, that it's adversarial, and that it is weighted towards people who, for one reason or another, have the capacity to assemble large volumes of clinical evidence. We're trying to find a way to make it a little fairer and a little easier for people to undertake the planning process.
Sorry, Chair, can I just correct my earlier statement? I've been advised, if I may, through you, just Senator, I've been advised it is a different software product, not PACE. So,
okay.
So that was the correction over my shoulder. Sorry, Chair. I just want to get that on the record.
That's fine.
Well, that's pretty key. So what software product is it?
It's called Composite, but I'll get some details on that.
Okay.
For you. I'm not aware of the details, so
Thank
I'll
you,
take that
Ms.
on
Fingal.
notice and get back to you.
Great. Thank you, Senator Stilton. We are rapidly heading towards the lunch break, so I think we may take that early and be back at 12:55, so that, 1:55, so we can continue in this outcome area. So we break for lunch. Thank you. on disability and carers. Thank you so much, Broadcasting. I am going to go to the Minister for a short statement to kick off.
Thanks very much, Chair. I just wanted to provide an update because Senator Ruston had asked me questions about the Victorian SIL providers, and the call was moved on while we were really in the middle of dealing with questions which are important, and I just wanted to make sure that you had accurate information, Senator. So firstly, I think it's worth setting out the dimensions of the issue because not all of the media reporting about this has been entirely accurate. So I've been regularly briefed on the issue. As I understand it, the Victorian Government is the housing provider for many of these participants. We provide funding through packages through the NDIS to those participants so they can obtain support from providers in their homes, and the funding that is provided to those Victorian participants is provided in the same way that it is to other participants around the country. There is an agreement between some providers in Victoria and the Victorian Government. We are not privy to the details of that agreement. Secondly, in relation to contact between myself, my office, my officials, the Victorian Government and Victorian providers, I can provide the following additional information. I understand that the Victorian Minister had sent a letter through while I've been in estimates this week on the 2nd of December. This follows ongoing conversations at all levels. So our officers have been talking about this issue. The department and the agency have discussed this matter with their Victorian counterparts. The NDIA has been working closely with the affected Victorian providers for many months, and I understand there was a meeting with the relevant CEOs in the past few weeks. The agency have been undertaking an audit of the plans of relevant participants to ensure they are funded at appropriate levels. I have personally met with staff who work at some of the relevant provider organisations, and I regularly speak with providers about the SIL market. Finally, I want to note that at no stage has a provider notified the Commission that they are withdrawing services on the 1st of January. The NDIA has well-practiced procedures in the case of providers changing the services that they offer, and our focus is always on the continuity of service for participants and a focus on participant safety. And it is very important that people get good and accurate information because we wouldn't want people to be worried without reason about the security of their housing. Thanks.
Thank you very much, Minister. Can I just mention the media that are currently in the room? In an earlier statement that I read out, just wanted to bring that to everyone's attention. If there are issues, please speak to the Secretariat staff. I think we're going to you, Senator Ruston, to kick off.
Thank you very much. Can I just ask a couple of extra questions in relation to ICANN, but mostly in relation to in the article in relation to ICANN, there was also reference made about the ART and process of the ART, and the article noted that under the proposed changes, if an NDIS participant appealed against their plan to the ART would no longer have the authority to alter a person's plan or reinstate funding. I'm just seeking, is that a change? So previously they could do that and now they can't?
Good afternoon, Senators. Matthew Swainson, Deputy CEO, National Disability Insurance Agency. So, Senator, under the new planning framework, which I think we've been discussing this afternoon, a participant will retain a right to seek review to the ART, so that doesn't change. They will continue to be able to seek a variation of their plan under 47A and a reassessment under Section 48, both of which are reviewable decisions under the new planning framework.
To the agency?
What's that, sorry?
So they can seek a review to the agency?
Correct.
To the agency, not to the ART?
They'll be able to seek a request for a variation to the agency and a reassessment to the agency, and if they're not satisfied with the outcome of those two things, they'll be able to seek a review of those two decisions to the ART, so both of those are reviewable. The support need assessment report, which will be an important part of the new planning framework, will be subject to review by the ART. So these are matters which are within the legislation at the moment.
So I'm just trying to seek clarity because I've only got this article, newspaper article. So the article actually says that the ART no longer will have the authority to alter a person's plan or reinstate funding. I'm clearly want to understand. Previously, have the ART or the AIT had the capacity to alter a person's plan or reinstate funding?
So, Senator, it's probably worth, I guess, putting in context, and I will answer your question. I guess the concept of moving to the new planning framework is a much more transparent and consistent rules-based approach. So the ART will have the same powers and same decision-making rules as what the NDI delegates will have. Which is,
sorry. So
yeah, sorry.
I'm talking about the ART's component of it. Senator Steele-John sort of prosecuted the issues in relation to the new assessment tool. Just trying to understand the differences in the ART and only the differences in the ART.
Yeah. So. The ART concept, or the concept of merits review, is that the tribunal will stand in the shoes of the original decision maker, which is the agency or an agency delegate. So they will have the same powers and same discretions available to them, which will be available to an agency decision maker. So where the rules allow for, and the rules are still being developed, I think that's a really important concept. So for the new planning framework, a lot of the rules which are still in development, I think Mr McNaughton talked to the procedures around that. So the ART under the new planning framework will have the exact same powers and exact same discretions available to them as what a planner will do, what the agency will have under rules which are still under development. So where the rules, which we're still to work out, where the rules do allow, where the rules do allow.
Mr Swainson, I'm really confused, and it could be just because it's been a very long week. The ART was and remains the body of review. I'm just seeking to understand, previously, if a person sought to have their plan reviewed by the ART, did the ART have the authority to alter that person's plan or reinstate their funding?
Currently, Senator.
Currently, sorry, yes.
Sorry, Senator, I'm talking future. So that is correct, Senator. So currently, the ART does have a power, as does the agency, to adjust plans in the way you described.
So subject to the changes that are being proposed and considered at the moment, is one of the proposals that is being put forward that the ART will no longer have the authority to alter a person's plan or reinstate their funding?
So the ART will have the same discretions as it will be available to agency delegates, and they will be subject to the same rules. So the rules are still being developed, Senator. So the rules which are in development, if those rules allow for an agency delegate to alter a plan, the ART will be allowed to alter a plan.
So this article is incorrect, is what I'm trying to get to.
I think the point is that the rules which define the discretions which are available to a delegate under the new planning framework are still being developed.
But yes, Senator, I think the advice that's been given is the intention is the ART would still be a point of appeal which could then amend or change the plan if a participant was successful in the ART.
So the ART doesn't get to make the change. It would then come back to the agency. If the ART made a determination that there was some error, it would then come back to the agency as opposed to the ART being
Well, I think what
that
Mr Swainson just said is that the ART would have the same capacity to make changes as the delegate within the agency, and therefore it could make changes.
Okay.
Senator, the key that drives the new planning process is the support needs assessment. There's a process to feed information in from the participant and their advocates that informs the way that their support needs are assessed. There's a report that's produced as a result of that. That report feeds into the calculation of their budget together with a range of other factors, including, as we discussed earlier, their personal and environmental circumstances. Also includes things like their plan management type. It includes stated supports and other elements of their plan. That plan is then approved by a delegate of the agency, and if a person isn't satisfied with the outcome of that process, they can seek an internal review. They can seek a review to the ART. The ART can order a replacement support needs assessment, and that then generates a fresh consideration of the person's circumstances, which follows through that process.
Okay. All I'm seeking to understand are the proposed changes going to alter the remit of the ART on the basis, is the story, the article that has been written by Kate Lyons on the 3rd of December correct or incorrect in relation to its comments around the powers of the ART? So far, I've had a lot of words, and I think I understand, Mr. Swainson, that you're saying that technically it is wrong, because if the rules are written in such a way, the person will still have the same, or the ART will still have the same powers. But I don't think anyone's actually just said that. They've just sort of gone around the edges of it. So,
if I might, I can see the frustration. There will be, and it's expected to will be, a different scope and discretion and merits review before the ART under new planning framework.
Okay.
Because it's a different system of decision making, as Ms Shannon just described. But what that looks like is still to be determined by the rules.
So if you wanted to make these changes, would it require legislative change or regulatory change?
So the changes to the primary legislation were passed by the Parliament last year.
In relation to the ART, I thought you said the rules.
In relation to the whole concept of the new support needs assessment and new planning framework, including the articulation of review rights.
Yeah, sorry, so you're telling me that they haven't been designed, and you're telling me the legislation's passed. So can we just stick to the salient point we're talking here in terms of the powers of the ART? And I mean, I get it's probably very complicated, Ms Shannon. So any changes to the powers or authority of the ART as is designed by whatever your rules, what they end up looking like, does that require legislative or regulative change subsequent from now?
No, Senator. The powers and functions of the ART are set out under the ART Act.
But you're seeking to change them.
So what we're saying is under the new planning framework, there'll be a different way for determining a participant's budget, which will be going through a support needs assessment conducted by a person.
So right now, there is a process that the ART can undertake. Tick, no, no concern about that. If you are about to make changes to what the ART is authorised to do or not do, how do you do that without change? I mean, it's not up to the NDIA to determine how the ART works.
No, the arrangements for the way new framework planning operates and the role of the ART as the reviewer are set out in the primary legislation as well as their own operating legislation. The primary legislation also creates rule-making powers so that a range of elements within the new needs assessment and new planning framework...
So those rules don't need to be registered, don't need to be, they're not disallowable instruments?
Yes, no. Senator, they will be.
They will be, they won't be?
Sorry, they are, but they also have to be agreed by the states. So there's a whole agreement process for these rules,
So the rules haven't been made yet, so the primary legislation makes for the rules. This is sort of a bit of a trend that we're seeing, that the primary legislation doesn't have a lot of information and everything's subordinated to the rules, which makes it so opaque, which is probably why you're seeing articles like this that create confusion, which is really disappointing because I would imagine that there are a lot of people who get quite distressed at reading these, and the reason they are reading these is because we don't have the rules, because it's not in the main legislation. So you're saying that the rules that still need to be written in relation to these procedures are a disallowable instrument?
Correct.
Okay, so they are subject to regulation. They do have to go through the Parliament?
Correct.
Right, thank you. That took a long time to get to. The other thing is, in terms of the actual process of the ICANN assessments, is it proposed when a client or a participant goes through an assessment where the assessment actually occurs, can that be done on the phone or at home or, by video link, or do you have to actually physically be at a particular site?
I can take that, Senator Scott.
Sure.
Essentially, because it is a sort of semi-structured interview, it does go for some time. The preference would be to do that face-to-face, but we will work with the preferences of the participant. If they prefer to do that virtually, over a Teams or whatever the virtual thing, It could be phone-based, but I think you'll lose a little bit of the sort of validity of it.
Yeah.
So our preference would be they're either through a Teams virtual process or in a face-to-face setting.
But there would be flexibility for circumstances to be considered in that.
That's right, absolutely.
Yep. Cool.
So we'll work with participants around what the preferred methodology is along those lines.
Great, thank you. Thank you very much. Do you want me to keep going to the next one? Or? Okey-doke. I just wanted to raise some concerns that I've had raised with me in relation to the financial viability of not-for-profit service providers. Welcome back, Ms McKay.
Chair, can I just ask whether captions could be turned on, just to assist?
They're back on.
They're back on.
This monitor's working. We can see the captions.
No, this one's just come back on, but it wasn't working before.
It wasn't working before.
Yeah,
Okay.
so it's now back on.
Yep.
Thank you.
Just wondering what the NDIA's assessment of the overall sustainability of the not-for-profit sector is in terms of the delivery of NDIS-funded services.
Thank you so much, Senator. It's Penelope speaking. I guess there's two things I want to highlight in answering that question. Firstly, in relation to pricing and how we set pricing, and then secondly, in relation to how we're working with the sector to get further information about the issues that have been raised in relation to the financial viability of not-for-profit, particularly SIL providers. So firstly, in relation to pricing, we set pricing based on a range of economic factors. It's evidence-based. We look at supply and demand in the market, prices in other markets, and broad economic factors. So what we've seen is that there's 263 active providers across the market that are providing services, and the number of providers in the market has consistently grown year on year. So that's the kind of information we look at when we set pricing. As we've indicated previously, we have really heard the feedback that people want more engagement with us about pricing, and they want longer lead times in relation to pricing. And as we've been talking about, we really want to make sure that our pricing incentivises quality services. So we have recently commenced the SIL quality pilot, where we're working with a number of the larger SIL providers.
So I'm not necessarily talking about SIL providers. I attended an Ability Australia's round table a few weeks ago, and they raised concerns with me overall about the viability of the sector, and they were particularly concerned that the sector was verging, if not already past the point of viability. And I know we've already seen that, Centacare and Anglicare Western Australia, Momentum Collective, and I could go on, providers who are pulling out of the market. And so I'm sort of I'm sure you've got a very robust process for determining these things. I'm just worried, I'm just interested in whether overall that the NDIA has concerns about the continued reported stories of providers leaving the space.
So we use evidence with the pricing and said, and overall the market continues to grow. We are looking at, and I focused on SIL providers because SIL participants are the most vulnerable participants that we really do want to ensure there's quality services around SIL participants. And generally SIL providers are the ones that tell us they have the most financial difficulties. So that's why we've focused on thinking about that cohort They do tend to be more of a not-for-profit. Obviously, we don't set different prices based on the entity type that's providing the service, but we're really keen, and we have been working with those providers to better understand what the financial drivers are and why they are experiencing financial difficulties.
So I don't want to verbal you, but it's sounding like you're not that concerned. So you're saying the market continues to grow. So is there some suggestion that those that aren't profitable will fall out, but they're being replaced by others in a growing market who are prepared to step in and provide those services? So, is there, I suppose, in simple terms, is there any real need for concern about an exodus of providers from the market that potentially could leave the market unsupported to the extent that NDIS participants could find themselves unable to actually access the services they currently are or that they need?
And these are really important issues, and I note that the department and the Commission and the agency work together in relation to our market stewardship responsibilities. And we do care deeply about the type of market that we have providing services to participants. The agency's specific role in relation to this is to set prices, and what we have indicated is that we are working over a number of years to look at the quality of services and how we can incentivise the quality of services, because we're very keen to ensure, and our responsibility is to ensure that we're pricing services appropriately, and that's our responsibility. The issues broader relating to market stewardship and provider viability go to broader issues, and the department and the Commission work with us to ensure that our market stewardship responsibilities are acquitted.
So maybe to the department, to you, Ms Shannon, does the department have concerns about the viability, particularly of the not-for-profit sector?
Senator, we are aware of the concerns that have been raised, and as Ms Mackay said, we do work quite closely with providers to try and understand. In some instances, there obviously are some individual decisions or particular markets where viability becomes an issue. But we certainly are looking, and you'd be aware that there are sort of a range of medium-term policy issues that are being explored, coming out of a range of reviews, including the NDIS review, which look at things such as pricing reform, as Minister Butler flagged, some consideration of the benefits of independent pricing, to regulatory reform, which might do two things. It might give us, gives providers perhaps a bit more of a level playing field when it comes to that, but also gives us greater visibility of their financials and their operating costs, as well as we're testing alternative commissioning approaches and blended payment models.
And great, but I'm just trying to understand if there's any concern. So, Ability Australia is an organisation that is huge and represents a massive number of providers. They are saying that they're concerned that their profitability levels have actually gone into the negative. We're already seeing potentially consequentially, I have no evidence to say that one's caused the other, but it would seem likely that we're seeing the closing of services on the back of it, and I named a few before, and there are many more that we could be talking about who are either have closed or are concerned about their ongoing viability. I'm just interested to know whether the department is concerned about the concerns that have been raised by this collective that represents a huge number of NDS providers.
Well, we're certainly working closely with them to understand and unpack it.
If you're concerned.
Well, we're doing work that we think will better set us up to, in the medium term, to provide advice to government around those range of issues that are being raised by providers.
So, Minister, is the government concerned about this?
I talk with the providers that you speak with, and in fact I think I probably attended the same meeting that you did in the Parliament. We could have done it together, Senator. I'd characterise it this way. We think that there is more we can do to build the market, and without taking up too much of your time, in addition to the Thriving Kids work and the foundational supports that Minister Butler's been leading on, I've indicated my 3 priorities are a system that operates with integrity and safety, a system that offers a better participant experience, which we've talked about a bit this afternoon, but thirdly, a market that delivers services that are of genuine value to participants who are purchasing them. And that is going to require more focus than occurred under the previous government. And so some of the initiatives...
You can't help yourself, can you?
Well, regrettably, Senator, it is true. There is a lot of work to do across a lot of different areas of scheme administration because it was neglected, and there are a range of challenges that we're now seeking to meet. But one of them is market stewardship. And some of the initiatives that officials have talked about go directly to this. Getting a good data set about what drives quality in those big providers that provide the majority of services to people with the most complex needs is critical. Understanding what needs to happen in thin markets where we simply may not have enough demand in those places to drive the provision of market-led services, and making sure we get pricing right so that we are appropriately rewarding those people who are offering services to more complex participants. And those are generally the things that those big providers that you've spoken to, Senator, also talk to me about. They also, of course, talk about regulatory arrangements, and we've done quite a number of things in recent months to intensify the regulatory obligations for all providers. We intend to keep working on that area because this scheme must be safe and must operate with integrity, and we will keep a very intense focus on those latter questions.
Senator Ruston, I am going to need to share the call, so just checking on whether that's possible to do now, and I can come back to you. Sure. Yep. Senator Stilger.
Thanks, Chair. So let's try again for a little bit more clarity for the community. So I'll bring us back to the article that was published in The Guardian on the 3rd of December and the 4th of December. And I'll quote directly from the 3rd of December article, quote, that if NDIS participants appeal their plans to the Administrative Appeal Tribunal, so this is tackling the question of changes to appeal process, the ART will no longer have the authority to alter a person's plan or reinstate funding, but will only be able to send the plan back to the NDIA to be recalculated through the ICANN tool. Now that's correct, isn't it?
Senator, I am identifying some frustration in the answers that I've been providing, but the reality is, I think as answered, is some of that is yet to be determined by the rules. There may be circumstances, and here I just want to be very clear that on 2 things. One, participants will continue to have a right to review their plans under new planning framework. That will remain as it is now and under the new planning framework. The second part of my answer is there may be circumstances, and here I'm being a bit hesitant because the rules are yet to be developed, where, for example, somebody with complex home modifications may seek some sort of variation to their plan through the powers that will be available under the new planning framework. A review of that type of decision would allow the ART to make a decision to increase their plan. So I think previously I got asked whether or not the article was correct or not, and my answer is we're yet to determine the rules which will lock that down.
Okay, now, notwithstanding any further rules that are in development, there is quite a lot that is certain at the moment. One of the things that's kind of set in legislative stone is what is and is not a reviewable decision. That's identified for us in the Act, and that was significantly amended last year. Now, the total budget amount given to participants, is that or is that not a reviewable decision under the Act?
Currently or in the future, Senator?
Currently, and then under the new framework model.
Currently, it is a reviewable decision,
Yes,
Senator,
it
as
is.
part of the reviewable decision under the current arrangement is a review of the statement of participant supports.
Yep.
So it's a single review decision that looks at total funding amount, it looks at plan management arrangements, it looks at funding periods, so it looks at a range of issues around a participant's plan, and that's all reviewable under a single reviewable point. That's the current arrangement, Senator.
And then under the new arrangement?
Under the new arrangement, there will be a single point of review, again, of the statement of participant support, as is with the old arrangement. That will include the plan management type, the funding period, and also whether or not the support need assessment could be accepted.
Yep, the support need assessment it can be accepted. So the one that's...
Sorry, Senator, and I should just add that extra clarification. I did say that there is a Section 47A variation is a reviewable decision now, and it will be a reviewable decision into the future. So that's a...
And so the one of these that is not like the other, Mr Swainson, is that under the new model you're proposing, the total funding amount is not a reviewable decision.
Absent a potential variation under 47A, which
Absent a variation under 47A, which is not a common occurrence, the total funding amount is no longer a reviewable decision.
That's correct, Senator.
Yes, it is.
That's correct,
okay, so this is what we're trying to get to, right? So that is, for want of a better word, for those following along at home, the core of the pot of money you receive to fund your supports. The other things are important, meaningful, but the funding amount is one of the more tangible pieces.
Senator, could I just make a clarification of that? Under new planning framework, there won't be a concept of total funding amount. What there will be is a bucket of a flexible funding and a funding for stated supports.
Yep, and they are not reviewable decisions, are they? The flexible supports or whatever you've rebranded it as.
They arise out of the support needs assessment. That's correct.
They arise out of the support needs assessment, the outcome of which is not a reviewable decision, is it? Only whether or not it has been conducted correctly.
That is correct, Senator.
That is correct. So the article stating that...
Senator Sturgeon, I think Ms Shannon...
Just to add, Senator,
please jump in.
There may be additional factors on review that haven't been captured in the support needs assessment, which would then feed into the support needs assessment, which would then calculate a change to the budget.
There may well be.
It will affect, like, if there is a variation, then it would affect the amount of the budget. So it will drive a change in the budget.
And the tribunal may well find that and therefore order a new assessment.
Correct.
That would then result in it being recalculated through the ICANN tool.
Recalculated through the budget method, which is subject to a separate rule, which will be, as we established previously, a matter of public record and finalised in consultation with states and territories and scrutinised by the Parliament.
Which we will get to in a moment. But for the purposes of answering what was now a question put to you about 40 minutes ago by Senator Ruston, there is significant change in the role of the ART here. We are going from a space where the ART has a role in ordering that additional funds be allocated to the total funding amount given by a participant to a model in which that is not a question before the tribunal. The question before the tribunal is whether or not to reorder an assessment, which may, after that process, result in a different funding amount, or it may not. But what is the question before the tribunal is whether or not the assessment should start again, which is a totally different question than the one the tribunal considers at the moment, and is the centre of the claim in the article. So, the NDIA would be the only body allowed to reassess the value of the plan, correct?
Senator, there is, I guess, a slight nuance here, and again, I appreciate you're trying to get to the bottom of this, but I mentioned the provision around Section 47A, which without being too technical, that's the ability for a participant to seek a variation of their plan. Whilst it's still being developed and the rules are still underdeveloped, there is a scenario, for example, where that would be a mechanism by which, for example, a quote for an expensive piece of assistive technology or home modifications could vary a participant's budget, and that is reviewable by the tribunal. So I think what you're putting to us, and I appreciate we're trying to get as clear as we can and assist this committee, which we're absolutely trying to do. I don't think we can sit here categorically and say that the ART under the new framework will not be able to vary a participant's budget.
So
at this point in time.
Beyond those two categories of assistive technology and home modification, are there any other areas?
I was presenting that as an example, Senator, because as I said, we're still developing the rules.
Okay. So one of the other things mentioned in the article is whether or not the tribunal will have the power to ask that the assessments be undertaken by a non-agency assessor. The advice apparently that you have is that that is not possible. Is that correct? Will the tribunal be able to ask an outside third body to undertake the assessment?
Senator, I think that that part of the article, which I have reviewed, I would say is not correct. I think it still, I guess, is being worked through. We'll have to work this through with the tribunal about what it does look like if a tribunal does require us to do a new support need assessment. I think there's a range of different scenarios, there's a range of different powers that are available to the tribunal in those circumstances, and where we sit here at the moment, I don't think we can categorically say on that point.
Because what we have, and I've heard the audio of this briefing, there is a senior executive saying that it is the law that only an agency official can undertake a ICANN assessment process. So
I don't think that's correct, Senator.
Okay, so can you table the advice for us that
Senator, I'm aware of the article. At this point, we are unable to identify the advice that's referred to in the article. We've got a large range of legal advice that ourselves in the department have commissioned in terms of developing the Act and how we operationalise the Act, but the advice referred to in the article we are unable to identify at this point in time.
We've seen a large number of people go to the ART and appeal NDIA decisions to that space. The number and percentage is only increasing. In fact, in the year to June 25, I think we've got a 72% increase, I believe, in the number of cases going to the tribunal. Is that correct? About 72%, the latest figure?
It's about correct, Senator, yeah. And I think it's right to say we're experiencing increasing numbers at present.
Yeah, I think so. Minister, as I see it, this change could take away important checks and balances on the agency at the very time when people are needing those checks and balances more than ever. What would you say to those who would suggest that this would weaken the checks and balances placed on NDIA decision making?
I've indicated earlier that the purpose of the reform is to have a fairer and more transparent way for people to engage with the planning system. One of the things that people raise at the moment is that the outcomes of the planning process don't always appear to be consistent between people who have quite apparently, on the surface, quite similar circumstances. The point of building out a system which has a more consistent way of assessing a person's support needs, but then also allows a more flexible budget, is designed to generate a much more stable environment for participants. The officials have confirmed to you that matters that the delegate may take into account when they're making a decision through the planning process will be able to be considered by the ART should a matter be taken there, and that the ability to go to the ART remains. they've also indicated to you that actually the design process isn't finished. We are working with members of the disability community, with a range of stakeholders, to actually step out what the new planning framework is going to look like. It's difficult to definitively answer all of the questions that you pose because that work isn't concluded. As I sometimes say, one of the challenges of co-design and working collaboratively with stakeholders and with community is that we have longer periods of uncertainty about how changes are going to occur because it takes time to work these things through. We're committed to doing so, and we'll be able to consider the accountabilities as part of that process.
Thank you, Minister. Before I hand the call back, I just have to clarify because, again, I think there will be questions raised in people's minds. So, Mr. Swainson, you've shared with us an example of a piece of assistive technology as an example of something that the ART might order that may result in a variation of the total funding amount. How can a fancy piece of paper doing a quote for, a wheelchair, for instance, how can that be factored into this this new assessment process when at the same time you are no longer considering people's additional medical evidence that they might provide? I can't see how those two things fit together.
I think evidence was given earlier today about the potential, and again, we're still in the design process of different reports potentially being used for, the different targeted modules that are still being developed. And I think some examples were brought forward about, behavioural supports and other matters where it might be the case, and again, I just keep caving this, we're still really designing these rules where, participants' own reports from their treating practitioners or allied health professionals may be of assistance or may be taken into account.
Well, that they are of assistance because the 72% figure I gave you, that's the outcome of ART cases that result in a variation. So that is participants going to the ART and saying the agency has made a flawed decision, and 72% of the time the tribunal going, yeah, you have. So in that context, there is often presented additional medical evidence. Sure, I accept that, but you've said there's potentials to do this, potential to do that. What your agency has said really clearly, and what the government has backed up in meetings both private and public, is that while additional medical information may be received, the primary inputs to the assessment that result in the budget will no longer be people's expert specialist assessments. So these two things do not match up, and people see that looking in here, and that's why they're frustrated. I've come to the end of my time, so I'll pass back to the Chair.
Thank you, Senator Steele-John. Senator Brown.
Thanks, Chair, and hello, Minister. I just want to ask a few questions about the sports needs assessment as well. So I'm trying to get an understanding of what informed the thinking behind the new supports needs assessment process, and how the new assessment will improve the experience for NDIS participants.
Aaron Verlin, Acting Deputy CEO, Service Design and Improvement. Firstly, there's a great source of information that came from the NDIS review originally, the number of submissions, the number of consultations that occurred with the broader disability community about what does different look like and what are the most important parts of understanding a participant's support needs. And so the agency wasn't starting with a blank piece of paper due to the significant amount of consultations that had occurred through the NDIS review.
Yeah, that occurred really from 2023 and then led to the introduction of that legislation.
Yeah.
The second part was following the introduction of the legislation in October 2024, what we had done is worked and established some distinct co-design and consultation groups with the disability sector, members of our independent advisory council, and also directly with participants. And what we did was we spent time working through and consulting on a statement of requirements that would then inform the procurement activity for the support needs assessment. We had 2 sessions with the co-design working group, and we also engaged with our disability registered and carer organisations and the IAC around the statement of requirements, and then went through the procurement process. As part of that procurement process, we had a dedicated lived experience advisory committee that was able to provide advice as part of the procurement process, and we also had people with disability on the evaluation panel as well. So that really established what was really important about the support needs assessment. Following the procurement of the tool, we have then really started to establish what's really important from an experience perspective for the participant, and then how do we move to test and trial particular components of the support needs assessment. I should say, as part of broad engagement since October 2024, we have run 135 dedicated information sessions, and we've had over 6,000 participants attend those sessions to really start to understand what are the important components of new framework planning, and then particularly talk about parts of the legislation, and particularly around the support needs assessment. So that was our broad opportunity to really start to engage with the disability community. As we've now moved into what we are saying a core design phase, we have established a design hub. That design hub will bring together participants, our designers, our members of, as I said, our disability organisations, to come together to start to really focus in on those core moments of the new framework planning, particularly around the support needs assessment. A couple of weeks ago, we commenced our first design hub session. We had 12 participants. We had a couple of our support needs assessors from within the agency. And what we've done is, through that 2-day workshop, we started to work through how would a semi-structured discussion occur. As the Minister and the Department have outlined, the support needs assessment is a conversation. It's not a set of distinct questions. And what we did is we worked with those participants to really start to test and get direct feedback about how the conversation should occur and what were the particular questions that we were asking in that conversation piece. We did get direct feedback. Some participants were seeking more granular information, and others were really comfortable about a conversation. We know that's a very small number of participants, but I wanted to give the committee a sense about how we're bringing participants into our design space. And finally, we have established engagements directly with Inclusion Australia and Down Syndrome Australia, because we want to make sure we have intellectual disability as part of our cohorts as well.
So you indicated, I think you said 12 in terms of the discussion around the hub. Is that right? 12 participants?
So as our first workshop,
Yes.
we had 12 participants work directly with some of our support needs assessors, but I must reiterate, that's the first design hub of many.
Yeah, okay, so that was my next question. So what's that rollout look like?
So we know we've got the next few months, particularly, to start to have ongoing discussions. And as I said, we want to go more broadly to make sure we have diversity in the disability cohort to be able to work through that. We have our participant reference group, and we also have participant first in the agency. And the participant first gives us ready access to over 5,000 participants that we can utilise for these bespoke activities. We have also recently launched NDIS Engage, which is our dedicated engagement platform within the agency, and we've, as part of that Engage, we've also put up there an ability for participants to volunteer and be part of our pilot over coming months.
So this isn't AI decision making then?
It's definitely not. What we've been really clear is the support needs assessment is a human-to-human interaction, and we want to make sure we get that right and have an opportunity to spend dedicated time with participants to ensure that we can meet all of the requirements.
So you've given me quite a good overview of the work that you've undertaken so far and the work that you're going to be doing in terms of more consultation and review around the hub. But what's going to happen from after you've finished that work, which did you give me an indication of how long that was going to take?
That will go right up to the commencement, but what we also have with the University of Melbourne and Centre of Disability Studies is we know this is a transition over a number of years, and we will continue to use many mechanisms to engage with participants and the broader community through that transition.
So the consultation you've undertaken, the co-design you've undertaken, and the further design work that you're currently working through now through the hubs, and once that's finished, the tool is going to be launched. Is that, have I got this right? Or I've skipped a step?
No, as Mr McNaughton outlined, it will be a progressive rollout of the...
but the tool will be launched and then progressively rolled out.
Yeah, and there may be ongoing modifications to the whole support needs assessment report as we start to transition more participants over the period of time.
So have you got to the point where you've launched the tool, you've rolled it out? How have you thought about how you're going to do, get the feedback, any changes that are required? Have you thought about what that's going to look like?
A core component of the contract with University of Melbourne and the Centre for Disability Studies is an evaluation and an ongoing evaluation as part of the rollout of the transition over that period of time. We also want to make sure that we are building feedback into the modifications, not just of the tool, but really importantly the experience between the assessor and the participant.
So but is that progressive? I mean, it's not like 12 months in you get an evaluation, or it's a progressive evaluation.
Absolutely.
Yeah. Okay. Well, it sounds like you've done some really good work. Well done.
Great, thank you. Senator Roberts.
Thank you, Chair, again, and thank you for being here today. I have some questions. It's very much a contradictory set of questions. I've got questions on fraud and questions on how to make more people eligible. So this whole NDIS, NDIA seems to be full of contradictions from the moment it started back in 2010 or whenever it was. Could I ask questions about the Fraud Fusion Task Force first, please?
Of course.
I had some NDIS data. I'm not sure exactly where it's coming from, but it's from within the NDIS. It says that for the June 2024 quarter, there were over 7,000 tip-offs, but only 16 prosecutions. Why has the task force achieved only 16 prosecutions in a quarter despite 7,000 tip-offs? Can you explain the gap? And I'm not pretending it's easy.
Thank you for the question, Senator. John Dardo, Deputy CEO, NDIA. The tip-offs that we receive may be treated through a range of mechanisms. So those mechanisms might be that we look at them and we're able to engage with a provider or participant and deal with it through education. The tip-off may require us to implement some sort of prepayment review where we nudge a person to give us some evidence before we pay a payment. It may be that we do a post-payment review, we do a historic review. It may be that we do a more serious administrative compliance intervention. It may be that we implement manual payment reviews where we stop payments until we receive evidence for each claim. And in the most extreme cases, we may revert to a criminal investigation and/or a prosecution. So it's really important to note that there's a spectrum of treatments depending on the severity of the tip-off and the efficacy of the tip-off. In some cases, we look at the tip-off and it's actually a misunderstanding and there's no substance underneath it that requires an intervention.
The tip-off itself is wrong.
The tip-off might be wrong, it might be misunderstanding, it might be, in some cases, it's malicious, somebody having a go at someone else. So it's really important that while we do measure tip-offs, and we have put an enormous program in to improve the way we capture, understand and process tip-offs, the volume of tip-offs of themselves do not indicate the requirement for a prosecution. And just while I am talking about tip-offs, once upon a time tip-offs used to be captured effectively on a spreadsheet. We have put in a range of system improvements to make those tip-offs more able to be captured in a codified way. So whether it's through the call centre or through our online systems, they're able to be captured in a way where we can code and then analyse the content of the tip-offs. The beauty of that is that as the volumes have increased, and they are increasing, they continue to increase, as the volumes increase, we're more able to run analytics over the top of them and understand whether the tip-off relates to previous tip-offs or previous treatments or previous risks, and then cluster them up or group them with associated intelligence or associated treatments. So those systems continue to improve by the week. But I just don't want you to assume that every tip-off is going to be a prosecution. That would never be the case.
Senator Roberts, if I may, Catherine Myers, Deputy Commissioner from the NDIS Quality and Safeguards Commission, as members of the Fraud Fusion Task Force who work very closely with the NDIA. Since November 2022, we have executed over 306 compliance outcomes, including 179 banning orders, 38 revocations of registration and 89 other regulatory outcomes. So in addition to the prosecutions undertaken, there have been a number of regulatory actions taken.
Restrictions imposed and banned, etc. Okay. All right.
And Louise Glanville, the Commissioner for the NDIS Quality and Safeguards Commission. I think the really important piece of this is that it's a very collaborative arrangement between the NDIA and the Commission, as well as other enforcement agencies. And the sort of development and growth of that, I think, has been particularly positive for being able to identify, better analyse, as Mr Data was saying, and understand what are the best actions that can be taken to address whatever the nefarious or other action is that has occurred. So I think that's a really important part of this process as well.
So it is a big issue to you, NDIS and NDIA.
To the Commission and the agency, yes.
Yeah, and it's also a matter of restrictions, but I'll go to total prosecutions and convictions for NDIS fraud. How many since the task force was established?
Yeah, I think it's really important that we step back. It's a metric that has a significant lag effect, and what I mean by that is that while you may start something,
plus the investigation.
Yeah, you may start something. There may be interventions that are lower level interventions, or they may rapidly escalate. Before search warrants are executed. It could be 30. In some cases, it's very, very fast. It could be, weeks or a month. In some cases, it takes longer. But even after search warrants are executed, sometimes there's a charge on the day, sometimes there's a court attendance notice, sometimes it takes another 6 to 12 months to get to a charge. And then to get in front of the courts. In some cases, we're seeing cases not getting in front of the courts for several years. So can I just flag, prosecutions is it's not a number that's a great indicator of the level of activity that is occurring. And it's certainly not a number that reflects just the enormous collaborative effort that's occurring across the agencies. I think. Our colleagues at the Commission have been phenomenal in partnering up with us, as have a number of other agencies, Services Australia, Tax Office and so on. So sometimes the interventions are actually better administered by other agencies in terms of interventions, or they're administered in partnership with other agencies. If you want something that's a more indicative number of activity at that sharp end, like the activity that you're trying to get to, at the very tip of the iceberg, we're talking just in the first 4 calendar months of this year, we did 35 warrants. That's more than were done in a whole 4 years before the task force was established, and that was just in the first 4 months. So if you're looking for an indicator of sharp activity, you can see we're talking 12-fold increase in activity in a task force. And can I just say that doesn't even scratch the surface of the things that happen underneath investigations, the interventions that occur underneath.
It's pretty daunting. I don't know if it was you, I think it may have been you who a year or so ago told us that you were overwhelmed and the court system would not handle it.
Look, it's really important to note, we've never said, and I'm on record, in this House on a number of occasions of saying debts, prosecutions, raids, they are the wrong metrics for a successful system. What we really are trying to build through all our big investments is how you prevent those bad things from happening. And so if you look at the big system investments that we're making, are trying to figure out how you make it easy for people to get it right, really hard to get it wrong. That means that all the people that are trying to do the right thing, which is the majority, are having a better experience, it's more streamlined, it's easier for them to get paid the right amount. They're less likely to get themselves into a misunderstanding. They're less likely to be abused by a non-compliant provider. So that prevention up front is overwhelmingly our mission. Everything we're building in the Crackdown on Fraud program is about building prevention up front so that you can safeguard participants and get sustainability. So whether it be improving the identity systems for the people that log in, which we've delivered, whether it be improving the identity systems for the providers, which we've now delivered, whether it be improving the evidence requirements for claiming so we're more confident people are getting right, which we've partially delivered and continue to improve, building a data analytics system that allows all that data to be pulled together so we can identify risks and stop at prepayment where we can, whether it's working with our partners to have those risk detections so that we can identify providers that are problematic and exit them from the system at the earliest opportunity. All those things that prevent bad things happening, that has to be the focus. You'll never get rid of the need to raise debt or prosecute. Like, that will always be something in the arsenal. We will need to be good at it, but it should be the last resort. You would hope that, whoever replaces me in 2 or 3 or 4 years' time is sitting here saying, actually, we only had to do 5 prosecutions because the systems work so well we didn't have to prosecute.
What you're saying makes perfect sense. Nonetheless, some people will bypass just about everything.
Yep.
Deliberately. Have there been any custodial sentences handed out?
There have been, absolutely. And not only have there been custodial sentences, there have also been successful confiscations of assets. So there are people that have gone to jail and are serving custodial time. There are people where we've grabbed, $4 or $5 million worth of assets from them. We have cases in progress right now where we've worked with partners, whether it be state or federal, to put seizure orders on, in one case, 33 houses and 3 cars. A provider. Let me emphasise that was a provider, right? So we absolutely, custodial is in the tool set. But remember, custodial's got to be an outcome from the courts. We don't get...
Which can take months and months.
It can take years, and the courts, we can't... At the end of the day, the court makes the decision about custodial. We put our best case in the brief, the CDPP puts the best case in front of the courts, and the courts make the decision.
I'll say it again on the record. What you're saying makes perfect sense to me. So I commend you for that. I don't know whether you're doing a good job or not, but it sounds like the right approach to me. So,
Just checking how much more time you need, Senator Roberts.
probably 5 minutes, please, Chair.
Okay, no problem.
Well, my subsequent questions are not really necessary because of the comprehensiveness of your answer.
Can you put them on notice then? Is that what it means? To know.
Apparently you stated that a survey showed 90% of a group of plan managers exhibited signs of fraud.
Absolutely.
How many of those cases have been referred for criminal prosecution?
So again, let me and that was a discussion that I'm pretty sure we had in a previous Senate estimates. So it was a particular subset of plan managers, so it wasn't every plan manager, so it was the plan managers that had between 0 and 100 clients. And I know that sounds weird, but you can have 0 clients because you had clients and you're not claiming for them right now. But plan managers that are between 0 and 100 clients, there were roughly 1,000 in that sample, and about 899, to be exact, at that time when we did the analysis, had indicators that we would think are associated with potential fraudulent behaviour. So again, there's a range of interventions that we've applied there. In some cases, we have put prepayment reviews on them where they can't be paid unless they provide evidence for their claims. And if those prepayment reviews, they turn up and they provide evidence that's problematic, that we look at it and we go, that looks like you're falsifying your invoices, or you're claiming for things that are not remotely connected to the scheme, or you're claiming for participants that are not getting service, then we will work with the Commission to remove them from the scheme. So that's an intervention that may or may not go to a prosecution. The other intervention that we've applied is that we've asked them for requests for information for historic claiming, and we've gone back and looked at their historic claiming. We've just done another sample of 47 where the majority of those had problematic claimings, and so we've referred them either to the Commission for banning, or we have removed their ability to claim from us. We're working through those. In some cases, we executed search warrants with our partner agencies. In one case, we, the Commission, the Tax Office, and some other regulators targeted the plan manager. That so access through a search warrant. Tax debt raised, banning orders from a number of regulators, the Commission and other regulators, to remove them from multiple schemes, and that case. May proceed to prosecution and we'll work our way through it. And in that case, debts were also raised from multiple agencies. So there's a spectrum of treatments. We are not going to prosecute every single plan manager that we said had fraud indicators, and there may be some where we look at them where we go, the fraud indicators are there, but they didn't lead to anything.
Okay, final question. How will you know you're being effective? And how will we know you're being effective? How will we know that when fraud is out of the NDIA?
Yeah. Fraud will never be completely out of the NDIA, just like it's never out of any scheme. There will always be a level of it that just exists, and you have to continue to innovate because it's an arms race to stay ahead.
Stories are rife.
They are. So it's continuing that work for prevention. That has to be the overwhelming focus.
How will we know if Mr. Dardo's done a good job? I mean, it sounds good, and I'm not being patronising. I sincerely mean that. It sounds good. What you're saying makes perfect sense. You're managing the process, which is what very few managers understand. Look, so how will we know that the process has good outcomes?
The first time I came here representing this agency, I sat in this room and we rattled off the half a dozen things that needed to be built out as capabilities. We talked about, the vulnerabilities in the scheme, identity, the way claiming was working, the way providers were interacting. We've rattled those things off. And when we sat down and imagined the program of work that would address those things, which government funded, that program of work clearly articulated those layers of capability that needed to be built and delivered. And you can't, you build the foundations and then you've got to keep building. But we then laid that out as a program of work, or the crackdown for a program of work, the systems uplift. That systems uplift was funded by government. In February 2024 it commenced, and we have delivered every single milestone in that program of work between February 2024 and now, on time, under budget, or let me rephrase that slightly, within the timeframes that we promised we would build it, because we started 2 months later than we said we would, so a couple of things have finished a couple of months later than we said we would, but within the timeframe we said we would build it. And so one indicator for you that we're doing a proper job is that we are building those layers of defence on time, and as they go into production, we can actually see that we're stopping things happening that used to happen or that used to be completely invisible. So we are now more confident that some of those things that we promised should be there are there. The journey's not finished, we've got a long way to go, but it's how we deliver on those promised uplifts so that the system is less likely to be open to abuse by those that want to abuse it.
And then would you include in that an audit of the systems to make sure the systems are working as you say?
I can assure you we've got eyes, not just our eyes, everyone else's eyes on it. The ANAO, the ANAO comes and look at us and make sure that we're actually building what we said we were going to build, and we're building it on time. The Department of Finance Gateway Reviews comes and looks at us and says, you promised this, did you build it, has it been delivered on time? So there is an enormous amount of independent assurance that's coming and looking at what we promised for the money that we got and whether we've built it to the standard that we said we would. And in addition to that, we've got independent assurers that work on the program with us that write reports for government about whether we've delivered what we said we would build on time, on budget. So the scrutiny is impeccable.
Thank you. Thanks, Chair.
Thank you so much, Senator Roberts. Senator Ruston.
Thank you very much. I'm just wondering, how many complaints has the NDIA or the department received from providers concerning late or non-payment?
I don't believe the department's received any complaints of that nature.
Where would they go?
Well, can I just clarify
sorry, I was going to say, you can't
to?
say that because I gave you one.
Sorry, can you just clarify what the payment is?
Well, payment to providers.
Late payments to providers.
Yeah, how many complaints has the NDIA, the department, received from providers? Well, so I'm not a provider, so actually you don't count me, but it was on behalf of a provider, regarding late or no payments. No.
I'll attempt an answer, Senator. John Data again, Deputy CEO.
I don't want an attempt, I want a number.
Yeah, it's a difficult number to give you, and I'll explain why. I'll just use one example. We have one manual payment review on one provider right now. That provider has probably lodged in excess of 200 to 300 complaints in relation to that manual payment review. Those complaints are via emails to myself, to members of Parliament, to...
Okay, maybe I can help you out a little bit, Mr Dardo. How many providers have you received complaints from?
Yeah, that number I would have to take on notice, Senator.
Okay, thank you very much. So actually, earlier today, Mr Comley, your officials in health actually agreed to provide speedily some advice in relation to the use of the Medicare, or the requirement for the use of the Medicare logo on clinics that were bulk billing. I wondered, did your department ever get that information for you?
I believe there was some information available, but it wasn't complete, and then we moved on from the outcome.
Yeah,
so
okay.
I can check whether the officials are still here who had that info. It wasn't passed to me.
Okay, thank you. Just in terms of the obviously the amount of media that's been generated around the NDIS and the NDIA at the moment, there was another story in the AFR yesterday, and once again seeking for you to give you the opportunity to clarify or verify the claim in it. and it was an article, what was the article titled? There is no evidence NDIS therapies help kids thrive. So I don't know whether you've seen that article. But in the article, and it says, and I quote, that there's been $5 billion per year into therapies without any evidence they are improving health and educational outcomes. Is that a fair statement?
Senator, I'll ask Mr Gifford to give some data that we collect through our outcomes frameworks, where we actually do collect information around the outcomes through therapies and others. So
No,
we can.
I'm really just seeking, is this statement correct or isn't it correct? I'm just giving you the opportunity to put on the record, because if the statement's not correct, I'm assuming you want to say it's not correct.
Senator, I think we would not regard the statement as correct that there's no outcome achieved. I'll just quote a few figures. Sorry, David Gifford, Scheme Actuary. Apologies. I mean, for example, participants who've been in the scheme, in the NDIS for at least 2 years, report an overall increase of participating in social and community participation from 34% at entry to the scheme to 41%.
Yeah, sorry. I'm sure you can come up with a whole heap of statistics that sound great, and that's good.
Yep.
And I'm sure your participants think that's good too. This is a statement that has been put on the public record in a reputable paper. It is attributed to a previous senior staff member of the NDIS. I just wondered whether anybody, maybe this is one for you, Mr Head. I mean, can you say that there has been no evidence in any bodies of work that have been done within your agency that would suggest that $5 billion a year are being invested in therapies that there is no evidence they are improving health or educational outcomes? I'm just giving you the opportunity to say that's not true.
Senator, I don't want to cut across Mr Head's
Well, you
opportunity to
are.
answer the question, but I think it is a very broad statement. I think one of the things that's fair to say is that there isn't a lot of evidence about the intensity or the quantity of therapy that some participants in the scheme get. For some participants, it's quite clearly highly beneficial and life-changing, but for many participants, they can be in a pattern of very regular therapy, particularly for children, where we see some children receiving up to 40 therapy sessions a year, when there isn't a lot of evidence about what the right intensity or dose of those kinds of supports might be. That lack of clear line of sight to the evidence in the case of an individual's experience in the scheme is one of the reasons that the NDIS review recommended the formation of the NDIS Evidence Advisory Committee, which the government funded, and my team is now responsible for standing up. And we have worked through, including taking material to Disability Reform Ministerial Council to set out a work plan over the next 12 to 18 months, which includes looking at some of those issues. So what types of therapy might be what's the evidence about the types of therapy that might be most beneficial for certain participants in certain circumstances at a particular intensity or dosage. So we are recognising that there is a need to build that evidence base, and we've started to implement the Evidence Advisory Committee to address that issue.
Okay, so I can read into that the statement may well be true, but you are taking action to make sure that you remedy the concerns that statement would point to.
I think that's true. It's a fair characterisation, but I do think it's also a very broad statement. It may not apply in all cases, so just with that very bureaucratic caveat.
Yeah.
I think the other thing I'd add, and the Evidence Advisory Committee will look at this, that it is actually, in this space, there is also a contest about the type of evidence that is compelling in this case. There is a lot of evidence that is self-reported for participants about how they feel it's improved their functioning or life skill. There are other evidence that might be closer to what we might see, for example, in the medical system, which has more of a kind of, plus double-blind or other form of evidence that has more quantitative dimensions. So we're looking into that.
Sure.
And an example of that might recently have been the Duckett Review, which was into music therapy.
Yep, absolutely. Thank you. So I'm just interested, in relation to complex support needs pathway. Is that you?
I'll get Ms. Stangel to join me.
So, Ori Chestnut. Hi, thanks. I'm just wondering if you could confirm that this pathway is now only accessed by agency staff referring a person at the discretion of an internal NDIS planners and subject to cost considerations. Is that correct?
Thanks, Senator. Jodie Stangel, General Manager for Specialised Service Delivery. The complex support needs referral pathway has always been an internal pathway. It's never been external. The pathway was originally designed to ensure that we're meeting the needs of people with quite complex needs. The pathway is also designed as to ensure that we're hoping that people don't actually stay in the pathway for a significant amount of time.
Yeah. So what you're telling me is there's been no change?
There's been no change,
Great.
Senator.
Thank you. Easy. Okay. Well, that answers the question. We can get through them very quickly when we do it this way. NDIS cost assessments. Right person? You, Mr McNaught? No?
Senator Ruston, cost assessments of the scheme overall or
no, there was a report from
individualised?
the Australasian Psychosocial Alliance about access to the NDIS for people with psychosocial disability. Is that something I should have gone to health on, is it?
No, well, it depends.
It possibly could have been, because if it's not in the NDIS, it probably should have gone to health.
Perhaps if you ask your question, Senator, we will see who's here and who might help best help.
I suppose the questions were more around if somebody's applying to the NDIS with a complex psychosocial condition, I'm just interested to understand, what kind of costs will that person be expected to incur in order to make application? Because we've heard stories, and this report also highlighted that they could be asked to pay $1,750 for a psychiatric assessment, or $1,200 to access their own medical records, etc., in order to provide the information to the NDIS to make an application. So I'm just keen to understand if that's true.
Senator Scott McNaughton, Deputy CEO, I'll take that and attempt to answer it. Obviously, for anyone applying for the NDIS, people with psychosocial disability, we assess against the age and residence criteria, but also the disability criteria. So with that, we rely on a range of information from the person's treating health professionals. They can get that through Medicare, through their GPs or others. Others may bring allied health reports, psychologist reports if they have them.
I'm just interested in the cost of those. I mean, I accept that you have to have those reports, otherwise you can't make your assessment. But this report is from the Alliance was concerned about the cost to these people. Often these people are on a disability support pension. The cost of them being able to get access to the material in order for them to apply to the NDIS. I'm just seeking whether that is a fair thing for them to be saying.
I think we would, Mr McNaughton will have better information, but I don't know that we would collect data about that issue in particular because it's not the NDIA funding that process.
Well, it's sort of like, I suppose, if you are requiring these reports, and reasonably you should, what processes are in place to provide an equity proposition for somebody who couldn't reasonably afford to go and spend $1,000, $2,000, $3,000, getting the necessary information that they would need to make an application to the scheme. Is there anything in place for people who do not have the wherewithal to be able to source the data that you quite rightly need in order to make an assessment of their application to the NDIA?
Senator, quite often we see people who are accessing those reports through Medicare funded, through their general practitioners and others. That's the primary mechanism where people haven't got any other means. So we do see people using the Medicare funding items for those reports too.
Okay, so there's no real restriction to somebody who would want to get a report. There are pathways that would always allow them to get the reports that you would need.
Treating health professionals through the general practitioner can fill in an access request form and can fund that through Medicare.
Okay, that's good. Just following on from the questions I asked you at last estimates about the fact that the NDIA seems to have freedom of information disclosure, their disclosure log is completely different. I mean, Mr. Comley's got a very open disclosure log and you don't seem to have one. Just wondered if, since the last estimates, that there'd been any movement in terms of rectifying that.
Thank you, Senator. I'll get Mr. Swainson to cover that off, and also the nuance between a lot of where it's participants' own information.
Oh, you
about the
totally
disclosure
understood
log.
that.
So,
I think we accepted that last time, but you did take it away and say you'd have a look at it, and I just wondered if you had done anything.
I'm pleased to say, Senator, we've had a very good look at our disclosure log arrangements subsequent to the last estimates. I think we have provided some information through the process on notice, just to give a bit more context to this body about our process in place at the moment that do allow somebody to obtain that information within 5 days, but we've heard you and heard this Senate, and we will have arrangements which align with the Department of Health's disclosure log early in the new year.
Thank you, that's great. And just finally, I have been asked by a number of people to seek your help on particular cases, and I certainly understand that you're not going to comment on individual cases, but I appreciated the work that you did for me after the last estimates in resolving an issue, a gentleman in my home state of South Australia who had a challenge with the DSOA and having his funding cut, and I thank you very much for rectifying that. I can tell you he is a very grateful person that it was eventually resolved, and I can't tell you how relieved his wife is too, so thank you. So I'm going to have another go and see if I can make it work again. Talking about a 66-year-old who sustained C3, C4 spinal cord injury back in 2007, primary diagnosis of quadriplegia. Previously, he was 2-to-1 for transfers, pressure care, showering, dressing and toileting, and 1-to-1 at all other times. And so he was in receipt of 2-to-1 for 8 hours a day and 1-to-1 for support for all other times. The NDIA this year reduced this person's supports. The practical effect of it saw that care was reduced from 24 hours a day to 15 hours a day, and the monthly spend was reduced from just on $60,000 to $25,000, so it's been more than halved. The decision has been described by a health professional as clinically indefensible, and that there was not one single piece of medical evidence that is supportive of what the NDIA has done. So we also have heard that this person's care workers are now working for free in the times that are no longer available to them. So I suppose I'd be keen to understand, on the surface of that, if you are a quadriplegic, one would assume, but I'm no medical expert, that they would need 24/7 care. So I suppose as much as anything, would the department minister, the NDIA, be prepared to review this decision, because it seems quite incredible that the NDIA could justify more than halving somebody's support against what is quite clearly the advice of medical professionals, that it is just manifestly unfair.
Senator, Scott Norton speaking. Obviously don't know the individual case you're referring to, but
it's all right, you will in a minute because I'll give them to you.
Thank you, Senator. I'm more than happy for you to refer that in through the office, and we'll have a look at that to make sure they're getting the right disability supports they need.
And we've got another situation, a 36-year-old person who suffers from a rare autoimmune condition as well as severe brain injury, and cared for by their parents. Got an assessment from the NDIA and was believed it to be manifestly inadequate. Subsequently went through a process to get it reviewed. The NDIA have agreed that their original assessment was not correct, and funding has now been increased. During the period of time when the person following their brain injury was not able to get the services because of the decision of the NDIA, service providers were continuing to provide services to this person because they clearly needed them, and throughout the process this person and their family was assured that if there was a change in determination, any outstanding, that the funding would be paid for. This person now has a $60,000 bill with their providers that looked after them during the period of the reassessment, and despite being regularly told that money would be paid, subject to the review, they've now been advised that it's not going to be paid, and so they're left out of pocket by $60,000. And I was hoping you would look at that one as well.
Senator, it'll be the same pathway. If you refer that in through the office, we'll have the teams to have a look at that.
Yep. Okay. Chair, I'm going to send it back to you. Thank you.
Well, thank you, Senator Ruston. That's in record time. Senator Steele-John.
Thank you very much, Chair. Can I just clarify, under the new needs assessment process, the only decision that a delegate will be able to make in relation to the budget that has been generated will be whether or not to accept the assessment which has been generated, the assessment which has then been used to generate the budget, to accept whether or not that assessment was correct, and therefore the budget was generated based on the correct input or not. That's the decision before the delegate under this new structure, isn't it?
Senator, that's part of it. There's also a few other decisions that the delegate has to make, including the duration of the plan. As the Minister said earlier, one of the things we are looking at trying to work with in response to participants is move to much longer plans than we have today. 3, 4, 5-year plans, depending on circumstance. So the duration of the plan is a decision. The funding periods, so the funding periods of the plan management type, what parts of the plan are flexible versus stated in the system. If there's any other requirements on how certain supports must be used. As you said, whether or not to order a replacement assessment, because there was issues with the current assessment. And whether or not, and this is still in the Design Centre, we need to commission any other of those modules I talked about. Disability health related supports, home modifications, assisted technology, behaviour supports. So there is a fair few things the delegates will need to go through as part of that decision-making process.
Yes. Okay. But in terms of the input, which then, are you saying to me, Mr. McNaughton, that those other factors materially impact the total funding amount?
The latter, those modules might. The module
yes,
I talked about, those modules might.
Okay.
The 3 or 4 modules. The others impact the
That's
construct
about how
of
you
the
use
plan.
it in the construct of the
That's
thing.
right.
Okay.
Yes.
All right. In terms of this, thank you for clarifying that. In terms of the new process that you've set out, has the agency done any modelling on whether the new framework planning process will save the agency money?
Senator, I'll ask the scheme actuary to come up and give some advice about the modelling around the scheme in terms of the implementation of the NDIS reforms. Is that the specific question?
Well, that could be a very long answer. I'm specifically looking at the new assessment process that we've been discussing all day, and that is the topic of conversation. I want to know if you've done any modelling around whether the new framework planning process will save the NDIA money.
Senator David Gifford, Scheme Actuary. So, as has been communicated in the past 2 annual financial sustainability reports, there are assumptions built into projections of scheme expenditure around the impact of new framework planning, and that there will be savings associated with that. I'm not sure if this was your question, but we haven't done any specific modelling or more specific modelling with the support needs assessment and the budget method, because as has been provided in previous evidence, a number of those, the specific rules are being still determined. So there's an overall allowance within projections of scheme expenditure, but not specific allowance in terms of any of the rules themselves. If that
All right.
helps.
What's the overall allowance for the new framework? What did you describe it as? The new framework.
The new framework planning.
Yeah. What's the overall?
Yeah. So over the forward estimates, the current forward estimate period, which is the 4 years to June 2029, it's approximately $9 billion. $9
billion.
$9 billion out of from a baseline of approximately $230 billion. Yep.
And that will move up and down based on how the rules are written.
That's correct. Yeah, that's right.
Okay. Now, what is the timeline for the writing of those rules? When do we expect to have?
So that's probably more of a question for the department. So we're currently working. We have a number of rules that we're preparing. Some of them are quite well advanced. I would say they're probably the more straightforward rules. So, for example, there's a rule that would go to the way that participants are transitioned into the new framework planning approach. There are a range of other rules that are kind of more administrative. The rules around the support needs assessment and the budget model are being developed in parallel with the agency's work around the design of how they propose to operationalise it. So we are working very hard to finalise, I guess, the drafts of those rules with our state and territory colleagues, as well as the agency and the disability sector, with a view to iteratively agreeing them. But the new framework planning approach is to progressively start from 1 July next year, or mid next year, I think, as Mr McNaughton said. So those rules would need to have been agreed and be registered by the Minister in advance of that date. So we're probably looking at really wanting to have reasonably settled rules in the first quarter of next year.
Okay, thank you. Now, going to Section 30A of the NDIS Act, as amended by the Parliament last year, is that now in effect? And if not, when will those changes be implemented?
Sorry, I'm just getting a bit of a...
James McIsaac, First Assistant Secretary, NDIS Participants and Performance Division. Senator, that particular rule which was brought in around 38 was around eligibility reassessments. There's yet to be any further work in terms of looking at any changes to that eligibility reassessment process.
So it's a rule-making power, but
Yes.
it's not been brought into effect at this
There's
point
not,
in time.
and there's no implementation time frame for that?
Not as yet, Senator, no.
Okay. Now, I've been hearing from disabled people with complex or chronic health conditions that they are facing still many barriers getting their conditions recognised by the agency. Common complaints I've heard are that the NDIA staff do not understand a person's particular condition, why certain treatments are not advised or simply not accessible. Now, I'm aware that on the NDIA's website there are some guidelines around the use of reputable websites for researching conditions. As part of this, the NDIA advises staff that websites like the Mayo Clinic should be used for general educational purposes. Can you please confirm that this is still the NDIA's policy?
Senator Scott speaking. Scott McNaughton speaking. We have a number of resources that our staff and our eligibility branch use. We have access lists which help determine, you know about the access lists, list A, B, C and D, so they help to provide a guide. We also have a series of disability snapshots that we've built with the sector. We also have another range of external resources, and internally we have our technical advice and practice improvement branch, who have a series of allied health and other clinical supports within that group for more complex access determinations. So our access team will make a referral into that group if they need more evidence or support of those more complex cases that you talk about.
Yep. But the guideline that I refer to here, which advises that staff can use references to reputable websites like Mayo, is that guideline still in use? Is that still your policy?
I'll have to take that on notice. I'm not exactly sure of that referral, but we'll see if we can get that through the hearing, Senator.
Do you have a reference for, sorry, Senator Steele-John, I just wonder if, to get a better answer to your question, you might table or otherwise provide a reference to the document you're looking at?
I can do. I'm short on time.
Yep.
But it is one of your formal. It's one of your formal and available guidelines. It was also quoted in an FOI, which I can give you the number.
I think that sounds
for.
good.
That's FOI number 24-25. -1836 was the number of the FOI, that there is a link in there.
Perfect.
Now, I'm just wondering what the current policy or new policy is in relation to gathering information on a participant's disability. So, what can you tell us there in terms of how we might go about gathering information on a participant's disability?
Senator, can I just clarify, are you talking about current state, how we're currently operating?
Yeah, current state at the moment.
I'm not aware of any significant changes to how we've reframed any of those settings for gathering information.
Okay.
There haven't been changes to Section 24 or 25 of the Act in terms of that, so I'm not aware of any specific changes you're referring to, but
okay.
Again.
So can I clarify then, does the agency's policies in relation to AI or generative AI allow that to be used when researching a participant's disability, as long as it isn't used for the disability itself?
Senator, it's really important that for all decisions that we make, whether that's access or eligibility reassessments or planning, they're always made by a delegate of the CEO, that is a person. They're not made by any of those other sorts of things that you're referring to. We have staff using a range of resources. We have said within our planning cohort of our staff that not to use AI to help with planning determinations, and some AI systems have been blocked from our agency computers. But we are taking quite a measured and risk-based approach to how we embrace technology to improve outcomes for participants and efficiency. But there is always a delegate making a decision, Senator, at the end of all of those key things under the Act I talked about, whether that's access, planning, eligibility reassessments and reviews.
And I'm just wanting to clarify, because I know I've read a bit recently around your clarifying statements around the use of AI, but I'm specifically asking here around what guides your employees when they are researching a topic, a disability that they may not have come across before, or a chronic or complex illness. Are you saying that you kind of are not allowed to use AI in that research process, or that you are, but not allowed to utilise those tools in decision-making processes?
Senator, very much not allowed to use those tools in decision-making process. How our staff will engage through a Google search, through the internet or others, to find appropriate websites, and as you said, we've given some guides on those. We have instructed staff about some reputable websites we would prefer people use, and that's the guidance that we've provided to help with any background research to support decisions.
Yes, okay. So you can use it for background research?
You can use what's available on the intranet, and we've given some guidance around that.
Yeah, okay. Now, in terms of quality assurance, how do you build quality assurance into the process of what is available so that you don't have disreputable or outdated sources that sit there in your internal intranets to be used in these processes?
Yeah, we have a couple of ways that we do that. We have a quality decision maker process within our scheme eligibility branch, and Ms Stangel might come up and talk about that process, where our access delegates will have their decisions quality assured by a senior quality delegate before decisions are made. So there's a range of processes that we put in place to support decision making. to ensure they've used all the available evidence to do that. So if that would help, we can give you a bit more information about how that process works.
Yep, it would, and I'm particularly looking again, if we're looking in the space of background research, my concern is that the phenomenon known as AI hallucination can take place, where as you're researching a certain topic, the biases inputted into certain programs can basically chuck up really bad information. So I'm trying to ascertain what protections are in place to make sure that as your planners are utilising the resources you provide and the other resources they may access, they're not accidentally feeding in poor information from these systems.
Thanks. And Mr Angel can talk to all the evidence that we use to support that decision.
Thanks, Scott. Thanks, Senator. I'd just like to add on top of what Mr McNaughton was talking about in terms of reputable information, and Mr McNaughton did talk about particular disability snapshots and other evidence. It's clear to say that on our internal website too, we have very reputable information about specific disability types, and if we don't, we actually utilise the technical advisory branch, who obviously clearly are our internal advisors that have quite significant experience in multiple different areas, and are also our advisors that work very closely with peak bodies if we don't have the right information about somebody's specific disability as well. And we continue to do a whole lot of groundwork obviously around that each time. Mr McNaughton talked about our quality officers in scheme eligibility branch. Their role, once a access assessor has gone through the eligibility requirements for the scheme, which is age and residency and permanency of disability, will then go through a quality check through senior experienced staff that obviously have the right qualifications to be able to do that, but also their role is to also link in with our technical advisors. And I think, Senator, you mentioned people access to the scheme that might have disability-related health supports, and that there might be some interest around whether we actually have the right evidence and information in relation to that. Our quality officers are obviously, their role is to ensure that we do have the right information, that we are reaching out into the right sources.
Yes, I understand that, and thank you. That speaks to your internal processes, and I understand those. I guess the problem is that in your background research policy, it does mention being able to use the internet to research conditions, and it suggests a number of reputable sources that you might go to. But the reality is, these days, if you are Googling something, you are very likely to have a top search result or a top part of your screen that includes the recommendation or summary of a generative AI model. And they are profoundly and quite often wrong about the complexities of somebody's particular condition. Now, I am seeing that kind of AI slop medical research ending up in planner responses or agency explanations to participants who then contact my office with very complex intersecting conditions who have been denied support or access or funding, and the reason given in the plan is exactly what you find if you just Google it and accept the AI slop response. So something isn't working here, because I'm seeing too many of these over the last 3 or 4 months particularly.
So we certainly give our staff a range of guidance and materials to support and do what we call justified decision making. I'm more than happy to have a look at those individual cases. I'm quite interested in that to see those from you. It's something we continue to work with our frontline workforce about: quality justification, quality decision making, having the right evidence to support your decisions. And we have a very strong quality assurance framework, as Mr Angel talked about, in access, but we also have it in planning to continue to do that. But it is something that we'll continue to make sure we're building the capability of frontline.
Just so you know, Mr McNaughton, this is a case that's been given to me, so you've got it directly. In a recent NDIS rejection, the scheme had rejection from the scheme. The Cleveland Clinic was cited, and the Mayo Clinic was cited as a reference for determining as to whether the participant had tried, quote, tried all of the treatment for POTS slash another condition. However, upon investigation, the NDIS appears to be referencing a public-facing website content piece from these institutions rather than peer-reviewed clinical evidence or literature or evidence-based guidelines or comprehensive medical textbooks. And we've seen this a number of times with particular reference to the Mayo Clinic and to the Cleveland Clinic, where quotations are used from those websites that are the web pages of reputable institutions, but they are just the web pages, to support decisions made by planners in relation to complex conditions that otherwise cite no clinical evidence for that outcome. So we do actually have a situation where what I see and my team sees is the outcome of planners taking very surface level pieces of information and citing them because they back up a decision to deny support, where actually peer-reviewed, scientifically verified information had been cited, an access decision could have turned out very differently. So that's our concern.
Senator, I think, as I said, we have very good, robust guidelines and practices in place. More than happy to take on and have a look at those examples that you've provided. We always want to continue to build the capability of frontline. We do.
Yeah. I can't have another bunch of participants come to me in such distress because somebody's used Google. It's just...
Senator, if you pass some of that feedback through to Ms Dangerline, we'll have a look at that and continue to work with our frontline on making sure we're making good evidence-based decisions through the justification.
Okay, thank you. Thank you, Chair.
Thank you, Senator Steele-John. That concludes the committee's examination of the Health, Disability and Ageing portfolio. Thank you to all the witnesses who have appeared today. I remind senators that the committee has agreed that any written questions on notice should be lodged with the Secretariat by Thursday, the 11th of December 2025, and that answers to questions on notice are due by Thursday, the 29th of January 2026. There was a typo in mine. We will now suspend for our afternoon break until 5 minutes past 4.
Well done, Chair.
Broadcasting. I invite the officials from the Department of Social Services to come to the table. I now welcome Senator, the Honourable Katie Gallagher, Minister for Women, Government Services, Finance and Public Service, representing the Minister for Social Services. Minister, did you want to make an opening statement?
No, thanks, Chair.
Great. I will also welcome the Secretary of the Department of Social Services, Mr Michael Lai. Mr Lai, did you want to make an opening statement?
No, Chair.
Great. I will now call the officers from the Department of Social Services in relation to the whole of portfolio corporate matters, and I will invite Senator Little with the first call.
I'm going to start with the APS Capability Review 2025, if you can help me with that, thank you.
Excuse me.
Thank you. The review identified that strategy capability is currently rated as emerging, and stakeholders describe the department as reactive and sometimes caught out preparing too late for unforeseeable milestones. According to that review, internal and external stakeholders actually agreed that DSS does not have the strategic capability to meet future demands. Can you tell me what specific measurable steps DSS is taking to rapidly uplift so that you can respond to strategy?
Yeah, Sarah, I might make a brief comment and then hand over to my colleagues, but that's right. The review identified strategy and policy capability as areas where we needed to develop. The department's doing a number of things. One of the things we're doing is looking very critically at where we use outside consultancy. We've probably tended to throw harder problems, more complex problems to externals, and therefore lost some of our internal capability. And so we're looking very deliberately at in-housing some of those tasks. The executives looking at learning and development, specifically, we're anxious to kind of invest in high quality policy capability courses and not low value courses, and so we're going to invest in that and direct our staff to do that in an environment where the department's reducing in numbers. We're maintaining our commitment to a graduate intake to make sure that we're bringing new people into the department and fostering that capability that way. So they're just a couple of things that we're doing.
And how does that align with the Shaping DSS work program in terms of the review and that piece of work?
Well, the Shaping DSS is the sort of way in which internally that we're kind of moving on the capability review, where we've done a bit of work around identifying what the top priorities for the department are, and also working with our minister to make sure we're on the same page in that respect, and they're the things that we want to invest the greatest resource in to make the biggest impact. And so that we've been through an exercise both internally and with the government with the minister around that.
Okay. And in terms of the machinery of government changes, how will leadership ensure that staff understand and therefore reprioritise some of the work that they are doing, including the difficult task sometimes of stopping the work that you're doing and scaling back things that are lower on the priority list for DSS?
Yeah, so as well as identifying high priorities, we've also had a program of Keep, Stop, Start, which is really asking all of our staff to identify areas where there's activity which they think is low value or low priority, and we've made an effort to try and action those. So, for example, in a lot of areas, the level at which we approve certain things has risen over the years, and we're trying to push delegations down so that staff, don't have, 4 or 5 people in the food chain correcting their work. I suppose the quid pro quo of that is that we need that work to be right, so we're also investing in the staff to produce good material.
Right. This question is asked in the context of innovation. The department's capability was assessed in that in terms of managing risk as developing and driven by a tendency to be compliance-driven and risk-averse. Can you tell me what you're doing to make sure that you can actually respond innovatively?
I think that finding by the capability review is right, and the executive's belief is that stems from the department's correction from Robodebt, and so there was rightly a focus on making sure that we operated within the rules, that people felt that the organisation had integrity. And so there's been a lot of work done by my predecessor on that, and that's established a good base. But it has meant that people are less likely to engage with risk, provide bold advice, and so that is where the work we're doing around improving our policy capability is particularly important to get people to kind of be prepared to speak up and say, well, this is the direction we think we should go in a policy sense. We can't lose that focus post-Robodebt on integrity, but we do. We've been quite conservative in the advice we've given government.
You've got 48% of staff that recognise failure as only 48% recognise failure as part of innovation. How are you going to change that? We are encouraging. One of the things that we talk about in the department is that there's nothing wrong with putting advice to government and getting told no. The problem is when you don't put advice or you don't put a view to government, that's a worse problem than getting told that someone doesn't like your ideas. And so we're really encouraging people to chance their arm on the policy side and do that at the same time maintaining that we're working within the rules. So that same report also looked at the efficacy of and leveraging from the work of subcommittees and their purpose, including more frequent meetings that actually led to an outcome. Can you tell me a little bit about how you will ensure that they will become more active and purposeful, and therefore staff will be more engaged in those processes?
So we've just been through an exercise of refreshing that, what we call our second tier of management committees. So, but really we've got to make sure they meet regularly, that the membership of those committees reflects the whole of the department, not just particular streams of the department, and that we're bringing the right issues before those committees. So to give you an example, we've done a refresh in our policy committee, and we're making sure that some of the complex policy work that we want to bring forward in the budget context, that there's a chance for people to talk about those ideas and contribute, regardless of what stream they come from, and contribute to the effort on that. So it's just hard work, and that we've got to put in there, and myself and my deputies, my executive, are all invited to come to those committees and make sure they're active participants, but also to make sure that there's good contributions from across the department.
So in terms of collective impact, the internal collaboration part of that review was rated as emerging. Can you explain a little bit about what sort of work you're doing to make sure that there's cross-collaboration and there's a breaking down of silos, so that people understand about contributing to collective impact and not individualism within the workplace?
Yeah, well, to give you an example, we're doing a lot of work around family and domestic and sexual violence. That work crosses over a number of streams in the department. So, on the family and community side, we fund a lot of services to respond directly to the impacts of family and domestic violence. In the social security stream, we are looking through the child support system and the social security system at the weaponisation of those systems, and also assistance that goes to people who are impacted by family and domestic violence. And And so what we're doing is we're asking the people who have the responsibilities on either side of the department to work together, and they're doing that collectively, where previously we might have pursued those issues in different stovepipes, and so they're very, very connected issues, and so that's we're kind of encouraging that as an executive of our staff.
So these questions kind of all relate to organisational change, which is not necessarily an easy thing to do. How are you making sure that organisational change and the expectations of driving that are coming from the top, but also being driven from the bottom, because there's permission to actually participate in that process and benefit from that process?
Yeah, so I mean, again, the keep, stop, start piece of work, everyone in the department was involved in nominating things that we might stop doing to improve efficiency and make sure we're focused on the right things. On a monthly basis, we have an all-in staff call where we talk about issues important to the department and the direction of travel, including the outcomes of the capability review, and the executive take questions from anyone in the department who wants to raise them. And we do that on a regular basis. It's a chance to talk with everybody about how we're tracking, but also then, people have got challenging questions to ask when they don't agree with things, and we're making sure that we're accountable on that front.
So we've talked a bit about people and the importance of people as a resource to health performance. What about structural issues and such as IT systems? Because the review also talked about that contributing to some of those inefficient processes and outcomes.
Yeah. I mean, a very large percentage of the of our staff census result, and also in the capability review, was the standard of our ICT. So we've been paying particular attention to that. It won't surprise you that the main irritant is people having dependable ICT that supports them to do their job each day, and that when we have outages and other problems, that contributes to people being frustrated in the department, and there's a high level of frustration. So we are bringing some services, Services Australia provide our ICT, we're bringing some services back into the department, some effectively customer-facing services, to make sure that we improve that offering for our staff and reduce the friction.
Right. So how are you going to accelerate that, given these things often take time, require a lot of resources, there's a budget cycle, all of those sorts of things? How are you going to address the ICT component?
Pat Hetherington, Chief Operating Officer. Just to build on what the Secretary was describing, we've been through, we have a small investment budget annually for investment in ICT upgrades. That budget for the last couple of years has been devoted to sort of modernising some of our core ICT, so think upgrading to newer versions of Windows, shoring up things like our virtual private network that enable remote working. So we've been investing quite heavily in those to make sure that we have a stable, reliable system for our people to be able to operate off. We're getting close to the point where we can start to invest in some of the business-focused tools that will really help our people. And one of the things that we've been investing in quite heavily recently, obviously, is AI, and trying to work out what the best use cases for us are in the AI space, leveraging the good work that the Department of Finance has done in GovAI. We've seen quite a large increase in people taking up those centrally hosted AI opportunities for a bunch of really good reasons. One is to learn about AI and its possible application in our department, and how we think that can bring productivity to the work that we do, which is deeply related to how do we get focused on our priorities, and how do we give our people the tools to be able to be influential in the policy development space. So we've really encouraged and seen a big uptake of people taking advantage of those tools, building their capability. We've done some pretty novel things in parts of the organisation as well, like run small competitions about best use of AI to try and encourage some of that innovation piece. So along with that, we'll continue to invest in some of the higher end business applications as the opportunity arises to give our people the best tools we can.
So you've got the review in 2025. When was the last time that you updated your strategic workforce plan? And does it currently reflect that, or do you need to do more work based on the outcomes of that review?
Yeah, we absolutely need to do more work on our strategic workforce plan. We sort of set aside really getting stuck into the next iteration of what the future workforce looks like until the conclusion of our capability review. We wanted to see what the independent reviewers determined were the right areas of focus. A lot of, I mean, as the Secretary's described, a lot of what was in there wasn't an enormous surprise to us. We've already set about some really important things in terms of building that policy capability, but there are other areas in there that were illuminated as well. So I think now, having gone through the process of the capability review, having consulted with our workforce around what we think those priority areas are of work, we're in a really good place now to sit down and work through what does the strategic workforce plan look like, what are those capabilities that we think, some of the capabilities will remain enduring, but there are new capabilities that we need to bring into the organisation. So we think we're in the best place to really work out what the next 18 months, 5 years looks like from a strategic workforce planning perspective now. Some of that we've started with the grad work already. Yeah.
And most of your, 1/3 of your staff are EL1 and EL2. Can you tell me a little bit about, how you respond to some of the feedback that they gave to the review, which is about feeling they were spread too thin, they thought that impacted the quality of their work. How will you focus on that cohort, given they make up such a significant proportion of your workforce?
Yeah, the EL1, EL2, Band 1 part of our workforce are really a critical part of the workforce. Engine room, and they've also got a mix of tasks to do, but also leadership responsibilities. So we're working really hard to make sure that information is shared within the department and make sure that the context in which we're operating, that and the kind of feedback we get from, say, the Minister, for example, around policy proposals, that information is shared down through the organisation. I think that there is some concern that when you look at our census and the capability review, that hasn't happened to the degree which it might have. I think trying to help staff understand what the priorities are, and our Minister would say do fewer things well, and focus your efforts on the things on those things, and so that exercise of getting people aligned to a set of priorities is really important, and giving them permission then to sort of say, well, this other thing that you've been doing, you don't have to do that, because otherwise the staff would be feeling as though they've got to do everything and nothing well. So,
yeah.
Senator, there's no one thing that fixes that issue, and I think we've talked a bit to your line of questioning. They're interrelated. The responses that we've outlined are sort of getting after the problem that you've described. So the reason we want to invest in things like AI in particular, or automation or novel IT, is to help alleviate some of the pressures that our staff are feeling. We want to get them really sharply focused on the priorities. We want to give them the tools that are going to help to make those jobs easier for them to do. We've done a range of work. If you take the policy space as an example, we've done a range of work on giving policy specialists the toolkit that they need to be able to develop policy and really streamline the way that they approach that work. We're also investing in leadership and helping people to lead their teams well, along with a really, really, closely defined set of priorities that hopefully will keep folks on track with the right tools to do that. But work in progress.
Okay. Your staff are also accessing the Employee Assistance Program at a much higher rate than comparable institutions. Can I just ask, we've seen new referrals to the service triple between the first quarters of 2022 and 2025, an increase in accepted workers' compensation claims. Can you tell me why that's actually happening? Have you done any work to understand that?
At a sort of a high level, what I'd say is we advertise EAP really well in our organisation. We think that's a fundamental part of our work health and safety proposition, and encourages good mental health. Our people avail themselves of that opportunity. I know it's at a higher rate than others might. We also have some really difficult policy spaces that we work across as well. And we've got the redress scheme for institutional child sexual abuse. We've got some really difficult areas that deal with vulnerable people in our society, and so we want to make sure that our people are well supported. We do encourage people to take advantage of things like EAP. In the Comcare space, the growth, I think, broadly across government in approved Comcare claims has been in psychosocial space. I don't know that ours have grown at a rate that's any higher than anybody else's, but we do see that EAP is actually a really important tool for ensuring that people are well supported in the workplace.
Are you able to provide a breakdown from 2022 until for every year since then, in terms of the what the review referred to as a sharp increase?
I can take it on notice for you.
In that, if you can provide me with that.
I can take it on notice and come.
Thank you.
I mean, at the same time, the other observation is at the same time there's been a lot of change.
Mm-hmm.
We've had some big MOGs, as you know, big machinery of government changes, as you know, and in periods of change, I think you often see an increase in people availing themselves of those services. But we'll have a look, in looking at that period of time that you refer to, we'll have a look and see if there's any more granularity that we can provide you.
Yeah, I'm interested too in understanding with the numbers of people that are participating, whether there's been a change also in the actual level of compensation for those people.
Sure, yeah, we can do that.
Those years as well.
Yeah, I'll take a look. I'll take a look at the nature of claims and see what I can. It'll be at an aggregate level. I'd be loath to provide sort of too granular and individualised data just based on privacy concerns, but we can have a look at the nature of Comcare and how that's changed over time.
I'm interested in the aggregate figure.
Yeah, gotcha.
Can you tell me, everybody's sort of talking about AI. It's different, it's new, there are all sorts of unintended consequences. How are you preparing your staff for some of those, for their capability to not only get the inputs right, but actually do the analysis of the data that comes back?
I might ask our Chief Finance Officer and ICT Officer to respond to that.
Thank you. Pia Connolly, Chief Finance Officer, Senator. Chief Operating Officer mentioned that we have had a really significant uptick in our use of GovAI through GovTeams, the Department of Finance central platform. We've more than doubled our subscriptions to GovAI, so we are now sitting at over 1,900 of our 2,900 people having access to that tool. A key function of GovAI is that it is a learning and development tool, and so there are a range of levels of expertise that people can nominate. They can go in at entry level and then progress through as they build their maturity and their capability in the use of AI in a safe space, if you like, a quarantined sandpit. As well as that GovAI platform, we also have access to a range of training from the APSC and the DTA around fundamentals in AI, and we are encouraging and soon to make mandatory that training for those who are using AI in the department.
Okay, thank you. In recent years, DSS staffing has grown by over 40%. Can you tell me how are you going to plan for any efficiency dividend that might actually apply to your department?
Senator, I don't think that we're not planning for efficiency dividends per se. I think the challenge for DSS is that we've got to return to levels pre-COVID effectively. There was a growth in staff over the COVID period. Programs have ended or are ending. The redress scheme is scheduled to end in a few years' time. And so, putting aside any other movements in budget, we've got that task to do, and we're managing that carefully. So, for example, at the moment, we've still got reasonably good attrition rates, and we're being very careful about hirings. So, aside from our grad program.
It's interesting you mentioned the redress, because you've obviously, I'll talk to that a bit later, but you've got a significant backlog of processing that you need to do. So I'm just wondering if you've got, you're talking about staffing, surely you can't reduce that while you've got that kind of backlog sitting there at the moment.
No, but we're happy to talk in the outcome area about what we're doing in the redress space when we've got the officials. Yeah.
Okay, thank you. We can. I do have a couple of questions on the machinery of government changes. I'm assuming it's mostly the same people. Yeah, thank you. So the transfer of all funded functions under Outcome 4, housing, to the Treasury, and certain functions under Outcomes 3, disability and carers, to the Department of Health, Disability and Ageing, occurred close to the end of the reporting period, May-June 2025. Since the gaining entities are expected to report on these functions for the full period, what mechanisms did DSS put in place during the transition to ensure a seamless handover of performance data and full accountability for the July 2024, so that we see that there's no gaps in reporting?
I will hand over to the CFO in one moment to walk through some of the detail if you like, but in general terms, it's actually a very well-worn path. The Department of Finance lays out really comprehensive guidelines on how to conduct MOGs well, and effectively what you see for all of these MOGs is those agencies involved have that checklist, and we work our way methodically through the checklist of all the things that you need to do. And performance reporting and those things is one element of that, and I think the guidelines around who reports what when are reasonably clear, and so I think we did a pretty reasonable job on that with our colleagues at Health and at Treasury.
All right. Senator, we followed the guidelines that Finance provided, so I'm working very closely, weekly meetings chaired by COOs with CFOs, HR, IT, security in attendance to make sure, working through a standing agenda of key issues that usually come up when a large and relatively complex MOG is underway. Always with those objectives that Finance sets out for a seamless MOG with staff, ministers' offices, stakeholders not impacted. It does mean a fair bit of work, a lot of conversation, but those were held quite efficiently, and the MOG has been completed successfully. Our financial statements report for 24-25 on a pre-MOG basis. They will move to post-MOG for 25-26.
So there would have been, under that process, a final assessment that was done that took into account the metrics at the transfer.
So I'll ask Mr Navarro to clarify, but there are some final adjustments that will flow through in mid-year economic and fiscal outlook in terms of adjustments of appropriations. But it was done in a relatively timely fashion.
Yeah. So Cheryl and Navarro, Branch Manager, Budget Reform Branch. The impact of the machinery of government financials will be published in 25-26 annual report, and also in the PBS when we get through to the publication next year, and that will show the completion of the transfer of funding and the outcomes as well.
Okay. I just want to refer to the expenditure table that is on page 135 of the annual report. It relates to contracts and expenditure relating to the transfer of functions. It included 23 new consultancy contracts with expenditure of about 3.8 million and 10 ongoing consultancy contracts. Can you provide details of what those contracts were and their duration?
Senator, which table are you looking at?
This is on page 135 of the annual report. There's a reference there to contracts, consultancy contracts.
Yeah, there's a table at the top that outlines the number of contracts. I mean, I'd be happy to put some of that on notice if it's easier. It identifies 47 new contracts. So if it's easier, rather than do that now, we can take it on notice.
Yeah, that would be fine, because I've got the same thing here, just after a bit more detail. Thank you. I'm wanting to return a little bit to human resources and staffing profiles. Your annual report states that DSS operates with 3,564 employees at 30th of June 2025. However, the entity resource statement indicates the staffing resources for 24-25 is 3,340. Are you able to explain the differences in those two? There's a 224
maybe Senator,
person variance.
Because it could be ASL versus FTE.
Yeah.
Do you want to know what the actual is?
Yeah, if you could. I'm trying to understand what makes up that difference.
I'll give you some numbers and explain what they are. So current ASL budget is 2,905, and so then headcount against that is 2,869. That's sort of around the September timeframe, and that headcount, the difference between that is part-times, etc., etc. So we have more people. ASL obviously is the average. Going back across the last couple of years, 30 June 2025, that ASL number was 2,917. In June 24, that was 2,894. Our FTE, or our head count, is ordinarily higher than that number as we take into account people that are on part-time arrangements and other flexible working arrangements.
Right.
Yeah.
I'm interested in understanding, in the annual report, you reported a 7.1% of your staff are people who are living with a disability. What's the target that you had? Is that higher than your target?
I think the target outlined in the, I don't have that in front of me, but the target outlined in the Public Service Commission's disability strategy is 7%, is the target. So we're in line with the target. Yep.
So have you got any indication of what's going to happen, considering that under the machinery government changes, I'm assuming some of those staff have
Indeed,
moved?
Yeah, and so I think in aggregate terms we're still in line with the target. So a number of our folks working with disability were in the disability policy space, but it would be untrue to say that the rest of the organisation didn't have quite a number of people that work with disability, and so I think our target, we remain pretty close to that target, if not above. And I would say that the number that we reflect in the annual report is based on those that have identified in our HR system. Actually, when we look at the anonymous census data, the indication there is that the number of people who have disability is actually higher than that target.
Yeah, it's higher than the APS.
And so post-MOG, I don't think we've seen an enormous change in the percentage, in the proportion of people across any of the groups for which there's a workforce strategy.
Right. I wanted to ask about performance payment. Your annual report says there were no performance payment made to departmental employees during that reporting period. Does the department correlate this zero performance pay outcome with the failure to meet key cross-program output targets, such as the timeliness of ministerial advice, which was significantly missed, 78% met versus 95% target, or something, or is there something else there?
We typically don't do performance payments for SCS officers. So for APS staff under the enterprise agreement have the whole of government agreed pay rates as pay rises, and then they will move through bands, move through a public service level band. At the SCS level, we don't do performance payments, so
yep,
that would be why there's a...
Okay.
Yeah.
So there's an amount that is 2.1 million in separation and redundancy expenses that's reported, and that's up from the previous year. To what extent did the machinery of government changes contribute to that figure? Can you break down the voluntary redundancies, planned redundancies and separations?
Whereabouts are you?
That is actually on page 173.
173. Yeah, I mean, again, Senator, I'd be happy to take it on notice and give you as much detail as we possibly can on that. What I would say is that there weren't a lot of voluntary redundancies associated with the machinery government changes, from my recollection, but we'll confirm that. Come back to you on that.
And I don't think there was any that weren't voluntary.
Yeah.
Sorry,
Senator, I don't think we've used anything but voluntary redundancy.
Yeah, we have not done any involuntary redundancy work.
Right, okay. So there has been also a significant increase in total employee benefits in the last 12 months, in fact 472 million compared to around 390 the previous year. Can you tell me what that increase in total employee benefits comes down to?
Whereabouts are we?
That's I think that's page 173 as well, I think. Yeah, total employee benefits is just under the separation of redundancies.
I believe that that's a function of growth due to additional staff employed in the redress scheme. Right. And you'll see increases in all employee expenses.
Okay. So in terms of employees, outside of Canberra, there's 1,281 employees that are based around the country. Are you able to provide details on where they're based?
Yeah, I can do that.
Outlays?
I actually do put some of this up on the website, Senator, so that you can see. Or I'm happy,
Oh, if you want to provide the link, that's
I'm happy
fine if it's
to
there.
provide it on notice for you. We've got by state location.
Yep. And are you able to tell me why those services are carried out by DSS employees outside of Canberra, particularly given Services Australia is part of the Department of Finance?
Well, yeah, I mean, the reasons are many and varied, but very briefly, we have a presence right across the country, every major city and some of the smaller cities. We have a lot of touch points with service providers, in particular through the Community Grants Hub. We service 13 client agencies and do about $11 or $12 billion of payments a year to service providers across a range of services. Having a footprint that is in the same location as some of those services is enormously valuable to making sure that they work well. Equally, for us, a more flexible work approach and capacity to hire outside of Canberra has given us access to talent pools that we previously haven't had in Canberra.
Okay. I wanted to ask a question about, continue on with the annual report. The net cash operating loss of $6.8 million that's reported on page 133. Are you able to explain that loss to me?
Senator, that loss represents a small proportion of our departmental operations. In liaising with finance, we explained to them also that it's largely due to timing differences, matching revenue from government appropriations with our expenditure in delivering our programs.
Right.
I'll throw to Ms Navarro to see if she has any additional detail to add to that.
Yeah, so the majority was timing differences of our appropriation and when we incurred expenses. And we received an unexpected superannuation bill, which made up for the rest.
Okay. Your the personal benefits expenses, will they increased by 9.3 billion to 146.3 billion? Are you able to?
Are you talking about
page 133, personal benefits?
Yeah, I think you might be talking about outcome one, Senator. At 140 odd billion, I can only assume that's social security payment related.
Yep. Okay. Yes, that's right. That's over there. Just want a couple of quick questions on the annual report. When was the final annual report provided to the Minister's office?
Mr Whitecross may have that date. If not, we can take it on notice. I think we've got a requirement to provide the annual report by the 15th of October. So that it was provided within the stipulated timeframes.
Right.
That was provided on the 14th, and then obviously we tabled it on the 13th of. When did we table the annual report? 13th of November.
Yeah. So from that annual report, we learnt that 24 performance targets, of the 24 performance targets, 15 were met, 1 was partially met and 8 were not met. Can you give me a bit of an upshot of why it is that the systemic reasons may have contributed to essentially 1/3 of your targets not being met?
If it would be helpful, Senator, there's a lot of detail already in the annual report around the reasons for those targets that weren't met and the reasons for those targets that were met, as it happens, and the evidence that underpins that. If it's useful, we could come back to you with a bit more detail on notice rather than... Because there's quite a lot of information there.
Yep. So in terms of the... if I can turn to the APS employee census... that action plan focuses on 4 key areas: empowering mid-level executive leaders, communication and change management, enabling innovation and integrity. Beyond stating that activities were initiated, what specific measurable targets, and I understand you outlined some of them in response to the review, but this is in response to the actual census.
And so, Senator, I mean, it's fair to say we had the benefit of having the census data at around the same time as having the capability review. And so we've sort of linked those things together. So a lot of the work that we're doing in the census, in response to the census, is not dissimilar to the work that we're doing in response to the capability review and is outlined in the strategy for us moving forward. And I think we've touched on some of those things already.
I note that there was a consultant used, a public affairs, Ipsos Public Affairs, for the analysis of that census. Do you usually engage consultants to do the analysis of that?
Yeah, so I think for this census we engaged Orima to do some deeper analysis on it, and we actually get a lot out of that. It's not a particularly expensive piece of consultancy work, but there is some sophisticated data analysis that they do that really dives in for us on what we think the key drivers are for staff sentiment, and really helps us to understand what the pain points are and what the things are that we're doing well. And I think we found that incredibly valuable, certainly a value for money proposition for us as we go about the task of trying to address the concerns that our staff raise with us through the census.
So in terms of the information that was provided in that census, can you tell me, you engaged that contractor, were they only on a short-term contract to do that piece of work, so there's nothing else for them to do?
Fixed piece of work.
You've got what you need?
Yep, got what we needed. They do a report for us. They come in and present those findings to us. It gives us the capacity to dig into some of those, some of the groups where, through the data you can identify areas that are outliers. It gives us the capacity to really understand what's underneath some of the concerns.
Right. Now, I know we've talked about the review, we've talked about the census. Can you tell me, the areas of staff dissatisfaction or positive feedback, can you tell me how you're prioritising the work that you will do in those areas?
Well, I mean, just really quickly, the sort of higher scoring areas for us, again, weren't a surprise. We know our people work with us because they're highly engaged in the work that we do. That remains really rock solid for us. So people believe in the purposes and the objectives of our agency. They understand how their role contributes to the outcomes of the public service. Happy to go the extra mile. All of those sorts of things you see with high engagement remain strong for us, and we're very happy about those things. We don't want to lose any of that. The areas for us that we know we need to continue to focus on, we've talked a little bit about already. Obviously, technology came up and continues to come up for us as an area where people just, certainly they don't feel that we're providing them the tools that they need to do, and that technology piece underlies a number of the concerns that our staff raise with us. The Secretary's already touched on some of the work that we've done to reduce decision-making barriers and push decision-making down through the organisation, which goes hand in hand with an enhanced risk appetite and helping our people to understand how to take risks well. They're the sorts of areas where we've got the most improvement to make. So it's around that innovation, IT, empowering people to make decisions, and communicating and managing change well, which you see when you have machinery of government changes and other reforms in play.
Thank you.
And Senator Little, there's a census highlights action plan on that might be useful as well. If you want to see, because I think all agencies have to put an action plan together.
Okay. We publish an action plan that will go to those things that we think are the highest priority areas to go.
Okay.
Senator Little, I'm just inquiring about how much more time you might need.
Probably. Sorry?
Portfolio when we're asking.
Whole portfolio corporate matters we're still in?
Corporate. No, I've probably got another less than 10 minutes in corporate matters.
You still going? Yep.
Yep.
Another 10 or 15?
10.
10? Okay, great.
I can get it
no
down
problem.
to 10. I note the Minister is here, but I wanted to ask you a question about what you understand or what you have been advised will be the required savings that you have to find, the actual number you've been advised.
Well, they're not savings. I've repeated this in every committee I've attended all week and in the chamber last week. Agencies have been asked to identify the lowest priority 5% across their budgets as an exercise in fiscal discipline, so that we can look at when agencies are also seeking more money, that we're thinking about how we're using our existing expenditure.
So the department has already started that work?
I would say, Senator, that we routinely look at what our highest and lowest priorities are in the context of our budget. It's reasonably standard. There's been standing rules for bringing forward offsets in budget processes for a long time, so it's not new to us to look at what our lowest priorities are.
So how long will
Yes,
that work take you? Is that how long will that work take you to identify what your lowest priorities
Agencies
are?
were required to provide a response, and they have.
Right, so you've already provided it. Okay. That instruction that you were given, was that only around the lowest priority, so there was nothing in terms of actual staff numbers?
No.
In terms of reductions,
No.
it was just about the lowest priorities, programs and ideas for expenditure, right. Can I ask you a question about centre pay?
You shouldn't ask me a question about centre pay because I'll be unable to answer.
We're happy to
but
do
our-
it, Senator, in... we don't own responsibility for centre pay, but to the extent that it's connected to income management, we can do that in the outcome area, if you like.
Yeah, but I am interested in understanding the advice that you may have given to the changes to centre pay.
Well, if there's anything the team can respond to, it'll be an outcome one.
We dealt with this in Services Australia the other day because they're responsible for centre pay.
Okay. So there's been no role for DSS at all in that changes to centre pay?
Well, Senator, Service Australia will have talked to us about the changes that they're making in centre pay. We will have had an exchange on that, but it's their responsibility.
There was an extensive consultation process that
Yes, I was
wrapped
aware of
around
that.
the changes.
Yep. Right. So in terms of Services Australia, there's nothing for you to do to assist that work going forward at all from DSS?
We're not the right.
No.
In outcome one, we're happy to, if you have questions around income management, Senator, we can circle back.
Yeah, we can.
We're obviously interested in centre pay, but it's not our responsibility.
Yeah, okay. Okay. All right. That brings me to the end of the corporate section of that. Thank you.
You're done. Okay, great. Moving on to outcome one. So now call officers from the Department of Social Services in relation to outcome one, Social Security, and I will invite questions. I think, Senator Little, if you wanted to continue on, that'd be great.
To get myself organised too. Okay. Thank you. Thank you. These questions relate to the annual report and some of just understanding a bit more detail from some of the information that's provided in it. I acknowledge there is a short explanation as to why some of the targets were not met. Can you provide some further details of the two targets that were not met? Family tax benefit 1.1.1, 1.1.2, child support scheme.
Thanks, Senator. Jo Evans, Acting Deputy Secretary, Social Security. So I'll go to FTB first and then I might pass to Mr. Peoples. So we've seen an increasing number of families receiving FTB who are above the low income free area, and that is because they're earning income because of work or increasing income support payments, and so that results in that target not being met because they're earning additional income in addition to what they've been receiving in previous years, if you like.
Okay, so what's the effect on that number with the actual result actually not just not being met, it's actually going in the wrong direction?
It's not that low-income families are missing out. is it?
No, Senator, it's because they're earning other income in addition to their income support, which means their FTB, the percentage of families receiving that FTB payment might be correct.
Okay. The key target under Program 1.4, financial support for people with disability, that was not met either. Can you tell me why that is the case?
Mr Peoples?
Yeah, so Ben Peoples, Group Manager, Participation and Family Payments. So this performance measure looks at the proportion of people receiving disability support pension compared to the number of people with a profound or severe disability as reported by the Survey of Disability, Ageing and Carers, so the SDAC. The latest SDAC was released with 2022 data, and that saw a significant change in the methodology for the survey and an increase of around 50% in the number of people identifying with a disability. So up from 521,000 in 2018 to 776,800 in 2022. So that is a significant factor in that performance target not being met. Okay. We have seen an increase over the last couple of years in the number of people receiving DSP, reflecting kind of those broader population trends, and that trend is across the payment years too.
Okay, thank you for that. That's helpful. I'm also interested in understanding the, essentially it's a significant change in a very short period of time, and that is Program 1.4, which was at 98.6%, and now the actual result now sits at 72.6%.
Senator, that's the one that Mr Peoples was just talking about, and so that's because we've seen an increase in people identifying as having a disability, so you're getting an increase in the denominator, if you like, and so that flows through into your results.
Right, okay.
Yeah, so 23-24 was the first year that the 2022 SDAC was reported.
Okay. So what particular things, given that change, has the department put in place to respond to what is a significant change in a short period of time? Does it have any impact on you?
So, Senator, what I would say is, so in terms of total numbers of people receiving disability support pension, we're not seeing that level of change. That level of change is driven because you've got an increase in the number of people within the Australian population that are identifying as having disability.
Right. So we've got also the Program 1.5, financial support for carers, that indicates it has not been met. Can you give a description of why that has occurred?
So thanks, Senator. That's similar to the results for disability support pension in the carer payment measures use the Survey of Disability, Ageing and Carers. And similarly, with the 2022 results, we saw a significant increase in the number of people identifying as a primary carer, up from 861,000 in 2018 to 1.15 million in 2022.
Thank you. And then there's the working age payment. You know, there's been a change in that in terms of it only partially being met. Can you explain that?
So thanks, Senator. So this measure looks at the relationship between working age payment recipients and seasonally adjusted unemployment rate, and partially met is largely due to the fact that this is a demand-driven payment, and so there are times through the year where there has been really strong correlation between the unemployment rate, and at other times it is not has been as close, and so over the course of the year we determined that the target was only partially met.
And what was the cross-program outcome that was determined to not have been met? The cross-program rent assistance, I think.
Rent assistance was cross-program and that was met, Senator, so page
Oh,
45.
okay. Sorry, that's my error. Please ignore that. So in terms of the student payments, that's the one. Key activity 17.1 per student payment. What's the current percentage of payment recipients who are not receiving income support 12 months after exiting student payments? Because there are no stats on that measure on page 42 of the annual report. It just says movements aligned.
Senator, could you just repeat the question,
Yeah,
please?
so with key activity 1.7.1 per student payment, what's the current percentage of payment recipients who are not receiving income support 12 months after exiting student payments? Because there's not a stat on that measure on page 42 of the annual report. It just says movement aligned.
I think there's a table, Senator, on page 43, which is that, and I think the last year you get is 2023, and I gather that's because there's a lag. You've got to measure the 12 months later. So,
Okay.
yeah, is that right?
Correct, yeah.
Yeah, on page 43, the bottom of page 43 is that exact table.
Thank you.
Yeah.
Okay. That's it. I don't have it here. Thank you. Okay. I've got a couple of questions about the government's social security legislation, social security and other legislation amendment technical changes bill. Thank you. So the government's, that recent legislation, it was only very recent, increased the threshold for waiving small social security debts to a single unified amount of $250. Do you know, can you tell me why $250 was chosen as the number?
Yes, Senator. So previously, before that legislation, which actually received royal assent today, there was two thresholds in the system for what we call small debt waivers. There was a $50 for an individual and a $200 for a couple, and so the government has increased that to $250 and also indexed that through that legislative change.
Right. So, given that's slightly higher, is it? Have we now got some inconsistency in what that threshold actually is now, or?
So no,
Is there
the
a
threshold is now 250.
It's all the same.
Yep. So all debts below 250, it's open to services or will be waived.
Right. So does that have a retrospective effect on debts already raised?
No, Senator. I think we're talking about debts going forward.
It's all forward debts, not debts currently raised. The ones that are sitting there right now stated what they are. Okay.
So we can expect, so once the small debt waiver takes effect from 20th of March 2026, we expect 1 million potential debts will be waived.
Right.
And at the end of the financial year, we can expect 1.2 million debts to be waived.
Right. Thank you. The Minister has stated that it is uneconomical to recover small debts and that it has essentially costs $1,000 to pursue them. What's the actual cost of actually recovering a small debt?
So that $1,000 figure that the minister's referring to is the average cost that it costs Services Australia to recover a debt. And so putting in place the small debt waiver is actually quite an efficient way to deal with that debt backlog.
Right. So did that advice come from Treasury or from
the
Services
department?
Australia?
Yeah, well, from Services Australia, yes.
Okay. Thank you. So can you tell me, I know we talked about income apportionment commencing quite some time ago. Can you tell me, can you give me an exact date on that? Do you know an exact date on that?
Senator, we know that certainly the practice of income apportionment was occurring during the 1990s, but we don't have a precise date.
Right, okay. So do we know, I noticed you gave me that number, those numbers before, but do we know how many welfare recipients have actually been affected by that income apportionment?
Senator, we know that there were around 5.5 million debts affected by income apportionment held by around 3 million people.
Right. And how many of those have actually paid off that debt?
I'll just ask Ms. Du to provide those answers.
Thank you.
Sha Ju, Acting Branch Manager of International Payments and Compliance. 97% of potentially affected debts have been paid off.
Right, okay. And how many of the people will be eligible to apply for the redress under that scheme?
Senator, it's open to anyone to apply for a resolution payment under the scheme that the government will put in place from January 2026.
Yep. We know that 160,000 debts are outstanding. Do you know what the value of those debts actually is?
I might have to take that on notice, Senator.
Okay. I'm also interested in understanding if those who have an outstanding income apportionment debt will be eligible to apply under the redress resolution scheme.
Yes.
Mm-hmm. And once that scheme's underway, will those with outstanding Commonwealth debts for matters unrelated to income apportionment still receive a resolution payment? Or will any eligible payment be deducted to cover outstanding debt?
I think it will be, Services Australia would implement it so that an individual can receive their resolution payment, but if they've got another debt, then that might be offset. Yeah.
Okay. So that's a question for Services Australia, really? Yeah. Okay. So in terms of the media release, Minister, that was dated 27th of August, that said it recognised income apportionment only changed the amount of debt owed by an individual by a small amount, and up to a third of those affected actually ended up with a lower debt. For clarification, can you tell me 1/3 ended up with a lower debt due to miscalculations of income apportionment? And are they eligible for resolution payment?
People with a lower debt.
Yep.
Yes, Senator.
Yep.
So anyone affected is eligible for a resolution payment.
All right. So are you able to tell me what modelling was done to determine the payment of $600 for resolution payment?
Senator, we looked at the debt profile, if you like, of people affected by income apportionment, and then we determined that a significant proportion of those, I can't remember the precise percentage, would be covered by the $600.
A large percentage.
I can come back to you with...
Thank you. Has it been determined the legal basis for narrowing eligibility to the income apportionment resolution scheme? What the impact of that will be to those affected by that practice from the 20th of September 2003? Is there a legal basis for narrowing that eligibility to 20th September 2003?
There's a legal basis in that there were legislative changes made to the Social Security law in 2003. And from that time, we're very clear that, that there's income apportionment was not a legal practice. For the period prior to that, it is less clear.
We went through this in the debate in the Senate last week. So pre-2003, not as clear, post-2003, clear.
Yeah, I take your point about it being in the Parliament, but I'm asking the department. What measures were in the bill to address remediation for those who are criminally convicted in relation to debts invalidly calculated using income apportionment?
Senator, where someone has been criminally convicted, my understanding is that they wouldn't be criminally convicted because of income apportionment. It was a practice for determining a debt. They may be criminally convicted because of fraud or other illegal practices, and the CDPP will look at those matters in relation to those debts.
Right.
So this legislation doesn't explicitly go to those matters, and those matters will be looked at by the CDPP.
Okay. So what's the relationship between the resolution scheme and the scheme for compensation for detriment caused by defective administration?
Someone who's been affected by income apportionment can apply for a resolution payment under the resolution scheme, and so I guess that's a Commonwealth mechanism to provide recompense to those individuals impacted by income apportionment.
Can I ask about how people who will find it difficult to have sufficient documentation to demonstrate consideration under this scheme, what provisions have you made for those people who may have not kept their documentation?
Just before you answer Senator Little's question, I just have to flag I will need to move the call after this question, so I'm happy for the official to finish that if that's your final question in that block, and then I'll go to Senator Orman-Payne. So, sorry, Ms Evans.
Thank you. Senator Little, can you remind me of the question?
Yeah, I'm wanting to understand people who have not got sufficient documentation. How will you?
It'll be services. It will be individuals can approach Services Australia with their usual proof of identity arrangements. So they need to be clear as to who they are, and what payment they're on, and there won't be onerous burden, if you like, to provide detailed paperwork relating to employment going back to, 2003. Okay. So services will work with the individual once they identify who they are.
Thank you.
Thank you. Senator Orman-Payne.
Thanks very much, Chair. I just want to delve a little bit more into the line of questioning that Senator Little had around not meeting the target for people with a profound or severe disability. I note the response given that the way data was collected in 2022 or subsequent to 2022 meant that there was a big jump in the number of people identifying as being severely or profoundly disabled. I guess what I want to try and understand a bit more is, if that's the case, but you've still got a 90% target, is that because the view is still that we should have 90% of people with a severe or profound disability receiving the disability support pension? And if that's the case, what steps are actually being taken to massively increase that number? Because obviously it's dropped a long way behind, and particularly in circumstances where we're hearing that it's a lot harder for people to get the DSP, and in fact many of them are getting thrown onto JobSeeker.
Ben Peoples, Group Manager, Participation and Family Payments. So there's probably two parts to answer that question. Firstly, in the data that we see looking at disability support pension payment population over the last, say, 3-4 years, we are seeing an increase in the number of recipients. Similar, but not quite to kind of the level to, well, not near the significant jump that we saw in the SDAC results.
Well, 70, yes. I mean, it's gone from 68.5 in 2023-24 to 72.6. That's a small jump, still a long way off 90%.
And the other thing that I would say is we are looking at that measure at the moment to see if it is still fit for purpose, and if there are other measures that would be available to consider looking at the effectiveness of DSP.
So I guess just to ask, like, if somebody has a significant, what's the definition, a profound or a severe disability, is the suggestion that, now that we know that cohort is a lot bigger, is the view that people aren't reporting correctly? Is the view that there's a certain number of people that don't need a payment? If they're not getting a payment, they can't work. I'm not sure how they're surviving, certainly putting pressure on families. What sort of work then is... Can you expand on that a bit more? Help me.
The target would have been set, Senator, with the old SDAC, with the older data, and so we do need to look carefully at that methodological, what's changed that's produced the big jump. The DSP is demand driven, and there hasn't been a substantial policy change. So people in that larger, the larger denominator group could apply for DSP. So we need to do some work to understand that jump and understand who those people are. There's a whole lot of things. It could be that they're not claiming because they're not going to be eligible because they're working. There could be a lot of different reasons. We'd also need to look at the indicator to see whether it's contemporary. It would have been constructed off the basis of old data, and we would have said, based on a different denominator, 90% looks right. That's what we should be aiming for. So we've got to look at both sides of the equation, I think.
Can you help me out? When you say 90% looks right, is this also a fiscal decision? Like 90% might be too high in circumstances where we have such a large cohort and therefore the size of the bucket won't stretch?
No, well, it's demand driven. So, and there hasn't been a policy change too.
Yeah, okay.
I think the most recent policy changes on DSP have probably made it more accessible than less. So it is that other underlying data that's changed.
And we've seen a year-on-year increase in DSP recipient numbers over that period. So it's the denominator of the new SDAC that we're using that's led to that change rather than...
I totally understand that point. I guess the immediate question that comes to my mind, does that mean there's a cohort of people sitting out there actually who need DSP and for whatever reason don't, and we don't understand yet why they haven't yet? I think...
Yeah. So, but obviously it's also a means-tested payment. So, one of the hopeful things you might say is that there's a portion of people with a severe and profound disability who are actually working or have wealth and don't need DSP. And one of our policy interests obviously is kind of seeing people on DSP have an ability to kind of earn income and have some connection to the labour market if it's possible.
So in terms of the work that you said is happening to try and understand that more, is that going to take the form of a report that will be publicly available, or what does that look like? What's the time frame for it?
So that's work that we do as part of our regular reporting to update corporate plans. So we'll report on that as part of future corporate plans or annual reports.
Okay. So, and that will include some of the background for the decisions. Like obviously I might see an annual report next year that says, well, the target's 80 now because we looked into it, but will we get access or an understanding of what sits under that
Senator,
decision?
We'd be happy to come back to this committee and give you our policy thinking on that.
Okay.
Yeah.
All right. That'd be good. Thank you. Can I go to a question on notice that I asked in the previous estimates? The question was SQ 25 000721 was around youth allowance. And thank you very much for providing me with the breakdowns. That's been really helpful. I'm just interested to dig into that a little bit more. So we had asked about, there was a newspaper article that was suggesting that there were less young people who were studying accessing youth allowance, and part of the explanation that was given last time was there was a change in the methodology in 2005. So a comparison of 2005 to 2025 was not necessarily like for like, and I can see in the figures that you've given us and the tables why that would be the case. I'm interested in the trends though. So if I look at the document that you gave me in response to that question on notice, total youth allowance, if you exclude youth allowance other, there was 292,490,000 people who were on student and apprentice youth allowance. And then if you go to 2019, and if you again exclude youth allowance other, but add up all those other categories, there's 184,080 people in receipt of youth allowance. And then if I go to 2025 and again exclude those people on youth allowance other, that number drops to 154,370. So I think the trend is clearly that there are less people on youth allowance. I guess what I'm trying to understand is how does that square away with increases in population, increases in young people going to university and studying, and have you got any explanations for those trends, and are you doing any analysis around that?
So thanks, Senator, for the question. So I'd probably break it down into three categories of that population. So first, students in secondary education, secondly, in vocational education, and then lastly, in university study. So there's been a significant decrease in the number of youth allowance student schooling recipients, which reflects changes that have been made in, I think, 2014, which made family tax benefit the primary payment for students at home in secondary school. So that saw a reduction from 2011 of 145,880 youth allowance student schooling recipients to now being only 9,280 recipients in secondary education. Similarly, we've seen a reduction in VET student numbers, which peaked in 2009 at around 43,000 before steadily declining, with a significant decline which we attribute to changes to VET student loan schemes from 2015 to 2018 as well. And
no, you finish.
And then so comparatively, we've had more stable numbers of youth allowance recipients in higher education. excluding kind of the COVID period. There have been some increases and decreases, but not of the substantial nature we've seen in those two kind of sub-cohorts.
I mean, I can accept that those things that you've mentioned have changed the number between 2005 and 2019, but even if we look at 2019 to 2025, you know, there's a drop of 30,000 there. And again, in circumstances where I would have thought that there would be more people studying increases in population, how do you account for that decrease?
Yeah, so I think we also looked at how youth allowance student numbers align with labour market changes, and so trends in how people are taking education. So stronger labour markets, we do see a decline in the number of youth allowance student recipients, which reflects some of that. There also is an increasing number of students undertaking a part-time study load, which will impact the number of youth allowance student recipients too.
I mean, one of the other trends that's evident, and again, if you exclude 2005 and you just go from 2019 to 2025, the percentage of people that had earnings in 2019 was 40%, but that jumps to 49.4% in 2025. And I guess, to me, this begs the question, and I think it's interesting that you said when there's changes in the labour market, is it becoming too expensive for people to study and youth allowance is not keeping up, so that we don't actually have a situation where it's feasible for people to meet their cost of living expenses and study? And maybe that's... I'm interested in the department's view on that from a contextual perspective.
Like, I wouldn't say that we see any evidence that it's the rate of payment that is having an impact on any population change. It's more that we see a general trend, and I think there's probably some more analysis for us to do, but that where there are changes in labour market, there is a shift in the population.
Is there work currently going on to analyse this trend and to actually find out why this is happening? We
look closely at these trends on a consistent basis. So yes, there is kind of work underway on this.
It's one thing to look at the trend, but in terms of any research looking at the underlying factors, because it's one thing to assume, right, that it's happening just because the labour market's changing. It could be that it's not enough for people to study, and I guess the question is there research being done to actually find that out?
We haven't commissioned any research into that.
Okay.
But we do look, as part of our job, we look at those things. So, I mean, it might not involve commissioned research, but it would certainly involve conversations with the Department of Education, the higher education area, the vocational area, and then our own looking at it. And we're looking at the expenditure patterns, estimates variations up and down. So, as Mr. People said, it's a kind of part of our ordinary business that we do that.
When you say expenditure patterns of who?
Well, we look at very closely at, because all these payments are demand driven, we look at variations in the estimates. So if more people claim a payment than we might have expected, the estimate goes up. If fewer people claim, it goes down, and we need to understand and advise government around why that's happening.
But that doesn't tell you, does it, though, for example, if person A thinks about studying, starts, has to then work 30 hours a week, realises that that's actually not feasible to maintain a study load, do well and work to keep a roof over the head, like, that doesn't tell you that data, does it?
Well, I mean, you need, as you're saying, we need to kind of look at why the numbers are changing, and then and work out what's going on. I mean, I think I would say to you, your thesis is one possibility. I think the strong labour market might be drawing young people out of study and into the labour market full time, and we would even be concerned about that, because if the economic cycle changes, we know that further education is a protective factor for someone across their life course, across their working life. So that's of concern to us, because we do, all things being equal, want to see people get those skills so that they have that protection over their working life. So,
well, I guess that's the point I'm trying to make, and
Yes.
maybe this is a question for the Minister. Given that there's a very clear trend in the data, and I guess at the same time that we're hearing about massive skill shortages in a range of areas, is the government of a mind to get that research to find out if in fact the rate of youth allowance is the barrier to people being able to maintain work and study?
Well, I think the government takes advice on adequacy of payments and considers those in every budget process. We've said that since coming to government, and where we can, and we have adjusted income support payments where we find the room to do so, we do.
I mean, when you say take advice,
yep.
I mean, obviously the government has an agenda. Is the government of a mind to act? Like I've also just heard from the department that, you know, this government drives some of the decision making around what kind of research needs to be done to inform an agenda. So I guess the question is this the kind of research that the government is interested in the department pursuing to understand what the cause of this decline is?
I think, oh, sorry.
No, you go, and I'll jump in at the end.
I think the Minister's referring to the Economic Inclusion Advisory Committee.
Yes.
And so in every budget cycle,
yes,
that committee has when we're doing a program of focused research and general policy advice through that committee, and that comes to the government. And that's led to the increases in workforce age payments. It's led to the substantial increases in rent assistance. But it also involves, you know, interrogating some of these issues. There's not as Mr. Peoples is saying, it's not a specific research project that's been commissioned on this issue, but I think it's fair to say we are looking at what's going on with all of our payments on a regular basis and asking ourselves the question, you know, what's the reason for that, and then we're advising government accordingly.
Well, I certainly think the Economic Inclusion Advisory Committee has made and has given a number of reports now that have said actually that the rate of payments is too low. But anyway, I look forward to hearing into next year where the thinking is at on this, because I think there is a very clear trend, and it'll be interesting to see what work's being done to understand and address that. Can I go to...
Just checking how much time.
Do you want to rotate the call?
I'm just checking whether you... if you're going to start another block, then yes, I possibly will.
Yeah, you rotate me and then I'll start another block.
Senator Little, you have the call.
Thank you. Thank you. Thank you. I just return to some of the questions around the bill. Thank you. So I'm interested in understanding about the legislative instrument and what the timetable is for the department of for that, and who you've actually consulted in relation to the legislative instrument.
Sure, Senator. So we're working with government now to have the instrument finalised so that the resolution scheme can commence in January. And in terms of consultation, we've been working with key stakeholders, including EJA and ACOS, in relation to the scheme.
Just asking a couple of questions about changes to special circumstances debt waiver. Can you tell me how many Australians have applied for special circumstances waivers in the past 12 months?
Senator, I don't have data on me in terms of the past 12 months, but I can talk about the legislative change, the legislative changes to the special circumstances.
Oh, that'd be great, because that was the next question anyway.
Great.
Thank you.
The legislation that received royal assent today basically allows Centrelink to provide debt relief or waive a debt where someone knowingly makes a false statement or fails to comply with the social security law. So before this legislative change, there was no flexibility for decision makers to take into account where someone might have been experiencing coercion to make a misleading statement, and so even though because they knowingly did it, they accrued a debt. So this legislation really allows Centrelink to take into account where someone might be experiencing family and domestic violence and coercion, and that results in a Centrelink debt.
Those special circumstances you mentioned, and I understand family and domestic violence, coercive control is part of that. Can you tell me what other special circumstances might be considered, and what provisions that will be put in place to ensure that it will not weaken incentives for compliance with the requirements?
In addition to family and domestic violence and coercive control, there are other factors like someone's mental capacity. It might be the impact of natural disasters and, the loss of someone's home as a result of that. It might be serious addiction. It might be homelessness. So they're the types of things that Centrelink takes into account when thinking about special circumstances waivers.
Is it the department's view that you can only do that once, or can you go for special circumstances multiple times?
So it might be that someone, it could be multiple times. Someone might experience family and domestic violence, and then they might be in the unfortunate position that they're then homeless. And so, Services Australia would take into account the specific circumstances of the individual in relation to their social security arrangements and debts.
So they will be eligible for that, to do that multiple times if those circumstances exist. Yep. Right. So Mr. Plibersek, in her second reading speech, stated that existing safeguards will be strengthened to prevent manipulation of the waiver system. Can you outline, have you already identified what you need to do to strengthen those safeguards?
Sure.
And are you doing that across other
Senator, so what we're working with Services Australia so that they'll be monitoring the special circumstances debt waiver arrangements and the take-up, and so and then there'll be regular monthly reporting to the department on those arrangements, so that we'll be able to advise government through, the implementation period.
Thank you. That's it on that. But I do want to turn now to PARP. Thank you. That one. Payment Accuracy Program.
Sure. Payment accuracy.
Can you give me an indication of any of the change in performance accuracy data from last year to this year? Annual report.
Senator, I'm not sure, have I got... I can provide... so overall payment accuracy, so the figures I've got, so I've got from 22-23 was 94.03% to 95.01% in 24-25.
Thank you. There are some cohorts which are showing significant inaccuracy risks. Parenting payment partnered was estimated to have a 22.68 inaccuracy risk, and AB study had a 27% risk. What are the primary types of errors that are causing these to occur?
Senator, the primary payment accuracy issues and areas where we're working with Services Australia are typically around the reporting of income. So Services is doing work to nudge people, if you like, to remind them that they need to report income, that they need to report gross income as opposed to net income. And so certain cohorts and certain payments, particularly where people are more likely to earn income, so your payments as opposed to, say, your age pension, we tend to see greater levels of inaccuracy. And so Services Australia, we're working with them around that reporting of income issue.
So how do you fix something like that?
So, Services are, as I said, nudging people. They're using their app. They're reminding people you need to continue to report your income. They're explaining the difference between gross versus net. And when people engage with Services as part of their usual engagement, they might check in with people and just at the end of a call remind people about the reporting of income. So they're building that into their operational arrangements.
So if they're accidentally reporting net, there's an underpayment then, isn't there?
So they'll be overpaid their income support because they're saying they've got less income than what they actually.
Okay.
Yep.
All right. Do we know what the total monetary value is of overpayments as well as underpayments?
Across all...
across those two, parity payment and ab study, they're the ones I'm focusing on.
So ab study in particular?
Yep, ab study and the parenting payment.
So ab study, we've seen an upwards variation of 350,000, and parenting payment partnered, we've seen an upwards variation of 2.15 million. And we've got downwards variations as well. So for parenting payment partnered, I've got a downwards variation of 199 million. And for ab study, a downwards variation of 30.46 million.
And that's from a sample size of?
It is...
Katrina Chatham, Acting Group Manager, System Strategy and Seniors. So of AB study, there was 877 reviews completed, and parenting payment part to 984.
Okay. And what's the specific timeline and the target accuracy rate the government aims to achieve for the high-risk payments that I've just mentioned, parenting payment partnered and ab study? And when are you likely to see if there's any change in or improvement in those?
So, Senator, the Payment Accuracy Review Program, it's a trimester program, so we do reviews 3 times a year. And so then we're monitoring and, I guess, working with where we see particular payment inaccuracy for, for the 2 that you mentioned. We work with Services Australia and they might suggest particular adjustments to their programs that result in improved accuracy across the payments.
Right. I'm wanting to ask about the cancellation of payments on national security grounds.
The prohibition order, Senator.
Sorry?
The prohibition order.
Yep. Thank you. So, since 2022, have any welfare recipients had their payments cancelled or suspended on national security grounds or related to another country?
None.
None? Zero. Okay. And have any approaches or applications been made to DSS by other agencies to cancel or suspend payments?
I believe that's zero as well,
zero
but we can come back and correct if there's any different information.
Any change. Okay, thank you. I've just got, this is the last block of questions for me. They're around child support. Thank you. And if you refer to the annual report, page 30. So on page 30, there's a reference there to the number of children whose parent had applied for a child support assessment being reduced by 1.63%. Is there an explanation as to why there is a reduction of payments applying for child support assessments?
So, Senator, this is an area that we're looking at to understand how parents are engaging with the child support scheme and how those interactions with family tax benefit payments are working out. There's obviously a range of complex circumstances when parents are going through separation, and we've seen in some of our work that this is affecting their engagement with child support scheme, with family tax benefit, with government services. There's different levels of understanding, different levels of engagement, particularly for parents in the early stages of separation, and that's an area that we're looking at as well.
So what about some macro factors that you might have identified that might be impacting that? I mean, there is the issue of that's a difficult time for people, but are there any other things that you think are driving that?
I wouldn't say there's any... We haven't seen any kind of strong evidence of societal factors that are making changes to that, except in some of the work we do recognise that there are complex circumstances in those early stages of separation, and that people are connected financially through that separation, and so that's an area where we are looking at how that has an impact on the child support scheme.
Thank you. In relation to the maintenance action test, can you, for those who are granted an exemption, that number increased by 2.8%. Do you have an idea about why that's actually occurred?
So, Senator, what I can give you is a breakdown of the reasons that people are seeking a maintenance action test exemption, if that's helpful.
Okay.
Yeah, so the largest reason that people are seeking an exemption is in relation to experiencing family domestic violence or fear of violence, and then other reasons include because of a payer being overseas, or issues with kind of knowing who parents are as well.
Okay, right. I'm just going to wrap these few things in. I understand that you're actually in the finalisation stages of a review of the interactions between child support and FBT in response to this Joint Select Committee on Australia's Family Law System. Can you tell me things like the terms of reference, who's doing the review, the consultation, what you understand about the consultation, and when you're expecting to complete that.
So, Senator, there's a range of pieces of research that the department has commissioned in response to the recommendations of the Family Law Inquiry, and I can run you through some of that work if that would be helpful. I guess a significant piece of work has been undertaken by the Australian National University with the Social Policy Research Centre, looking at cost of children research. We've also worked with the Social Research Centre to undertake a survey of separated parents. And those findings are from that research is now informing reviews that are underway between the department and a range of other agencies, including Services Australia and Office for Women.
Okay, thank you. Is there somewhere on the website that I can find out that detail?
Yeah, there is information on our response to the Family Law Inquiry on the website, and happy to provide further information on those if that's helpful.
In terms of general child support, what is the current estimated value of unpaid child support nationally? And has that number, how's that number changed? Sorry?
Too much.
Yeah, well, it's
Yeah.
always too much, isn't it?
Yeah.
Sadly.
It's terrible.
So, Senator, as of June 2025, the child support debt pool was $1.92 billion.
1.92 billion. Right. And have you got that, is there somewhere I can go just to have a look? That'll tell me quickly the change in that?
I can provide that now, or I can provide it
If you can do it from 2022, that'd be great.
2022-23 was 1.74 billion, 2023-24 was 1.83 billion, and as I said, for 2024-25,
1.92.
1.92.
Thank you, that's terrific. What about data about repeat non-compliers? Do you maintain that? What have we seen? Have we seen more and more repeat offenders?
So I think one interesting data set to look at with the debt figures is around kind of the amount of debt that is now under arrangement, which is a really strong reflection that a parent has entered an arrangement with Services Australia to pay the child support. It may not be reflected in the total debt at this point, but in those same years, 2022-23, active cases with debt under arrangement was 50.9%. In 23-24, we saw an increase to 55.9%. And in 24-25, that's increased further to 57.6%.
Right. So given this has been increasing, is there any new work that's planned to actually put in new interventions that might actually stop that trend from continuing to climb? Is there any new work being sort of done?
Well, so that trend is a positive trend in that there's more cases under arrangement and reflects.
Oh, no, I meant, sorry,
I
jumped.
Yeah.
I should have gone back to the original in terms of the amount of debt outstanding.
Yeah, there's a range of work, including those responses to the Family Law Inquiry, which will consider issues like compliance, collection, and income estimations as well.
Right. The Social Services Legislation Amendment Child Support Measures Bill included an employer withholding measure, and the government expected that would recover up to $164 million in debt from some 18,250 parents. In the time that legislation has passed, how much of that debt has been recovered?
I don't have information on the financial impact of that measure. What I can say is that it has been applied to 9,955 cases with a child support debt, and around 1,000 further cases with an overpayment as well. So, but we can look to see if we can provide on notice the financial impact.
Yeah, because I'm interested in how successful that particular initiative actually has been. And given this enduring cost of living crisis, has the department undertaken any work on how child support avoidance impacts that financial security, housing stability and wellbeing of single parent families?
Yeah, so that's obviously something that we look at as part of kind of the ongoing monitoring and evaluation of the program. Some of the Commission research that we've worked on as well goes to those issues, looking at both kind of cost of raising children as well as the impacts of child support and other payments on parents. I would also say that we've established in the last 2 years a child support stakeholder consultation group, and the views that members of that group are providing go very much to kind of both the technical interactions that parents have with the scheme, but also their broader experience with the scheme and how it impacts broader circumstances of parents and children.
Do we have any understanding, or do you collect any data that tells us, given the increase in the actual debt, and families obviously doing it harder when people are not paying that, do you collect any data that tells us how many families are actually seeking some form of emergency relief or crisis assistance because they can't get child support payments?
No, I don't think we have any kind of direct data that goes to that, but we can have a look to see if there's anything in the research and provide that on notice.
Or if anybody, or if you're aware of anybody else who might do that when they provide that assistance, that would be good to understand.
I think I said earlier, Senator, we're having a really close look at weaponisation and the intersection between family, domestic and sexual violence and the scheme. So we'll have a look and see if there's anything we can give you.
Okay, that would be terrific. Thank you. Thank you for
Thank you,
answering my
Senator
questions.
Little. Senator Allman-Payne.
I have questions about the partner income test. I'm interested, I guess, in understanding how it applies to welfare payments. Can I just clarify, the partner test applies to all income support payments and welfare payments, doesn't it?
Yes, Senator.
Okay. If I'm a university student and I move from a regional town to, say, Canberra, and I meet 3 friends, and because rents are dear and we move in together into a share house, am I subject to a partner income test?
No, Senator. So the partner income, so there's, within social security law, there's what we term member of a couple. Mm-hmm. And so the partner income tests apply where someone is deemed to be a member of a couple, as opposed to in the share house accommodation example that you're talking
so if I
about.
have one friend and we find an apartment with 2 bedrooms and we want to share the rent, we can move into that?
Yes, Senator, but you may still just be friends. So there's specific criteria for someone to be deemed member of a couple. Miss Chatham, do we have member of a couple? It takes in
evacuation moment, Senator.
Yeah, so Katrina Chatham, Acting Group Manager, System Strategy and Seniors. So it takes into account a range of factors of the relationship. So it's the financial aspects of the relationship, the nature of the household, the personal and social aspects of the relationship, and the nature of the commitment.
Okay, because I guess what I'm trying hard to understand is if I'm Sue and I meet my friend Lily at uni and we say it's really expensive to live, we want to get through uni, we want to keep a roof over our heads, we need to afford rent, let's get an apartment to share, all good. But if I'm Sue and I meet Peter and we decide we want to share an apartment and then we actually get together, all of a sudden my income, if I'm Sue, and Peter's get put together. And I guess what I'm trying to understand is, why are we creating one situation for couples but it's completely okay if we're just friends? And maybe this is a question for the government, particularly in a modern society where we take the view that partners can look after their own financial affairs and have their own sense of personal security? Why are we treating Sue and Lily differently than Sue and Peter?
Well, I think it's been a long-standing feature of the social security system, Senator Allman-Payne, and I'm not aware of any plans to change that.
If the two people are both students or both, unemployed, and they move into an apartment because they're both on social security, the second situation where they're a couple, I mean, you're looking at the income, and so if they both don't have income, then they're both going to be eligible for support. But if one of them's obviously working full time, then obviously that's where the test makes a difference.
I guess the question...
Is that the like for like?
Well, I guess the question is we're then making one person dependent on the other, and I'm interested to know whether the department has done any work. I mean, we hear from family and domestic violence advocates that the partner income test tethers people to partners. It makes them dependent on partners. I accept that there is potential, if you've got a vulnerability, but I would also suggest that if you are someone in a domestic violence relationship, even the process of having to try to access that puts you at risk. So has any work analysis been done on how the partner income test actually impacts people's situations when they're made reliant on a partner? We hear it in the disability space as well. People with a disability are dependent on another. Wouldn't it be better to give people independent financial security? And that's a question for you, Minister, I think, because it's really a policy question, not a question for the department.
I've answered that with my earlier answer.
Okay. Can you tell me what the average reduction in payments for payments impacted by the partner income test is?
So, Senator, we don't have the data on the reductions or why people would lose eligibility or have their payment reduced because of the partner income test, because there's a range of circumstances that could have resulted in that, and so we just don't collect the data on whether it was the partner's income or other.
Okay, so what data do you collect in relation to the partner income test?
I think we'd have to take on notice and see what data we did have on partner income test.
All right, what's the minimum income? So if I'm on income support and I have a partner, at what point of their income does it start to impact my payment? So what's the lowest amount of income they can be earning that impacts my payment?
Senator, it would depend on a range of factors, including like which particular payment you're on and whether you're, there's independent, there's payments where you're living at home. So we just need to, it would vary depending on the circumstances of the income support.
Is there a matrix that sets out how the interplay between those?
So the detailed response is in the Guide to Social Security.
Mm-hmm.
We could provide you with some cameos if that'd be helpful.
That would be helpful.
We could set out, for particular payments, so for youth allowance and then say job seeker and when the partnered rate and where someone's earning income, where that starts to take effect.
Okay, thank you. Just in relation, this is maybe a question for the Minister. There was a 2021 Senate inquiry which considered the issue. The government at the time never responded to the inquiry's recommendations. And then when there was a response tabled in 2024, it said a substantive government response is no longer appropriate. Minister, is that because there was a change of government and so that just lapsed, or...?
I would have to take that on notice. I mean, there was, I am aware of reports under the former government where, the the incoming government said that we wouldn't be responding, but I'm not aware of that specific one, Senator Allman-Payne, but I'm happy to take that on notice.
Because I guess what I'm curious about is if it was 2021 and Labor was in opposition, then that would have been potentially a Labor majority committee.
Yes, I can't recall, Senator.
Okay.
I think, yeah,
Okay.
I think Community Affairs has always had, I'm not sure it's had a majority, but anyway,
Yep, okay.
I'd have to have a...
During COVID, a number of Labor members negotiated with the Coalition to introduce an extended income partner test, as I understand it, in response to COVID. And even if that wasn't the case, actually I'm going to withdraw that because I'm not sure, but certainly during COVID the partner income test was doubled to around 80,000, is that right?
Well, I mean, officials might be able to help there, but certainly a number of payments were increased
Yes,
during
was the
COVID.
partner income test doubled?
I'm not sure, Senator.
It goes back a few years.
Okay. Well, what I do know is that in 2021, members of Labor indicated that they were concerned about that ending. Andrew Giles said that he thought stopping that was concerning. And his quote was, "When we see what has happened in all of our electorates, we see the difference that the addition of the supplement has made to people and families. It's quite extraordinary that the impact, particularly on children who've been supported, which is enormous, has not been properly attended to by this government. It's one more shameful indictment in a series of shameful indictments on the part of this government." Why has Labor's position changed so much from when they were in opposition in terms of accepting the advice of the Economic Inclusion Advisory Committee and others to increase welfare payments?
Well, it's hard for me to go back and see the quote that you've read from what would be between 4 and 5 years ago. I can certainly sit here as the Minister for Finance and say that since coming to government, we have been looking at ways, not only through income support payments, but other ways to ensure we are helping assist people who rely on payments, whether that be in single parenting payment, Commonwealth rent assistance, the increase to job seeker, but all of the other measures that we're putting in place too. But there are finite resources available. The budget is in deficit to the order of, around $30 billion a year. So there are constraints on what, government can do, and there's pressures that continue to come at us. So our job is to essentially try to balance up all of the competing priorities and take decisions based on those. And we try to do that, and the PM has made it clear that we look at income support payments as part of that every budget round, and we'll continue to do that. Minister,
In the last 12 months, 1 in 3 big corporations paid no tax. Why is the government not going after them and instead forcing people on the lowest incomes in the country to still live on a poverty payment? Because if it's about choices, surely choices can be made to take the money from the people who have the capacity to pay.
And I don't accept the proposition you put. I think we have been, when we look at our multinational tax reform, when we look at the tax reform we've done to PRRT, when we're looking at the changes we want to make to high balance super accounts, I think you can see a genuine, decisions of government that are seeking to ensure that we are collecting revenue where we can and making the investments that we need to into either income support payments or other areas, whether it be the housing agenda, whether it be Medicare. Many of those programs are targeted to people who live on income support. So it's not just about, and I've had this discussion, I think, with, people in your position over the years. I don't think you can just see income support in isolation of other investments the government's taking. But we look at it every year where we can respond in a way that's responsible and sustainable for the budget, we do.
What about the Economic Inclusion Advisory Committee research that showed, though, that for every dollar that you increase income support, you actually get a return of around $1.20 because you're not having to fund people with extra unnecessary hospital admissions because they can actually afford the medications they need. People can stay housed, people can get the things that they need to live and stay healthy. People can actually get into work because they have the means to get themselves in a position to be employable. Does the government not accept the research from the Economic Inclusion Advisory Committee?
Well, we certainly take note of it, and I think you can go back and look through their reports and see where we've been able to act on it. But, the example you used there, so people can pay for their medicines, look at what we've done with cheaper medicines. And I mean, you can't just say, you can't just look at one side of what the government's been investing in, even though we have done what we can on payments and we'll continue to look at it. Look at what we've done on cheaper medicines. Look at what we've done on Medicare. Look at what we've done in housing and our attempts in housing. Look at what we've done on free TAFE. Look at the money we're putting into women's programs, particularly to try and target and end violence against women. I mean, all of this, has to be seen together. And we'll continue to work with the Economic Inclusion Advisory Committee and look at their reports as they provide them.
I still think it's an indictment that in a wealthy country we have over 2 million people living in poverty, but I'll leave that line of questioning there. Last estimates I asked, I'm going to move to compulsory income management. I did start asking questions about this to Services Australia and they told me I should ask them to you, so here we are. Hi. So last estimates I asked questions around the report or the consultations into the future of income management. I note that a lot of the feedback from those consultations was that the majority of people don't want to be compulsorily income managed. I note also that it was government's position, certainly coming into the 2022 election, that people shouldn't have to be compulsorily income managed. So in light of those things, I'm interested to understand what steps have been taken either by the Minister or the Department to work towards ending compulsory income management, and what the time frame is, I guess, because we've certainly got advocates contacting us and saying this has been some time now since that consultation happened. Where are we at and when is something going to happen?
Thank you, Senator. Corrie McKenzie, Deputy Secretary for Delivery and Data. I've lost my thing, apologies. So we're continuing work to really consider the detail of the consultations and to continue to provide a series of advice to government about the implications of the consultation and the sort of policy detail around that. So that work is underway. As you can appreciate, the consultations were very extensive. There's a lot of detail, and we engaged with a lot of people, which was incredibly valuable and important. And there is some quite significant nuance in the detail of that and in understanding that. So that's an ongoing active process.
Okay. Is there work being done around developing plans and supports for people to go off from compulsory to voluntary?
So we're continuing to provide. Advice to government in relation to the different options around that. In the interim, obviously, in the interim, people can continue to volunteer. So those people who aren't captured in the compulsory measures, people can continue to volunteer. So voluntary income management is already a feature of our system, but as you say, it doesn't relate to those compulsory measures.
And whilst it's a feature, I did ask for a question on notice last estimates to get the breakdown, and it is clear that the overwhelming majority of people on income management are on compulsory income management. It's also clear from the data that you provided me that overwhelmingly the people who are still being subject to compulsory income management are First Nations people. So do we have an indicative timeline for when the department expects that it will be able to provide advice to government to end compulsory income management?
Senator Witt, that work is ongoing, as Ms Mackenzie said, and so that's a matter.
Do you
for
have a goal for
decision-making.
when you want to finish that work?
We're working very, very hard on this issue.
Would you expect that the work and the advice to government would be completed by mid-next year?
It's a matter for government, Senator.
No, I'm not asking about the decision. I'm asking about the work that's required to provide the advice to government. When would you expect that you'd be in a position to conclude the work to give them the advice?
Senator, it doesn't. All I'll say is that our advice to government is an ongoing thing, and we go through gates with government. We get feedback. We do more work. So that's an iterative process. So and when there's an outcome, will be a matter for government to determine.
Have you been tasked with doing work to end compulsory income management, or are you still in the process of working on advice for the government to make a decision as to whether or not that will happen?
Senator, we're actively working on this issue.
All right, I might have to go to the Minister to ask that question. Minister.
On notice, I'm not the Minister responsible.
Okay.
I'm happy to try and find out if I can provide any more information.
All right. 3 years ago, as part of Labor's election promises, then Minister Linda Burney indicated that Labor was committed to making all income management voluntary. And I quote, she said, "Our fundamental principle on the basics card and the cashless debit card, it should be on a voluntary basis. And if people want to be on those sorts of income management, which suggests all of income management, then that's their decision. It's not up to Labor or anyone else to tell them what to do. At the moment, it's compulsion, and that's not Labor's position." I guess my question is, how long will it take for the government to act on this? That was an election promise 3 years ago. Minister, does the government have a plan to end compulsory income management in this term of Parliament?
Well, as you've had and as you've heard the evidence, this is something that the department and the minister are working on, actively working on. And if there is anything further I can tell you, I will come back.
Is it still the Labor government's position that compulsory income management should end?
We haven't changed our position.
Okay. All right. Thank you. I'll leave it there. That's all for me. I'm done.
Great. That concludes all the questions for outcome 1. We will now proceed to the dinner break at 6:20, and we will return at 7:20 to go straight into outcome 2. Thanks.